Good morning. Good morning. Good morning. Good morning. Hello, how you doing? Oh, okay. Greg, are you there? All right. No more anonymous. Hello, Greg, can we do a sound check?
Good morning, everyone. Hello. Let's get things started on time, so that way we stick to our time for the schedule. So as people are coming in, welcome again. Thank you for being here. We have a fantastic program today. As you know, the focus today is for ischemic stroke. Now, I'm sure you guys know May is the stroke month, and you know that stroke is #1 cause of disability. So thanks for being here. We take care of a lot of patients, help with their preventing their disability, so and treat their stroke so they don't have disability. So I hope the talks today helps highlight some of those treatment that we offer. The speakers are, all the talks have been scheduled. The only difference is the reception. It says at 4, but the reception is at 6. That means party starts at 6. So stay throughout the day if you can, and don't forget the party is at 6 o'clock across the street on the beach, so even better. With that, I would like to ask Dr. Savageau come, and looking forward to hear the talks. Thank you.
So today, for the first time at the Innovations Conference, a little bit later today, Demetrius and Vitor are going to show you some incredible human imaging using intravascular high-resolution imaging. And so when I got this topic, how you develop a tool, I thought it'd be really appropriate to show you that it took 8 years to get to this point, and what was the process of developing this particular tool. Relevant to this particular talk, I don't have any stocks in the company. The company that developed it is called Gentuity. They have given me some travel support so that I could attend the First in Man in Buenos Aires and in Toronto. If you look at the major advancements of imaging in the angio suite, it happens about once a generation. Of course, it begins with the original description of the X-ray. In 1917, an Austrian mathematician who won the Nobel Prize for it described the mathematical transform that is the basis of tomography. So all the times when you take a 3D imaging, whether it's a rotational angiography or a cone beam CT in the angio suite, it's because of that mathematical transform. Of course, Monitz described in the 20s cerebral angiography. He also won the Nobel Prize, but he didn't win it for cerebral angiography. He actually won it for lobectomy. In 1953, Seldinger described a reliable, safe, and easy technique that's now used all the time to achieve access. In 1973, Mistretta at University of Wisconsin, where he still works today, he invented digital subtraction angiography, which was originally an intravenous technique. And then in 1984, Feldkamp described a practical back projection algorithm that is used for all rotational imaging. And I think, maybe it's bold to say, but I think that today what you're going to see this afternoon done in Toronto is the next major evolution in imaging. And it's not a new concept. So optical coherence tomography is basically very analogous to ultrasound, right? Instead of listening to echoes, you're looking at light reflectance. And so it uses near infrared light. It was first applied at Harvard MGH by Fujiwara and his group to image the retina because the ocular media is very clear. So it makes a lot of sense for ophthalmological exam. It was in the early 90s proposed as an endoscopic imaging technique. And then in the early 2000s, a company named Light Lab took off, licensed the technology and applied it for intravascular imaging. And it was approved subsequently in the 2010s, and it's now routinely used in cardiology for imaging coronary atherosclerosis and how devices used to treat that disease are working. And I just want to highlight, this is Giovanni Ughi. He's a scientist of advanced R&D, and he's been instrumental the entire process of our exploration. So we kind of want to define what's the challenge. And the challenge, so that's the first step of developing anything that you're going to do regarding a new device, is what is the clinical unmet need? And our argument is the clinical unmet need is that devices today, you can braid devices with 20 micron wires. You can laser cut features in stents or other devices as small as 5 microns. The vessel wall that I'm going to show you in the brain is about 150 microns. Aneurysms, we've imaged inside the aneurysm, the dome is thin as 20 or 10 or 20 microns. So we're talking about really, really small things. And although we have great non-invasive imaging tools that we talked about yesterday, MRI, et cetera, CT, we're not even on the order of magnitude in terms of spatial resolution. So this technique gives you really high spatial resolution. And the first one to explore this was at the Cleveland Clinic, where you can see there's these 2 sidewall aneurysms in a dog. And in ex vivo preparation, so this was not in vivo imaging, they looked at how the neck of the aneurysm was healing in response to coil embolization using optical coherence tomography. The very first person that I personally know who did OCT inside the brain was Patrick Brower. He did it around 2010 with the Dragonfly system, which I'll show you in a minute, of a basilar aneurysm. He never published it. So the first in the literature is from Kentucky. It's Dr. Given, who published this case of an atherosclerotic plaque that was treated with a wingspan stent. And you can see those images that were published then. Now, what's the problem? So we already defined we want to image in the brain at very high resolution. And we have this Light Lab system, which is now, it says here St. Jude. I apologize. It keeps getting acquired by somebody else. It now belongs to Abbott. Well, the problem is they have a torque wire inside the catheter. So there's a laser at the tip and there's a lens that receives the information and you spin it, right? That's how you take a CT. The problem is and then you by the way, you pull it back so that it's like a spiral CT. The problem is if you bend the catheter even just a little bit, like this kind of a curve, that torque wire comes into contact with the catheter. So it can't spin freely anymore. So it's like you have a patient getting a CT and you decide to shake the bed, right? The images that you reconstruct don't make any sense. It's called non-uniform rotational distortion. The other problem is when you bend it even a little bit resembling the siphon, the wire just breaks. It has so much friction. So we went ahead and we looked at using this old system and can we use it for imaging in preclinical models of devices and neurovascular devices, and does it make any sense? So we decided to first use it to study malapposition. This was discussed a bit yesterday, but malapposition of flow diverters is histologically shown in this animal model that might be the cause of delayed occlusion of aneurysms. We were able to show this with optical coherence tomography. Now you're looking at a cross section. It's important to understand this picture. This is the aneurysm up here. This is the parent vessel. This is the flow diverter. And what you see is excellent apposition. In this case, in very poor apposition at the level of the cross section of the neck. This is only, remember, these struts are 40 microns. So this is really a small gap of about 100 microns. And indeed, what you see here is that when you have excellent apposition, at 30 days, there's a complete cure of this aneurysm, where here, there's this malapposition. At 30 days, the aneurysm remains patent. And this was very highly correlated. It doesn't explain all the variation of the data, but it's very much correlated that delayed aneurysm occlusion is probably related to microscopic malapposition or an endoleak at the level of the aneurysm neck. I'll skip this for the sake of time. What about surface modified devices? This is work I did with Miklos Marshui, where we looked at post-implant. And I'd like to point out that this is at the same time. So this DSA is acquired at the same time as these OCT images. And on DSA, yeah, we see this is a big, it's a 3.7 French device. It's very heavy, it's stiff. So it's kind of causing the subclavian to wrinkle up. But here in the area of the flow diverter, I did not appreciate any clot. But of course, what I find very impactful is this is the origin of the vertebral artery shown here. And these are platelet aggregates in the acute implant process. These platelet aggregates are over the vertebral artery. This is a thromboembolic complication just waiting to happen. And so we measured it, and I don't want to, this is not the point of the talk. We found that surface modifications can dramatically reduce clot formation on the surface of the devices, particularly over the origin of side branches. What about vascular response? This is work I did with Yildiz Karoff, who was a Fulbright fellow in our laboratory. And you can see here, this is the standard thing that we have to do to get a device approved. We have to do it at 7, 30, 90, and 180 days in animals. And we have to basically take the device out. We have to do these cross sections. We have to study the inflammatory processes. We have to understand the vascular response. And what you're seeing here is a cross section of OCT that is analogous to this histomorphometry. And of course, we're engineers, so we measure things. And what you find here is the typical analysis for this thing when you want to compare an experimental technique to an established technique of bland Altman analysis. What you see is that the bias or the inaccuracy is 0.15%. And the variance or the precision is 2.2%. This is incredibly analogous. So I'm basically saying that we can do histomorphometry in vivo with in vivo imaging. Okay, but you've already told me that we can't take this coronary device that was built for the peripheral circulation. We can't take it into the brain. We want to build a device that we can. And so what we have to do is the first step is make technical design requirements. What we wanted to do is be able to operate safely in the tortuosity of the intracranial circulation. There has never been, and today you're going to see for the first time, high resolution intravascular imaging distal to the siphon in the anterior circulation. It's never been achieved. Capable of acquiring obviously high quality images. So basically safe and efficacious. It has to be compatible with microcatheter workflow. That is a significant limitation. And what I want to tell you, every time we're building devices for the brain, the key thing that we have to, the key hurdle we have to go over is basically miniaturization, making things small. We'd like it to be small, but also have a very big field of view. So this is the wish list. And here, this is one of the cases Vitor will show later, but you can see this is the middle cerebral artery. You can see through the artery into the Sylvian fissure. These are arteries coursing in the Sylvian fissure. You can see the arachnoid trabeculae, but these are all the things that we want this device to be able to do. High spatial resolution, able to work in tortuosity, has to be really flexible. And spinning that lens in tortuosity is really the big challenge. We need to clear the blood. And that was a huge risk in the beginning because the brain is not like other organs in that if you're imaging distally, it's getting blood supply from other places. It's like a pressure manifold, right? So if you're imaging the MCA, it's also getting flow from the other side of the brain. It's getting flow potentially from the posterior circulation. So if I'm injecting proximally, I have to clear the blood. In this picture, it's a blood-free image, but if I even have 2 to 3% of erythrocytes in the field of view, it attenuates the light. We can't image anymore. So we have to be able to clear blood, and we have to do that in a reasonable way. And we'd like to be able to take an image of the relevant area in less than 2 seconds, because I know interventionists are very impatient. So this is what the device looks like. Because I put here's a standard Synchro 14. It's called the Viz-M. I apologize. That's a mistake. But this is a standard Synchro 14. Here's the device. It's got an optical window. That's where the laser is shooting out of. Here's a penny to kind of give you an idea of the size of it. It comes in a loop like this. This little thing that's sticking out, that's what plugs into the console. So you have 2 things that you got to work with. There's this pullback unit and then the imaging probe. You essentially hand those to your technologist. They plug it into a tableside module, and that communicates with this console. So you're going to get 250 images per second. You get them real time. You see them as you're acquiring them. It's like drinking from a fire hose. I've done, as Eric has mentioned, a lot of work in different devices. I do believe this to be, with the help of the National Institutes of Health, Gentuity, the company, and a grant from the Massachusetts Life Sciences Initiative, this is probably the most studied technology I personally have ever worked on. We've done in vitro in 30 different patient-specific vascular phantoms. We've in vivo, this slide is old. I think I presented this slide last year at this meeting. We've done over 1,000 imaging sessions in more than 550 cases, and that spans species from rabbits, dogs, sheep, pigs, and non-human primates. And we've done a number of cadavers. Ricardo, by the way, this clock is not working, so tell me if I'm going too long. Right. Give me the, So we published this in Nature a couple of years ago. And this is probably one of the more important images. I know it's a boring image, but you see this is a vascular phantom. And I specifically chose this because I want you to notice that the communicating vessels are huge in this vascular phantom. So I'm really challenging the concept of being able to clear blood. And we filled this with pig blood, and then we tried to clear. And so this is an image that's not acceptable. Basically, you see this is blood in the field of view, and basically you completely lose the image. You can't see anything anymore. This is an image where you have complete clearance. So again, it's boring because there's no pathology and it's just a silicone model. But here I can see the entire lumen, and that's what we tried to achieve. And we were really, really happy because if you look at these contrast injection protocols, and I don't know, they're technologists in the room, you'll notice they're very similar to what you use for rotational angiography. So this is like not weird or out of the ordinary. So we were happy with this result. This is another boring picture, but perhaps the most important picture. This is the first time we imaged in tortuosity. Here we're using the brachial artery of the pig in a maximally flexed position. And we've measured this before, and the curvature and the tortuosity is very similar to the human siphon, internal carotid artery siphon. And here, we're distal here, we're able to spin that lens because we don't use a torque wire. There's another solution for that. And you're able to spin that lens, and you can acquire an image that's artifact free. And I want to point out that that hyper intensity here, that's the internal elastic lamina. Then you see the media, then you see the external elastic lamina, and then you see the adventitia. This is essentially doing histology inside of a blood vessel. Here we implanted a flow diverter in a pig. I think you guys have seen this picture before. This is the high resolution cone beam CT. All of these images are acquired at the exact same time. And what we're showing you is the same cross section. Again, this is very zoomed in when you look out, so it kind of looks blurry, but this is a really good image quality. You don't see this malapposition or this clot on the surface of the device. I think in hindsight, you could go back and there is a little hypointensity here, and you could say maybe that was the clot that I missed, but I think it's pretty hard to call that prospectively. And here, I just love this picture. This is a wingspan stent, and you can see we just happened to catch as we were coming by with the OCT probe. The probe is right there. As we were coming by, we could see this platelet aggregate break off of the stent. That's basically a thromboembolic complication happening in that perforating vessel. So again, we like to measure things. We implanted 8 pigs bilaterally with these devices. We acquired about 1,500 images. We had 3 reviewers look at 3 modalities, and we just asked really simple questions. Is the device well opposed? That's both the stent and the flow diverter. And is there clot forming on the surface of the device for both the stent and the flow diverter? And you can see with optical coherence tomography, of course, we got excellent agreement looking at a Kappa, Fleischmann's Kappa. Interestingly enough, with DSA for clot formation on the surface of a stent, we got really good agreement. If you accept, based on what I showed you, that OCT is the ground truth, they were wrong half the time. So although they agreed with each other, whether they got it right or not was the flip of a coin. I've already talked about communicating malapposition. Here's the problem. You can see on the scanning electron microgram that where the device is not in contact with the vessel wall, you get delayed scaffolding, right? You don't get that neo-intima formation over the surface of the device. So it makes a lot of sense that this explains why aneurysms persist after a year. Only 20 to 25% of aneurysms continue after a year to not be completely occluded using this technology, which I think is a remarkable technology. So here we're going to actually measure it. So I've already showed you this. If you have excellent apposition, you tend to have early aneurysm occlusion. The measurements we're going to make just very simply, we're going to measure a volume. So we're going to take the area where the device is not opposed to the vessel wall, and we're going to sum that area over all of the stacks across the neck. That's our volume. And then we're going to take a normalized arc length. So we're going to take the length of malapposition and normalize it to the area of the aneurysm neck. And what this shows you, this is the standard ROC analysis. What this shows you is that using a volume threshold of 0.6 millimeters cubed or an arc length, a normalized arc length of malapposition of 69%, we're able to very powerfully predict which aneurysm will occlude and which one will not. So the value here is that we can make, you're doing your case, you acquire your OCT after the case, we can tell you in a quantitative way the likelihood of that aneurysm having a 6-month occlusion. I think that's really powerful because then you can go and do something about it. You can do an angioplasty, you can do a massage, you can pin it with a stent. There's other things you can do. Intrasaccular devices, again, this Miklos Morshui had coiled this aneurysm. This is a large canine bifurcation aneurysm. I thought this is a reasonable result. You can see here, by the way, this is the OCT probe in the picture. You notice that here, because this is the common carotid artery in a dog, very high flow rate. What we did to get adequate clearance is we blew up a balloon. This is a flow gate, I believe. We injected contrast and we acquired this OCT image. And what you see, this is the lumen. This is the aneurysm that's been coiled. This hyper-intense object here that's casting a shadow, that's a coil. That coil is sitting more than halfway inside the blood vessel. And all of that beautiful schmutz right here, that's acute thrombus formation on the surface of that coil in the middle of the blood vessel. I would argue if you had this information, you wouldn't leave that alone. And what about these intrasaccular technologies? We found that in this case, we have 2 of these intrasaccular devices, but we left a gap at the level of the aneurysm neck, that gap here. That's where the microcatheter was. And then we detached the device. This aneurysm at 6 months continued to recanalize and is not cured. Here, the bottom one, and by the way, if you look, most of the devices up in the dome, I thought we did a terrible job on DSA. But if you look at the OCT, we completely reconstructed the neck of the aneurysm. This thing was obliterated at 3 months and it continued for 6 months. And again, we like to measure things and I don't want to belabor the point, but we're very, very accurate at measuring gaps at the level of the aneurysm neck. And this is compared to scanning electron microscopy. And we can image here, you see the scale bar here is 500 microns. That's the scale bar. So we're imaging at really, really high resolution. What I really like about this device, I know most of you think I hate animals because we test these devices in animals and fortunately that's required. We can't get anything approved without doing it. I grew up on a farm in upstate New York. I love animals. So you really want me to be the guy who's doing this kind of stuff. And this is something I'm really excited about and we'll be presenting later this month to the FDA. I want to stop killing animals at each of these time points because now I can do intravascular imaging and I can track the progression of the healing of the device in a histological manner. So I really think we can study these devices longitudinally in the same group of animals. This is work done by Zeynep Vardar. And what we studied was the web device. And we found at 12 weeks, adequate occlusion only in 5 of the 24 devices we implanted. And here's why. I don't want to give you all the mathematics and bore you. But interestingly enough, when you herniate these devices, it's the same thing as with the stent with communicating malposition. You now put the device in the main streamlines of the flow, and it's actually really hard for the neointima to grow over the surface of the device. So that's what causes delayed aneurysm occlusion using these intrasaccular devices. And again, not to belabor the point, but mathematically we did pretty well. 90% of the time we could predict delayed aneurysm occlusion based on that level of protrusion. And we like to measure things. So we again showed that this was very accurate as compared to standard imaging techniques, in this case, scanning electron microscopy. What about intracranial atherosclerosis? I think that this is just the tip of the iceberg. What I found really fascinating in the cases that Demetrius and Vitor are going to present is that we have this idea that it's relatively rare. We, in our cadaver studies and in the human studies, we're actually finding that atheromas are actually quite prevalent. They may not be stenotic, but there's a lot of disease. And in this particular study, we imaged cadaver specimens, and we had an independent pathologist basically do a description of the plaque. And here I'm showing 3 different types of plaque: fibrotic plaque, a plaque with a necrotic core, and a dissection in the middle. On the bottom, you see microcalcifications. OCT is fantastic at looking at calcifications. And you can see that there was a 1-to-1 agreement with the standard pathologicals. What about luminal narrowing? Okay, so I only have animal data. We're acquiring now, like I said, and will be presented today for the first time at Innovations, the human experience. But I I pretend that every meeting, once a week, we have a cerebrovascular meetings. I'm sure you do. And every week there's a case of some, luminal narrowing of some vessel, and the discussion goes on for quite some time. The workup is very difficult. What's going on with this patient? Here, I'm just showing you in animals different things that we can see. Again, we're almost doing in vivo histology. This is a vasospasm in this anastomotic branch between the vertebral artery and the basilar artery, actually the anterior spinal artery. And here we see a normal blood vessel, and as we go into that spasm, you see this concentric thickening of the media. That's your classic vasospasm. And we have a case, I don't know if they're going to show it today, in humans of delayed vasospasm after subarachnoid hemorrhage, which has a very similar appearance. It's a concentric thickening of the media, and the internal elastic lamina becomes undulated just because it has nowhere to go, so it gets squeezed. Here, we kind of noticed something weird on the angiogram. I don't know if you picked that up there. And it turns out this at the same time we had a dissection. You can see a tearing of the blood vessel. A few days later, we re-imaged, and you can see here the true lumen, the false lumen, blood products in the false lumen. So you can see again histological level detail of this dissection. This is work done by my wife, Vanya Anagnastaku. And what was really cool, we actually did this years ago. We put the probe in the intrathecal space and we imaged the subarachnoid structures. And the problem with that was that we never knew anatomically where we were. So a breakthrough for us was that this is the basilar artery, and you're just seeing various details, again, super high resolution, looking through the basilar artery into the basal cisterns. You can see all the subarachnoid structure. You see the perforating arteries. You can actually see these arteries as they penetrate the pia. What was important was that taking it from a vascular standpoint, we now have anatomical landmarks where we know where we are. So we can do these 3D reconstructions and have an anatomical understanding of where we are and study the function of these subarachnoid structures. I think this is really something that's going to transform our understanding. I don't know if many of you know, no brain trauma models, our computational models of brain trauma, none of them include these membranes, which are the mechanical scaffolding of the subarachnoid space. They attach to the arteries, the nerves, of course, to the membranes themselves. They have different constructs. So I think it's going to really help us to understand. And I know you guys as neurosurgeons, you've been studying these but once you invade the cavity, you change their structure and function. So we think that by imaging them in vivo is really going to help us understand. And we can get some function. So what I'm showing you here is this is the vertebro-basilar junction in a dog. And we can basically do this dynamic image. Could you play that video one more time, please? We can do this dynamic imaging, and what you get over the pulsatile and respiratory cycles is you can see these the displacements. And from an engineering standpoint, once you get displacements, you can understand strains and get some mechanical understanding of what they're doing. And we demonstrated that you can do this in cadavers. So what do I think? We set out to develop this new technology. Again, I think this is very apropos to this particular session because the device is now built, now being tested in human trials, and I hope it'll soon be available commercially. What do I think we can do with it? I think we can characterize pathology in a much more comprehensive way. I didn't even talk about this, but rotational angiography, which we size our devices, is actually one of the worst techniques. You're much better using biplane. So the problem with DSA is it's one projection, but if you do it in two projections, that's the best way to measure a vessel with what you have today. Rotational angiography actually suffers from a very poor spatial resolution. You have partial volume averaging and just overestimation of a lot of things. So I think this technology, which has resolution approaching 10 microns, like I said, almost histological microscopy inside of a blood vessel, I think it'll help you size devices more accurately. And what Demetrius in vitro will show, you can actually histologically define the aneurysm neck. So you don't have to guess where the neck is. The neck definition on histology is where the internal elastic lamina is ruptured. And you can see that with optical coherence tomography. I think you can monitor the acute and chronic vascular response. We were talking about this yesterday on a SNIS or SNIS webinar. I don't know the answer to that, and I'd actually love to hear from you. It's an invasive technique, right? You have to put a microcatheter. So you can put this thing anywhere you can put a microcatheter. Right now in humans, 021. In the animals, we've actually used typically the headway duo, 0165. We've just changed the way we do our pullback. So anywhere you can put those catheters, you can put this device. The question is, for a routine follow-up, do you feel comfortable with microcatheterization to acquire this information? I hope I've proven to you in a preclinical setting that we can use this to prognosticate outcomes, as I mentioned, with both intrasaccular devices and flow diverters, and hopefully prevent complications. As I showed you, you can see in the acute setting the thrombus formation on the surface of the device, and then you can use medications to correct that. Now, I've had the good fortune, a lot of this information I shared with you already last year or even the year before, but I thought it was very appropriate to talk about device development. This has been an 8-year process to get to what is going to be, I think, one of the highlights of this meeting with Demetrius and Vitor's presentation a little bit later. But this has really been the work of a lot of people, including this great group of people who have been involved since the beginning, our HF-OCT working group that includes Demetrius, Vitor, Pedro, Ricardo, Haram, and Conrad. Haram is a cardiologist who has an incredible amount of experience with optical coherence tomography and has been giving us advice. The team at Gentuity is just fantastic. The CEO, David Kolstad, Giovanni Ughi, who's been involved with us all the way, even writing grants with us, and is actually on our faculty at UMass. And then the guys in our laboratory, all of whom contributed. So thank you so much. It's actually, I need to change this slide because we have now pictures. I don't want to steal the thunder from Demetrius and Vitor, but we have pictures of all the group together in Buenos Aires and Toronto. So next time these pictures will change, but thank you very much. And I finished exactly on time.
Any questions for Matt, guys?
Thanks, Matt. That was that's a tour de force. That's a fantastic platform that we see here. And I was just thinking last night about what I tell my residents in that my neurosurgery residents, in that the operating right microscope has inherently a greater resolution than angiography. Therefore, that's one of the advantages of intervening perhaps open surgically over endovascular. Even though there are so many other benefits with endovascular, I mean, this platform probably changes that equation because you can now understand not just disease, pathology characterization, but even just a fundamental understanding of anatomy and the dynamic views there. Those are incredible. So kudos to you and the team.
John, thank you so much. And I want to point out that the paper in Nature where we originally described all the experiments, we actually put microscopy in the title. The idea being this is analogous to neurosurgery before the operative microscope after. So thank you very much for those comments.
So Matt, one of the things that I get asked all the time, and maybe we should address that, your work was incredible on also not only the image part, but also the workflow, the amount of contrast that takes to acquire an image. And I don't know if it's clear to everyone here, but if you could speak about, the volumes of contrast that we add to the case. I'm surprised how little it is compared to what in some cardiology discussions, that actually is one of the main concerns, that they're using too much contrast and this and that. But for this, because the pullback is so fast, if you could just address that, I think it's really a good point with people that are familiar with OCT, that contrast sometimes is a limitation, but not for this.
Demetrius, thank you so much for bringing up that point. And again, I'm not going to steal your thunder because we actually have numbers in the clinical cases, and I won't tell you those numbers. What I will tell you is those rabbits that we do, they weigh 3 kilos. Okay. And we're doing 3 OCT pullbacks in the acute setting. It's like working in a baby. You have to be very careful about your contrast dose. And in the very beginning, when we were using the Dragonfly, we were not as careful as we should have been. And they would die 2 days later. They would die from kidney failure. So now we routinely do this. And because, as Demetrius said, we're acquiring these images in 2 seconds. We do 3 pullbacks. We use less than 15 mLs of contrast. So we use very little contrast. And you can do it simultaneously while you're taking your rotational angiogram. You can also be acquiring the baseline OCT imaging. So Demetrius will give you the numbers. What we also noticed in the human cases is that there is a learning curve. We were very careful in the beginning because we want clear image length. So we need to clear the blood. As the operators got more used to it, they would stop the injection immediately after the OCT images were acquired. We saw a statistically significant reduction in the amount of contrast that we're using as the experience improved.
Again, fantastic work. So, microcatheter could be brought everywhere in the subarachnoid space. So have you guys done any imaging of the spinal cord or the cortical surface?
We have. Our biggest problem right now is that we're only 10 people in the lab and have literally millions and millions of images. Our biggest problem right now is analyzing them. Our focus is using artificial intelligence is also with the company Gentuity, but we have a grant independently to use artificial intelligence to reconstruct these images and segment them and do the analysis for us because we just have too much data. So it's a good problem to have. Thank you.
Knock, knock. Good morning, guys. It is my distinct pleasure to introduce you my former partner and Professor Tom Brott from our neighbor Mayo Clinic here in Jacksonville. I had the pleasure of working with Tom for 7 years, and Tom has been instrumental in many areas. If you don't know, he's the father of NIH stroke scale. I know you guys use that every day, so that by itself, it's phenomenal. We use that every day, and I'm always telling his anecdotes and his stories. Tom is our PI for CREST study that we finished a couple of years ago, and now the PI with James Mesquia and others at CREST-2, instrumental in his study carotid disease, and now focus on asymptomatic. Tom, we got you. Finally, we have you here. A pleasure to have you here, my friend.
Thanks, Roberto, and thanks to the Baptist team for inviting me. It's a real pleasure to be here. I have no commercial disclosures, but right behind me is the golf course, which is closed today, but this is where I spend some of my hours relaxing. And what a place this is, isn't it? With the beach across the street, it's a great place. But Dr. Gunas, what a talk that was. You know, technology is just wonderful. I was at Mayo Clinic in 1973 and as a medical student. And Thor Sunt was there as the neurosurgeon. And of course, some of the giants in neurology were at Mayo Clinic at the time. And in July of that year, the middle of July, the first CT scanner in the United States was installed. It was called the EMI scanner, and it was from Great Britain, but it couldn't be installed in the hospital in Great Britain where its developer was situated because they didn't have enough support at that hospital to have everything put in one place for the scanner. So Mayo was the first place to have a scanner. Here I am, a peon medical student, and watching the reaction to technology. And since that time, just think of what's happened in terms of technology. Laptops, I think, were another 20 years before we had laptops. And of course, we had Polaroid pictures for the CT at the time, pasted in the chart. And it brings up what Dr. Gunas said, and really measurement is science. Measurement is science. The clinical measures like the NIH stroke scale are kind of pretty crude compared to what you just saw. Well, my partner today is Dr. Savinjo, and you've got the microphone, right, Eric? So let's get into, oh, and Dr. Given, I've got to say, Dr. Given is one of our partners in CREST-2. He and Dr. Brooks and Dr. Jones started the stroke program at Baptist Health Lexington. And they enrolled the second most patients in CREST, 140 patients, and they're already at 100 patients in CREST-2. What a team they have. Now, I saw Dr. Gunas's picture of Dr. Givens. He has changed somewhat. Okay, so here's our brain. And we're not going to go through all the anatomy, but we're down at the carotid bifurcation to prevent things going north into the brain. And so the problems, carotid artery disease, the cause of 5 to 10% of strokes. It used to be 25 to 30% of all strokes when I started practice in 1978. And Eric, maybe you could take us through what you do, and I'll advance the slides. If you could just tell the audience what happens when you're in the OR.
Excellent. And so I'll take it from there. And those are not my slides. So I'm going to make criticism as well. So This is a patient ready here for an endarterectomy. This is how people used to do it. Cosmetically, the longitudinal incision doesn't heal so well. So usually more contemporary neurosurgeon have adopted transverse incision because the skin crease will heal better. So the first step, obviously, it's to get to the carotid. One of the advantages the carotid endarterectomy has had over, for example, bypass surgery is that it's pretty minimally invasive. Even the surgical approach is pretty minimally invasive in the sense that, you could fill your carotid. It's half an inch or an inch, depending of your body mass index behind, under the skin. So it's pretty reachable to get to that. So usually what we're gonna do, there's possibility to do the surgery awake or asleep. The advantage of doing awake is that when we clamp the carotid, we could have a neurological exam to make sure that the patient doesn't have neurological deficit. The reality is most people will have sufficient circle of Willis, sufficient collaterals to tolerate, mainly when they're under anesthesia, the clamp occlusion. So it's really rare that people will need a bypass. So at Baptist, at least, Ricardo and I, what we do is all our patients are under neuromonitoring. So patient will be asleep, but we monitor them. So even if they're asleep, we could know if there's not enough sufficient supply. And then we could, at this point, put a little tubing, a little elastic tubing temporarily while the carotid is occluded, but it's usually quite a rare event. And usually that could be a reason if we don't suspect there's enough collateral to adopt another modality, which is stenting. So the carotid is exposed. You could see the external carotid artery that is higher up, the internal carotid artery lower down, and the loop, the yellow loop is on the common carotid artery with a clamp there. So the first step will be to occlude the internal carotid artery. Loving hockey, the best analogy is you want to protect the goal first. So you want to obviously protect the brain. So by occluding the internal carotid artery, then you could occlude the common carotid artery and the external carotid artery. And then basically you have an arrested system. So whatever you're going to do about this nasty plaque, nothing is going anywhere. There's no blood there. There's no circulation. And then you could peel away this entire plaque. Usually when you do an endarterectomy, it's a good reminder and you eat salad that day. And you could see this is pretty amazing when we think about the other modality, which is stenting, which obviously doesn't get rid of the plaque, just push that away. It's amazing that that it's also good available. Cosmetic result, again, the longitudinal incision here didn't heal too bad, so kudos to the surgeon. Now, carotid stenting. Carotid stenting obviously follow what was happening in the rest of the body. The main limitation here, the main concern initially was that same thing, the end organ, it's not the kidney. It's obviously if you have a distal emboli, if there's little pieces that did dislodge, and you've seen those plaques are pretty scary, patient will have a stroke. So one of the technological advances that were done was what we call a distal embolic protection. So you could see a small umbrella in the upper part of the internal carotid artery. And basically this umbrella, the little hole in it has to be big enough to not completely stop the blood flow. Otherwise a clot would form there. But hopefully they're small enough to catch little embolic debris that would go through.
And
So
let me just interrupt for a moment, Eric. The internal carotid artery, we see these pictures up here. You saw them with Dr. Gunas, and we'll show pictures. The inside of the internal carotid artery is only a little over 5 millimeters in men, and it's smaller than that. It's less than 5 millimeters in women. So an 80% stenosis is 1 millimeter. And Eric, what about getting through 1 millimeter?
Fortunately, the technological advance, have made quite a difference. So the little wire now, whether we go to the wrist or the groin, those little wire, the torque ability of that is pretty amazing. I mean, those technology now, a lot of them are not even a wire, they're a hypo tube with, little cut in it. So typically you could now, with the technological advances, you'll rotate them wherever you are, the groin or the wrist, and you have immediate response where you're navigating that. So obviously you have to be delicate, make sure you go in the true lumen in the opening of the vessel, but that has been made quite easy with those technological advances. So over the rail where this protection device is, it's basically a little wire, a little rail to bring then your instrument. So the first step usually, depending on the degree of stenosis, would be to bring the balloon or a stent. And then depending on the degree of residual stenosis, a balloon will be brought back within the stent, and then the stent will be expanded. And then after that, and you could see here an example of stent. So this is closed cell design. So basically there's two possibilities in the technology, and basically, you know, think about it like a fence. Either it's a fence that is all the unit of the fence are all attached together, or either to allow more flexibility, do you have an open cell?
Well, I think that might be an open
Is it?
cell. I thought it was. But what about the mesh? Well, the closed cell, you can mention the differences, and then the mesh stent. I don't have any more pictures.
Okay. So basically, there's different technological differences in the stent, but it just allows for conformability and all that. And those stents are what we call self-expandable. So it's not like in the coronary or the cardiac stent, which most of the time are on the balloon. And as you inflate the balloon, the stent is released. Those are syringe stent, and you basically just push them and they open on their own. And you could see here, after the retrieval of the protection device, you could see on image B versus C, you could see obviously revascularization of the vessel. So basically the plaque has not been removed. The plaque has just been pushed by that stent, and now it's kind of beyond that stent. And the lumen has been restored by the force of the stent and the balloon.
Okay, thanks, Eric. Now I've got to say, in terms of treatment, you saw endarterectomy and you saw the stenting. But the other tools are medical therapy and how things have changed. When I started practice, there were ashtrays in the nursing stations. I was able to bum cigarettes. I really like menthols. And there were a lot of nurses who had menthol cigarettes. I don't know why. And it was very relaxing to just kind of sit down there in the nursing station and have a cigarette. Can you imagine? The ashtrays were so big, they were like big circles, some of you may recall, and they had little ports in them so that, you know, you wouldn't run out of space for your cigarettes or the ashes. You had plenty of room. And then, of course, statins came in, treatment of hypertension has come in, and those are the tools that we as neurologists have, but so does everybody else. And look what's happened. This is the true revolution in medicine, or one of them. But this is age-adjusted mortality. And just look at what's happened with stroke mortality since 1965. This is one of the miracles in medicine today. Drop-dead MIs were so common in the 60s. You go out and you shovel snow, and the next time you wake up, you don't wake up. The automatic defibrillators were big deals in the 2000s, but now we just don't use them that often because drop-dead MIs, ST elevation MIs, and large vessel strokes have gone way, way down. If it weren't for atrial fibrillation, I think our interventional colleagues might have trouble finding enough cases. So what about symptomatic patients? Well, two big trials. The one on the top is NACID. The one on the bottom is Lancet. And these trials, look at those dates. I don't know if you can see those dates, but it's 1991. 32 years old. That's a generation. And these are the trials that we rely on today. And look at that. The absolute risk reduction in NACID per year was 8.5%. You're not going to find that for any treatment, almost for any disease. The number needed to treat to prevent one stroke is only 12. That is stupendous. And as a result, that's still the standard of care today. Well, what about stenting compared to endarterectomy? Well, in the CREST trial, we had 2,502 patients, and this was our 30-day stroke and death rate for the two treatments. Now, afterward, CREST did, the CAS patients did great. And if you threw in MI, the two treatments were very similar. But in terms of safety, 20 years, well, not 20 years ago, but as of the 2000s, and some of those patients were treated 23 years ago, I learned actually last night that Demetrius, I think it was Demetrius, come on, tell him what you did. Can you give Demetrius the microphone?
Thank you. But this is, we actually were the first CREST patient enrolled. I was the fellow on that case with Dr. Hopkins in Buffalo. And it was very historical for today. I still remember the day because it was the beginning of a new journey that you started. So I was very honored to be part of that.
Yeah, that patient was entered in December of 2020 at SUNY Buffalo. So an advantage. Well, there are 4 large trials worldwide that looked at this comparison. And the hazard ratio of stenting compared to surgery showed that stenting was not as safe as endarterectomy, 45% advantage to endarterectomy. The post-procedural rates, though, were less than 1% per year. So both of these treatments, once they're done safely, the patient is in great shape, And of course, stenting was a new procedure in the 2000s, a brand new procedure, and it's gotten a lot safer. And you can see that that would be where the money would be for improvements in clinical outcomes, would be the safety of carotid stenting. And this just shows the Kaplan-Meiers, and you can see on the left, the two curves, the red and the blue, that all the difference is at the beginning. And once the procedure has been completed, look at the right-hand slide. That's after the procedure has been done. Those patients are really better off. The one thing we learned in CREST, and we found in all 4 of the worldwide studies, is that a surprise to us was that stenting was more dangerous in the perioperative period than endarterectomy. And remember, stenting was touted at the beginning that it would be better for elderly patients because it was less invasive. But it turned out to be just the opposite at that time. We hope that things have changed, but you can see there was a big advantage for stenting then for the elderly patients, a big disadvantage for the elderly patients. Now today, if you've got an elderly patient and the bifurcation looks like interstate highways, everything's smooth, no tortuosity, and you just have stenosis, I'm sure that the Baptist Health team doesn't have a problem with stenting that patient. But the 80-year-old patient, the 70-year-old patient that looks like interstate highways, I'm not sure how common they are. Would you agree, you two? Okay, let's go forward. So symptomatic patients, what do we do? Well, here's a kind of a nice schematic, which is integrated with the level of evidence. In the far right-hand side, those are the patients we're usually talking about. And CEA and best medical therapy are recommended. Class 1A means that we should do it, and there are 2 randomized trials to suggest we should. And you could see that even in high-risk patients, it's recommended. And we don't have the time to go into all of the different permutations, but I would like to mention that this is a recent recommendation, is that for symptomatic patients who are not being considered, we now have the combination of aspirin plus clopidogrel that we like to treat our patients early on before going to monotherapy. And remember, get that LDL down below 70. What about asymptomatic patients? Again, 2 studies, and look at the dates. One's 1995, one's 2004. Neither one really had best medical therapy, but they did have medical groups. They did have comparative medical groups, and now it's a different story. You remember that absolute annual risk reduction for NASIT for symptomatic patients was 8.5. Now we're down to 1%. Okay, and a number needed to treat. Now you're close to 100 patients to prevent 1 stroke per year. Even if you go out to 5 years, you have to treat 20 patients to prevent 1 stroke. So a very different level of protection compared to best medical therapy alone. And these are the outcomes of the trials. And the one thing that I would just mention, if you look at the right-hand graph, you can see that everything's, the oldest are at the bottom and the newest are at the top. Everything's getting better, okay? Everything's getting better, both in terms of the procedural safety and in terms of the long-term outcome. And that's nice, isn't it? That everything's getting better. What about endarterectomy compared to stenting? Well, here it is in CREST, still an advantage for endarterectomy. This is the peri-procedural stroke and death. One thing I'd like to just point out in terms of everything's getting better, 1.4% for endarterectomy. In 1980, I can't believe it now, 1980. Well, actually 1981, I went around to 22 hospitals in Cincinnati, Northern Kentucky. The overall stroke and death rate in 1980, they weren't using aspirin peri-procedurally. The overall stroke and death rate at 22 hospitals was 9.5%. 9.5%. And look what's happened to surgery. In NASIT, it was 6.5%. In ACAS, it was 5%. And look at it today. In CREST, well, this is 10 years ago. This is a remarkable improvement in endarterectomy over 20 years. Remarkable improvement. And a whole bunch of reasons why. Well, what about asymptomatic patients more recently? The ACT-1 trial had, I think it was almost 2,000 patients. And if you can see those yellow numbers down at the bottom, we won't go into the details, but in this more recent trial comparing stenting to surgery in asymptomatic patients, the outcomes were very similar, showing that if you can improve safety, you can improve overall outcome. And then from the UK, this is 3,625 patients. We won't go into all the detail. You can see all the numbers there, but I can tell you that the overall results comparing endarterectomy to stenting now are very, very close. So in fact, stenting has improved year by year. But look at that yellow, okay? This does not address the question of whether, in addition to good medical therapy, a skillful, and that's how they spell it in Great Britain, a skillful carotid intervention would be appropriate because there was no medical group. And that's what we're trying to do in CREST 2. Now, you probably can't see this. This thought just hit me as I was putting this together. The top 2 rows, the top 3 rows, I should say, are the SPACE 2 trial. The results were just published this fall. This did have a medical group. It's the green. Do you see the green? Okay, and the green, you can't read it. It says 3.1%. And the next one up is 3.1%. And the next one up is 2.5%. That's over 5 years. None of those differences were significant, but they couldn't enroll patients. This is in Germany and Austria. They couldn't enroll enough patients. They only had 500 patients. The differences weren't significant, okay? But you can see that things are maybe different today. Maybe cigarette smoking cessation, statins, you name it. Maybe things are different today. But here are the guidelines, okay? And you can see carotid stenosis, 60 to 99% stenosis, life expectancy greater than 5 years, favorable anatomy, CEA plus best medical therapy. CAS plus best medical therapy. Those are the recommendations today. Okay. But we've got new knowledge on the brink, and that's CREST-2. And thanks to the Baptist team, the Baptist team, Gene is here, and of course, all of our interventionists, neurologists at the Baptist team. They're one of 142 sites in CREST-2. The study design is to determine the differences between intensive medical therapy alone and intensive medical therapy combined with carotid revascularization. Got 2 trials. Both trials have 1,240 patients, as you can see, and you look at them, 4 groups of 620. So each of our groups is going to be bigger than the SPACE 2 trial was in total. These are the enrolling centers, and if you've got really good vision, you can see Northeast Florida and Baptist Health. If you've had such good vision, tell me how you do it. But we've got 2,255 randomizations, and you can see the breakdown in enrollment, or a breakdown in terms of our sites. The 21st century components, we give out free PCSK9 inhibitors to lower LDL as needed. Used to be $14,000 per patient per year. Now it's down to about $6,000. CREST-H, we don't really have, that's a hemodynamic study. We don't have really time to get into. We've got baseline plaque imaging. We have end of study MRI. And here's just a picture of a plaque with hemorrhage using the conventional equipment available at every one of our 142 sites. The medical management is key. Of course, aspirin, dual antiplatelet therapy for CAS. Both trials, we want to get that LDL low. And this is what we focus on: blood pressure and cholesterol. And if you look at the middle column, that's where things were for the patients treated at the very best medical centers in the world. Mass General, Johns Hopkins, Cleveland Clinic, Mayo Clinic, Baptist Health Jacksonville, Baptist Health Lexington. We may have had, I think we've got 1 or 2 other Baptist Healths in the trial. You can see that we're really not geared up at the medical centers to really get blood pressures down. You need a cookbook. You need a cookbook. And that's what CREST-2 has. For instance, right now, 40% of our patients are on 3 medications to get their blood pressure down. And look at where we are with the cookbook. Now, 70% of the patients had blood pressures less than 130, 70%. And our mean is about 125. Imagine what that would compare to in ACAS, where it wasn't even looked at. And it looks like I don't have that. Let me just go back. Oh, you've got LDL. Look at that. Again, LDL was not being controlled. And by the way, guidelines, if you have asymptomatic carotid stenosis, the guidelines are your LDL should be less than 70. So our 142 sites weren't really living up to what they should do. Look at this alirocumab. Each one of those lines is a patient. And the baseline mean LDL in these patients who were either intolerant to statins or we couldn't get their LDLs down enough with statins. So each line is a patient. This drug, and the other one is evolocumab. And by the way, Dr. Gunas, there is OCT in the Glagoff trial looking at lowering LDL below 70 compared to not. It was a randomized trial and it showed plaque regression. in those patients relative to the patients who weren't randomized to get their LDL plummeted. So we do think it makes a difference with plaques as well. But look at that. And the mean went down to 55.9. And these are tough patients. That's why they got it. These drugs work. Okay. And now we've got inclisiran, and we're going to have more with technology, better patients. These are injections. You take an injection every 2 weeks. So CREST end of study. The final results will be presented at the HA International Stroke Conference and will be published in the New England Journal, hopefully the same day in February 2026. That's what happened at CREST, and that's what we will hope happen here. Where are we? Well, you can see we're almost done, 97 complete on the right in endarterectomy trial, 85% in the CAST trial. And here's we are with the MED trial. And here's where we are in the CAST trial. And so that's where we are in CREST. Now we've got TCAR. We're not going to really get into the details of TCAR in this talk, but it's a neat technique. Now, what about the future? We're going to put Dr. Savageau back on the spot. Okay, so here it comes. Everyday practice 2026. What's going to happen? First of all, there will be fewer patients. And the reason is medical therapy. Medical therapy. And look at carotid endarterectomy. If you look at the top row, 1999, 2000, 2013, 2000, cut in half the number of endarterectomies. And here's Great Britain. And look at 2011, look at 2017. Worldwide, the number of patients is going down. So now we're going to ask Dr. Savageau for his wisdom. What's going to happen if CEA wins in CREST 2?
So I do not think, unfortunately, CEA will win. For the reason you mentioned, I mean, I do think medical therapy has improved tremendously. So I do think that the number, if you look in the United States, the number of carotid endarterectomy performed for asymptomatic disease is the bulk of the surgery. It's I think 80% of the endarterectomy done. So I think it's going to recalibrate this. I think a lot of people, are getting probably unnecessary endarterectomy. So I think for asymptomatic disease, my only concern is that I do believe there's subgroup that would still benefit significantly, and I'm afraid they'd be thrown away with the rest of the patient. So that's my concern, but I do highly doubt that endarterectomy will win, and I do highly doubt that angioplasty stenting will win. And as far as TCAR, I think it's always going to remain like the pushed by the vascular group. The lack of evidence there of randomized evidence, because all those prospective arm, I mean, there's quite a difference between a lot of that is self-adjudicated. So I do think it's going to remain like, is there a room for this? And that probably going to continue. And I think to me, what is really fascinating is you talk to vascular surgeon, and the reality is that the newer generation of vascular surgeon, it's not, TCAR is not replacing transfemoral, it's replacing basically carotid revascularization at large. The first answer is that, could we do a TCAR? Is there a contraindication to a TCAR? And if not, that's usually what they'll go with. So I think that's kind of changing the field, but without the same degree of science that we have for endarterectomy and transfemoral stenting.
I was encouraged by Dr. Gunis's talk in that, we're doing plaque imaging, but it's still, we're getting lipid core, we're getting, is there a hemorrhage or not, stuff that we've known for a long time. And we're going to do our best, and we're going to see if we can find some plaque characteristics that, make a difference in terms of risk. We're also looking with the hemodynamics, and your team is doing CREST-H. And just briefly, we do perfusion imaging and identify a group of patients who not only have the stenosis, but they have decreased perfusion to some degree on the side of the stenosis. Believe it or not, when the grant went in, the prediction was 20% of patients would have a significant decrease in perfusion. Hasn't turned out that way. Only 10% have a decreased perfusion, you know, because of what Dr. Gunas was talking about. The collateral circulation is such that 90% of patients with a very high grade stenosis have good collateral circulation. But that could, again, maybe that particular portion of patients might benefit. And then we hope that maybe with better imaging techniques that you heard in the first talk, that maybe we could come up with some really good high-risk patients. Well, that's where we are. We're actually, for the 45 minutes we were given, we're actually 5 minutes ahead. So thanks again for your attention, and please take care of your carotid artery. Dr. Hanel.
I have a lot of questions, Tom. It's mind-boggling to me that as a society, you look at numbers of blood pressure that you mentioned there in LDL, we see that routinely. As a neurosurgeon, I joke with my stroke neurologist and critical care neurologist that are stroke interventionalist that has interest on this. How come as a society we do such a poor job taking care of these factors that are way, way, way cheaper? And I saw the decline in stroke, all that. But in the era of iPhone 14, you don't know your blood pressure, you don't know your blood, and patients that go to primary care, not patients that don't go, not even going there. So I would love to hear your thought on the Sampras. We did that on Crest 2, you're doing that. This personal coach, is this something that we should be paying more attention and invest on that?
Yeah, I forgot to mention, we have an organization called Intervent, and they call the patients every 6 months and ask them about all of the things that they do. Now, I will say, I think Intervent's great, but the key still is medication. You can only lower your blood pressure so much with exercise, diet, avoiding the salt shaker. That's why 40% of our patients are on 3 drugs. Drugs work. Good intentions don't work. And to kind of get at your question a little bit, people get sick of me, our family members, you know, I'll say, how's your blood pressure? And they'll say, fine. And I'll say, well, the machine actually doesn't say not so good, good, fine, excellent. And I never get a number. Nobody knows what their blood pressure is. And I think that's part of the doctor's problem. We don't give them a number and ask them, write it down, write down the number. You should know it. The other one is LDL. How's your LDL? It's pretty good. Yeah, it's fine.
36.
Yeah, now that's what I want. That's what Dr. Gunas would say. Give me a number. There was a British philosopher who said, if you don't know, if you can't put a number on something, you don't know very much about it. Not very humanistic, but when it comes to what you're talking about, definitely important. Now, what to do? I think primary care, and by the way, I talked to the CEO of Mayo Clinic about this, John Noseworthy. And it was like, oh yeah, that's a great idea, Tom. Oh yeah, we should really do that. You know, Mayo Clinic. I mean, I'm not an expert in healthcare delivery. I've got to do what I do. You have to do what you do, but it's a real problem with our society. And for those of you in this room, what is your blood pressure? What's the number? What's your LDL? And if you say to yourself, well, I've got white coat hypertension, go on Google, buy a blood pressure device for $49.95. I've got one at home. It's kind of fun. Gives your heart rate, gives your blood pressure, and it's a piece of cake.
Tom, one more. I saw you're trying to get away from commenting, and I don't know if there's somebody from a Silk Road in the room, but I think Eric and I, when we went through the TCAR training, we asked this question directly, and the answer is not exactly what we want to hear. I know you tried to get TCAR into Crest 2 from the randomization perspective. I was there with you listening. TCAR wide adoption without level one evidence on randomized trials. How do you feel that? How do you see that playing after 2026? Are we gonna have an asymptomatic TCAR versus best medical therapy as a CREST 3? What are your thoughts on that?
People that I trust in vascular medicine, and if Eric will tell you, I asked Eric last night, what do you think of TCAR? Remember, Eric? I asked people that I trust, what do they think of the method? And people that I trust think that it's a nice alternative because of the retrograde flow. Another friend recently said, retrograde flow technology is going to advance, so it's going to be easier to get retrograde flow. And I do think it would be nice to have an easy way to get retrograde flow in terms of particulate matter. And your other question was,
Without a randomization.
oh, yeah. I was, as I mentioned, I was on the FDA device panel for 8 years. I was chair for 2 years. And we need technology to go forward. And it's hard to get randomized trial evidence for everything, particularly for what you do in endovascular neurosurgery. It's hard. And you don't want to hold it back. You want randomized trials, but let's take your question. TCAR versus endarterectomy, okay? We know from CREST, it took 2,500 patients to find out a difference when CAS was primitive, okay? Now, TCAR, the registry results are very good. I think it would probably take, and actually we have numbers on this, it would take over 8,000 patients to find an answer. And when you have, the more patients you have, the lesser clinical effect you're finding. Let's say you're studying a parachute. How many patients do you need in a trial to prove that a parachute works? I don't know the exact number, but it's less than 10. It might be less than 5, okay? Now, that's a lot less than 8,000. And when you see these trials in New England Journal, and there are 20,000 patients, that's usually a pharmaceutical trial, and they're trying to find a significant difference for FDA, and the difference they're looking for is that big. And that's why there are 20,000 patients. With 8,000 patients, again, you're looking for very little differences, and it's much more important who does it. Is it Eric? Is it somebody who's brand new to the procedure? That's going to be a lot more important from my point of view than whether it's TCAR or transfemoral.
I'll stop here. But as an operator that does transfemoral, transradial stent, endarterectomy and TCAR, where do I put TCAR in 2026? When I'm gonna have endarterectomy is the same or inferior to best medical treatment. And again, space shows that 3.2, 4.2, 2.5. Again, best medical treatment is showing there before. Again, CREST 2 is going to show that probably stronger. So TCAR was not studying any of those. So where do I put TCAR in 2026 compared to the other two surgical interventions?
If you two are correct about medicine, okay, because now you've both said you think it's not going to win, medicine is not going to lose. You said that. I think TCAR will go way down because I think it's primarily done with asymptomatic patients. It takes a while. Today in Denmark, no asymptomatic patients get revascularization. In Canada, where Eric's from, it's about 15% right now, and that'll go down. It will take time, but I think it will go down, and the revascularization, it's going to be symptomatic patients. Jose, Dr. Romano.
Thank you for a great talk to both of you. Will you have evidence in a CREST 2 about silent infarcts, border zone distribution infarcts, cortical infarcts related to a clinically symptomatic disease?
We have end of study MRIs, and already we've got 386. I wish we had 2,200, but we've only had about 1,000 graduates so far. So we're getting graduation MRIs in about 40% of patients. Our neuroradiologist, John Houston, is up in Rochester. He's looking at all of those things that you just mentioned. We're not going to have hard answers, but we're going to have information that's going to be useful to you. Nemo.
Yes, great talk. The recommendation that you had was about the degree of stenosis. And as you've said, obviously, degree of stenosis is important. How do you deal with the fact that there's discrepancy between whatever modality that you may take? For example, it's when we looked at our numbers in Pittsburgh, we found about 15 to 20% of patients who had high-grade stenosis based on either Doppler or CAT scan. When we did an angiogram, it was less than 50%. So in practice, I guess, how do you deal with that to try to figure out true degree of stenosis?
Well, you're absolutely right. And in CREST, we looked at the different kind of Venn diagram. And all I can say is that clinically today in the United States, those are the people that are getting treatment. And they're not perfect, overlapping groups. But the kind of the three things, ultrasound, catheter angiography, and, CTSA, those MRA and CTA, that big gamish, those are the people that are treated. And we've got a pretty good representation. We're going to break down the Venn diagram. As you know, in CREST, you got to have ultrasound plus one of the other ones. And we should be able to come up with some information, but not answers. Thanks for that question.
You guys, if not, Tom, here's a little token of our appreciation. You are in Ponte Vedra, but you take another piece of Ponte Vedra. Thank you. Phenomenal. Dr. Nima is going to introduce our next speaker.
Thank you. I have a distinct honor to introduce our next speaker, well known to our Baptist Health. She's a director of our structural heart. She's one of the pioneer of structural heart management, which is relatively new. And Beth, she's a great colleague, and we have a great collaboration with her and with cardiology. So with that, Dr. Sapati.
Well, good morning, everyone. I feel a little lost here between all the brain doctors. You got a cardiologist, and I'm an interventional cardiologist for people who don't know me. And so we're going to switch gear. Fantastic conference, great dialogue. But we're going to switch a little gear from the carotid artery to other causes that can cause stroke. And again, it's a lot, advances in neurocardiology. It's hard to cover in 20 minutes, but I'm happy to take any questions if it's not part of my PowerPoint. And again, with the caveat, I am going to completely agree on what we talked about, the statin and the diet and medical management about prevention of plaque buildup everywhere. Carotid in the heart, in the peripheral arteries, the medical treatment is advancing fast. So with that, so my disclosures, nothing pertains to my talk today, but most of them I have had the pleasure of being involved in a lot of the trials from the beginning and have had the luxury of seeing a lot of the devices in structural heart grow over the last 20-year period. It's actually a humbling experience, I should say. So as Dr. Nima said, I'm the head of the structural heart program at Baptist. And this term didn't exist 20 years ago. This is a very new term. And people ask me, what is structural heart disease? It's basically anything that's wrong with the structure of the heart. The biggest pie of the whole pie is portion of the pie is probably valvular heart disease. And a lot of times, historically gold standard have been open heart surgery. And now we can do a lot of things with catheter way. the TAVR and the mitral clip. And then there is the holes in the heart. We'll talk about the PFO, the ASD, and the VSD, depending on where the hole is. And then there is a left atrial appendage, which I'm going to touch upon a little bit because it's related to the stroke. And then there is the thickness of the muscle, hook'em and paravalvular leak. Again, for today's talk, I'm going to focus on, because I was tasked to talk about the prevention of stroke. And so I'm going to focus on PFO and left atrial appendage. But like I said, it's a big topic. Happy to take any questions at the end. So let's start with the case review. This is probably a person that you have seen very often in your practice, 82-year-old female who has AFib, she's on amiodarone, multiple PCI, so she's also on aspirin and Plavix, hypertension, diabetes, CKD, EF40, 45, a common person, very commonly seen in either cardiology or neurology practice, CHA2DS2-VASc score 5, recurrent GI bleed. So this is a little, the heart, when we have AFib, the blood clot usually happens in this little pouch called the left atrial appendage, which again, if the pointer will work, it's this little pouch that hangs behind the heart, just like appendix in the belly. And it's a very muscular structure. So once blood gets there, it tends to form clot. 95% of clot happens here. Historically, again, even today, the gold standard is blood thinner. And I'll talk upon the research status. But a lot of people, as we know, bleed, and now they're either not taking blood thinner, they're just taking aspirin, sometimes nothing, which we know does not protect against stroke. Before, we didn't have any option. The only option was to go for open heart surgery. So we clipped the appendix, but it was a big surgery. Nobody was ever interested to go there for prevention of stroke, because prevention is a hard one. But now we have almost 15 years of data. The left atrial appendage occluder, we'll talk about their different devices, but we go in and put a little plug. As you can see, the space is gone. And this is in the heart cath, our structural lab this is the TE probe. So we're looking at the echo and we're going in the right femoral vein or left femoral vein, right atrium, crossing over, go to the left side. We do pictures to see how big or small or narrow or wide this appendage is, and decide they come in almost 30 different sizes, and putting the right device so there is no leak. So we're at the right place. We're talking about innovation. A lot of stuff that we're talking today, we never thought we could do this 20 years ago. Comes in multiple forms. I'm sure you've been talking last 3 days about all kinds of this stuff. Whoever thought, right? What we're doing today. Remember the IBM Maniac 1945? This is how the machine looked. And now we're on a little phone. We can do actually Epic, probably can check the labs while you're sitting here and maybe do even a note if you're really good in typing. Nobody goes to theaters anymore. Nobody calls taxis. That service is probably going out of business. Nobody has those radio and tape recorders anymore. It's the iTunes and the iWatch. So in this era, so introduction of new technology, it's disruptive, but again, with refinements, it sustains. It's always disruptive when it comes. And this is in our structural heart world, this was disruptive 15 years ago. And now it's almost, with all the refinement, the light switch has flipped, and that's the standard of care. A lot of stuff that I'm going to talk about. So back in 2001, one of my mentors, Mike Mack, wrote, "Future of surgery is ablation over excision." I think it kind of talked, what we just talked in the last session about carotid artery as well. Image guided over visual, reconstruction without suturing, and access via a natural orifice over cutting. So I'm going to focus the first part of the talk on the PFO, on the AFib, and then I'll touch upon the PFO at the end. The AFib is the most common cardiac arrhythmia. It increases, and there are more than 33 million people in the world that has AFib. The stroke risk is 5 times higher with AFib. More than 90% of the clot with AFib happens in that appendage that I showed earlier. But there is a 10% clot that can happen in the other part of the heart. That's why we never say 100% prevention of stroke, because you can have other reasons or carotid non-cardiac reasons. Now, many patients, even in today's age, and we'll talk about the medications that are out there, either warfarin or all the DOACs and NOACs, still about 50% people are not compliant. So AFib is a growing problem associated, the stroke that's associated with AFib, and I don't have to preach to the people in this room here, the strokes are more morbid. They're more disabling because the clot burden is bigger and it's blocking a bigger artery. Now, historically, anytime we do any procedure in the heart, we were taught to stay away from this little appendage because it's a very thin structure. It ruptures very quickly if there is any trauma. But it looks like this. And this is the picture how it looks on echocardiogram or TEE. And this is the picture how it looks on CT scan. So we do a pre-procedure planning. And as you can see, they come in different shapes. Everybody's appendage looks different. So the guideline historically has showed the CHAD-VAS score, which again is a very easy app, probably everybody has on their phone, that if it's more than 2, you are recommended to be on a blood thinner. And that blood thinner historically has been Coumadin, but we all know goes supratherapeutic, INR 28, people bleed. A lot of times you guys see intracranial bleed. We see all kinds of bleed, cranial and extracranial and intracranial. And a lot of times they're under therapeutic, so they have stroke with INR of 1.8. So oral anticoagulants in today's era, still the standard of care, but compliance is a challenge. We thought when we have, again, 30% of people, even after all the NOACs, there are 4 NOACs that are commercially FDA approved, the Xarelto, the Eliquis, Sebacia, and Pradaxa. But even with that, as you can see, cost or the bleeding risk or the people interrupting for procedures, 30% people still stop taking medicines at 2 years. And the bleeding risk, again, better than Coumadin, but it's still there. As you can see, on average, it's 2 to 3% risk per year per bleeding. So if you do a cumulative over 10 years, it's 20% risk for bleeding. And that's the premise of the study that we started, Protect AF, back 15 years ago. I was one of the principal investigators in William Beaumont Hospital, where we did the first ever Watchman in US. And back then, the procedure used to take 4 hours. Now it takes 30 minutes. So everything, technology has improved over 15 years, just like medicine has. And people usually go home same day. A lot of times we do with twilight sleep. But the bottom line is, so you see this appendage structure, and we're going in with the catheter coming from the septum and putting a plug that, again, the sizing is very important. And the idea is they come in multiple different sizes, but it blocks this PTFE tissue cover, and it blocks the appendage, so there is no space for clot to happen, and the blood circulation in the heart doesn't see it. And on the surface, all the patient has is a little 8 French to 10 French catheter hole that we percutaneously close. And it gets endothelialized over 6 weeks. So we do have data. We do a TE at 6 weeks, a TE at a year, and most of the people, it's healed, endothelialized, and that's when they come off the blood thinner. So what does FDA say about the timeline of what you have? And this is important because a lot of times people who have had intracranial bleed or a massive GI bleed may not be comfortable being even on that short-term blood thinner. So a lot of times we have a lot of mutual patients. I would send text to Nima or Eric or Ricardo or Jason saying, hey, are you guys comfortable this patient going on a short-term blood thinner? So the ideal treatment is after the implant, 45 days of, well, it says Coumadin there, but the data is approved now for or whatever they're on, Eliquis or Xarelto or Pradaxa. At that 45-day mark, we do a TE. We make sure it's completely healed and there's no residual leak. And then they go on aspirin and Plavix for 4 months. And then at 6-month mark from procedure, they're only on, actually the data changed, only on baby aspirin now. There is a study called ASAP that actually said you can be on aspirin and Plavix with the new generation Watchman from day one. You don't need the short-term 6 weeks of blood thinner. These are all the trials that has happened. Like I said, my first experience was 2002 to now 2018. It has been a humbling experience seeing and being part of all these research studies. So what it shows that basically the device works, 95% implant success rate. There is a 1% peri-procedural risk, but it's one-time event and they're done and people come off the blood thinner. So this is what the FDA recommendation is. Obviously, if your CHA2DS2-VASc score is low, you can be okay on aspirin. We don't need to do the procedure. These are only for people who have a high CHA2DS2-VASc score. And back in the day, like I said, in this one, there's an addendum now to the FDA box warning that they can be on aspirin Plavix with the second generation Watchman, which I'll cover in a little bit. But before we said that they should be able to take blood thinner for a short period of time. So the breakthrough, and always there is refinement over time. So back in 1993, nobody thought wireless net so far, it's less, it's never going to work. Television won't last because people will soon get tired of staring at the plywood box every night. That's what we used to think. And that's same for all of this technology. Like I said, a humbling experience 20 years ago, stuff that I never thought was going to take off, we're doing every day in our life. Future, like I said, the Watchman has come up with the next generation Watchman called Watchman Flex. It looks a little different. This is the one that has the data for 6 months of aspirin Plavix. They don't have to be on blood thinner at all. And then Amulet is a new device that I was the PI. We did the first case in Southeast US, third one in the country, that also has much easier. This is the Flex device. As you can see, the technology is different, so it heals easier. The advantage of this Amulet device, which has been approved in FDA for 5 years, this is actually the more preferred device in Europe. 90% of the market is actually Amulet. It's like a dual door technology. As you can see, there is a lobe that is covering the appendix, but there is a disc on top of it, which is very similar to the PFO and the ASD devices that we have been doing for 30, 40 years. And these people, we did when they're 20 and they're 50 now. We know that device heals very easily because of the disc structure. And this is the one that I prefer, especially if they have had an intracranial bleeding, because the data is robust, that actually the guideline from day one was only aspirin Plavix. It never needed that 6 weeks of blood thinner. And in fact, now the data is 3 months, so shorter duration, which helps again if you have had brain bleed before. And actually, FDA had just allowed, because it's CE mark now, for 6 weeks of DAPT, and we're one of the 5 centers that we are in the pilot study for 6 weeks of DAPT. They come in different sizes, like I said, and this is a case of how the Amulet device looks. Again, same procedure, takes the same time. People usually go home same day. And as I said, the patients really like when they're off the blood thinner. The one thing that I'm going to mention real quick, because we are a part of the study, and the next level of the study is that people who are not bleeding, but they want to get off the blood thinner because their has bled score is high, which is a score that takes into account their age and comorbidities, that shows that they are at high risk for bleeding, even if they haven't bled yet. And that's the FDA has allowed, it's actually almost finishing enrollment. There's a study for Watchman device and there's a study for Amulet. We have both of those research trials here at Baptist, but that is looking into randomized 1-to-1 between continuing that whatever medicine blood thinner they're on versus getting the device, and we'll have the data at end of 2024. Switching gears to PFO. Again, this is a journey of probably 25 years now, maybe even longer. And we knew that PFO, I always tell patients, PFO is very common. 1 in 4 patients, if you put 4 people in the room, one of them is going to have a PFO. It's 25% incidence. And most people do not have symptoms in their lifetime. They do fine. It's a 10% of those PFO that actually go on to have either migraine or stroke. And the reason is because those neurochemicals or the tiny clots, instead of getting filtered in the lungs, get, going directly to the left side and to the brain. So this is a very, instead of a normal hole like a ASD or VSD, we call this a flap because you have a little curvilinear, track between the two flap that never fused. Normally it fuses when the baby comes out and cries. So the evidence in this has been, like I said, a journey of 25 years, multiple trials between the two big devices that is out there. One is Amplager, one is Helix Gore. And again, for a lot of time, I had the pleasure of being part of a lot of those trials. We didn't know, there was, we always said for a lot until 5 years ago, until you have a recurrent stroke, you have to have a recurrent stroke. We don't do the PFO closure. This study, TCT 2012, was published, and again, later in both cardiology and neurology journals. And that led to the approval of Amplager and later the Gore device that's showing on the bottom. They come in different sizes. The bottom line, again, there's a lot of data over a 20-year period. But the idea is you have to have a large hole. You have to be a young patient because the older you are, there is more reason that you might have another reason. We call this a cryptogenic stroke, but we always like to make sure we rule out the AFib. As I said in the first part of the talk, it's the more common thing. The one thing that we used to do monitor, 30-day monitor, but data shows that 90-day was the gold standard to define occult AFib. And that link monitor that we have now, and two companies make it, it's a little implantable chip that we put under the skin. It can stay up to 3 years. And the data shows that if they're a little bit older or if they have risk factors for AFib, we should wait at least 90 days to make sure they don't have occult AFib before we blame it on the PFO. We do make sure they don't have hypercoagulable disorder. The bottom line is it has to be a large hole. The patient has to be young with no other medical problems. And in that situation, the advantage of closing the PFO over continuing medical management, which will be a blood thinner, there's 75% risk reduction for recurrent stroke. Again, when you have an aneurysmal septum, that picture that I showed in the beginning, if you have the two flaps going in two different directions, it's called the aneurysmal septum. Patient now at the Epic read the report and they get worried so much. We get called that I have an aneurysm in the heart. I think that's the misnomer. It really, scares people a lot. But the idea is if you have that, your risk for stroke is 10 times bigger because when you're taking a deep breath, that hole, because the flap going in two different directions, is bigger. So this is the November 2016 final results of RESPECT coming out. And again, but this is where, just like on the valve side, we do a very good heart valve team discussion between cardiology interventionalists and surgeons deciding which way we should go, open heart or catheter way. I think the PFO team, which we do a great job here at Baptist, between the very collaborative relation between the cardiology and neurology to make sure it's actually true stroke. It's not, mimicking like a complex migraine, and what we should do if they need closure. The procedure is, again, so last slide on who are the appropriate patients. I kind of summarized earlier. This is a busy slide, but bottom line is if they're young patient, they have a large stroke, and their MRI evidence of a cardioembolic stroke, so multiple different territories. And then, like I said, the atrial septal aneurysm or Eustachian valve is increasing the risk of stroke 10 times. There is a ROPE score. Again, it's a little app that you can all have in the phone. We try to document it. The higher the ROPE score basically means they're a younger patient. There is no other reason for stroke. Those are the ones that probably get more benefit. The procedure, again, used to take longer. Now it's more 30 minutes. We do this one with intracardiac echo. So we actually coming from the vein with a little catheter that's sitting inside the right atrium showing the echo. So we're not doing the TEE like the other case that I was showing on the appendix occluder. And And we put, again, they come in different sizes and they're usually going home in 6 hours. At the end of the day, I think it's very important that everybody is different. We take every case into consideration. But advances, innovation is happening. We better acknowledge that. Learning and innovation go hand in hand. The arrogance of success is to think that what we did yesterday will be sufficient for tomorrow. This is our structural lab at Baptist. We have a great team of physicians and the team that takes care of people in our clinic and post-op. We are the highest volume structural heart program in the region. We have done pretty much a lot of first in the state or the region or the country. We actually did the first amulet, like I said, in Southeast US and from our own Baptist, and I televised. This was in Washington, DC for our International Interventional Cardiology Conference. 9:45.
Thank you very much for that great talk. It's great to see the innovation and advancement for our patients. Just a quick question. So just practically speaking, we have a patient that cannot take oral anticoagulant, bleed or whatnot. They just had a stroke. How early can they use a closure device? And also, can we now do it without anticoagulation, or does it have to be enrolled in a trial?
So great question. So I think there are two parts to that. How soon can they have a procedure depends on if they had a stroke, embolic or hemorrhagic. So I would usually look at you all to give us the clearance, because when we do the procedure, we're giving a bunch of heparin because we want to make sure there's no clot forming while even that 30, 40 minutes we're sitting inside. So the ACT is close to 300. So how soon we can do it, I usually feel like depends on if it's an embolic event, ischemic or hemorrhagic. And again, you guys guide us. We want to make sure that we get a clearance from neuro before we put the patient through that high heparin dose. Post-op, as I said before, the standard was 6 weeks of blood thinner. Now, I usually prefer amulet on the patients who have neuro issues, so that way we have more data on aspirin Plavix. But if for some reason they get a Watchman because their anatomy is more suitable for that device, there's also data for aspirin Plavix. But again, the duration of aspirin Plavix is almost 3 months standard now in Europe, and 6 weeks. Like I said, FDA has approved the study and it is CE marked. So I think that's where I feel like, because Plavix, we know that it still can cause bleeding. So I think I would prefer amulet, because if it doesn't heal, that's where it comes it bites us in the back end, right? If we cannot do that small or brief duration of blood thinner, they can form clot just like stent on the metal, and that's not good. So did I answer your question?
Yes, thank you. Any other questions? Go ahead.
Good morning. For the hospitalist and primary care team, this could be like a simplistic question, but what is the physiologic function of the left atrial appendage, and what is expected to be seen in the future? I mean, after a Watchman device is implanted, what do we expect to see physiologically and after they get the device?
So great question. So patients ask this question all the time, but so the function of appendage, we survive fine without the appendage in the short one. There are two things that we're still studying. One is, does the appendage have, appendage also causes AFib. A lot of times my EP colleagues, when we're going to try to ablate the AFib, they actually also go around the appendage. Nobody goes in the appendage. It's like, now we're doing sometimes TAVR through the carotid artery. And the first time we started 4 years ago, we're like, what do you mean? All this time we thought we have to stay away from the carotid. Now we're putting large bore seed doing TAVR through the carotid. But the appendage can cause AFib. And so sometimes the treatment also, actually, my EP colleagues will want me to do the closure device first. So that part is taken care of. And then they go in and do the pulmonary vein isolation. So it's a source for AFib. There is some data that it can maybe help with heart failure or compliance. But what we know so far, that we survive fine without it. The biggest, just like appendix in the belly, we do appendectomy, we're fine. I think the second part to your question was, what are we looking or telling the patients who have this? Once it's endothelialized, it's a one-time procedure, they're done. The studies, the follow-up is 1 week post-op, that's 6 weeks or 1 month TEE or CT scan. And the 1 year, either CT scan or TE. And once it's endothelialized, we don't do any further study. Once it's done, it's done.
Thank you.
Good morning, Dr. Satpathy. Thank you for your great talk. This is kind of another primary care question. So, of course, across treatment spectrums, people do things a little bit differently. And what I've noticed that when people come out of the hospital with a diagnosis of TIA or stroke, that sometimes the workup seems to be a little bit incomplete, where they may not have had an echo or echo with bubble study. So when I see them back in the office, I'll usually order a Holter and an echo with bubble study. And I was wondering, one, is there anything else from the primary care perspective, if the workup hasn't been as complete, if that we should be doing on a primary care standpoint, looking for the causes of the TIA? And also, is there a reason that you think that the echoes with bubble studies aren't done in the hospital when they're getting them, and sometimes not even an echo? So if you can just speak to that. Thank you.
Sure. So I think what we should do for a stroke workup, and again, I think we together, Nima, remind me, maybe about 6 years ago, developed this protocol at Baptist to combine cardiology, neurology to make sure that they get that workup done.
Yes.
Our hospital is at 95% capacity. So sometimes we're trying to get people out. So I'm wondering if that's the reason sometimes you're seeing on the back end that some studies are not complete and they're going home. But ideally, what they should have, if they come in with a TIA or stroke, and obviously all the brain imaging to see what, where the focus is and if it's ischemic or hemorrhaging and location. Carotid artery, we just talked about that in the last case. From the cardiac standpoint, a regular echo, we always do a bubble study to make sure there is especially young person. It's a part of the protocol. We ignore it if there's more than 75. If they're younger, that goes to the next step. TEE, if we think it's a cardioembolic, they should get a TEE to look at multiple things. Make sure that how big is that PFO? Because on a transthoracic echo, all you see is, yes, bubbles crossed, but bubble can cross for multiple reasons. So it could be a PFO, but it could be a delayed pulmonary shunt. It could be a pulmonary anomalous venous connection going into the wrong chamber of the heart. So we need a TE to see why there is a bubble study positive. The grading of the bubble study is very important. I didn't go into it. Grade 1 is less than 10 bubbles. Grade 2 is 10 to 20. Grade 3 is more than 20. And we're looking for everything crossing in those first 2 or 3 heartbeats, not 20 heartbeat. If it's 20 heartbeat, that's called a delayed bubble study. That's usually coming from the lung. That's intrapulmonary AVM. We don't need to chase those. The T is also helpful if they have a left atrial thrombus, or sometimes they could have, if they have a rheumatic heart disease, they could have a mitral valve problem or aortic valve problem, and they could have, especially if they're a little bit older, we know bicuspid valve, and that could be another non-LAA thrombus. We also can see on echo the plaque on the transverse aorta. They're common grade 1, 2, 3, 4, 5, which is again another cause of atheroembolism. It is, between the carotid and the heart, but it can happen from the aorta. They should get a monitor. If they're young, usually less than 60, we're okay with the event monitor. If they're more than 60 and they have multiple risk factor, they should probably have a longer monitor that I mentioned about the link. They should have a hypercoagulable worker if they're a young person. The why it didn't happen is not happening on every patient. I think we're a little bit stretched thin and trying to get people out of here sooner. I know in the post-COVID world, we all are struggling with staffing. I know on the echo area, we are short-staffed, but we just filled, I think, all our echo. So sometimes people are going home without an echo, but it shouldn't happen.
Yeah, but I'm just gonna add to that, Ruby. I think we gotta use what we have, right? We know this patient is ready to leave the hospital. There's no reason for this person to be 3 days waiting for an echo in the hospital. We can do that as an outpatient as long as it doesn't fall out of the radar. So I think you're going to see that more and more. And we're trying to. There was a nice talk on Wednesday, Keith from Chicago talking about how to optimize this outpatient scenario for stroke management, TIA, same day clinic, and those things naturally go through primary care and cardiology.
Yep.
We gotta stop the lovely discussion. Dr. Sapath will be here. Thank you. I will
Thank
come
you.
back at 10:15.
Perfect. Thank you for
Thank
having
you.
me.
Knock, knock. 10:15 sharp. This is a conference that we have a lot of frequent flyers and close friends to us and to Baptist. If you guys don't like anything that I do, you can blame this guy right here because I came to the United States and I landed in Buffalo, New York in 2001 on July 3rd. 4 days after he left Buffalo out of his residency fellowship in Buffalo, Demetrius Lopez, Professor Lopez, Dilo, is the guy that got me to Buffalo, and I built my life and career after that. So it's an honor to have you here. I think every single iteration of this that we did, he has been with us. Learn a lot from him, share a lot of personal interest in the develop of new technology and innovations and how to make the world a better place. Thank you for being here.
Got it. Okay. So I cherish a lot to be here and I appreciate the invitation to be back. Today, the topic is about AI and in where we are with this. As you know, we have a system of hospitals, so AI became almost essential for standardization of stroke care. And I feel that some of the things I'm going to discuss with you today are the obvious things, but I also want to share with you a little bit of where we are thinking as a system, where AI is going to fit and how we should probably all be thinking about. So we'll have some challenges to our concepts that we have today. We all are familiar of the use of VisAI Rapid for the detection of LVO. So this is something that is very much available to all of us. You can do aspects, you can also detect intracranial hemorrhage, you can detect subdurals, you can detect aneurysms today. All this is commercially available and we use this. What I'd like to share with you is we are running now in the background as a research pre-FDA trial is the use of LVO detection without contrast. So if you do a CT, a plain CT scan, if you look at the workflow that we normally have, we do the CAT scan. Many times you bring the patient back to use to do a thrombolytic if it's within the window, and then you're going to bring the patient back to do the CT with contrast and CTA, CT perfusion. There's a time that takes for that to happen. And if you could shorten that and have the decision of thrombolytic and LVO detection and potentially workflow calling the interventional team on the first plain CAT scan perhaps would be an advantage. And that's what this is. If you look in most hospitals, this may shave off about 30 minutes within that decision of avoiding do a CTA and just going from the decision on the CAT scan only. And this is also important in countries that don't have the accessibility to CT perfusion or CTA even. This may even allow those teams to start screening patients for LVO on a plain CAT scan, and perhaps more people globally can be treated with stroke because you have a way to detect more efficiently. This is some of the initial data from Barcelona team. They're showing to us that using the methinks algorithm plus NIH, you actually increase your sensitivity of the LVO detection. And this is some of the numbers on by location also. And it's pretty good. I think we struggle with posterior circulation, but the anterior circulation, it's actually very reasonable. The methinks LVO algorithm, especially if you add the NIH score to that. We did a similar simulation in our hospital system, and for sure we saw that we could gain about 30 minutes based on this time difference between CT and CTA. Another very interesting use of AI is going to be the detection on the field of through a step of different movies that you do. So very target movies to focus on face, arm, and speech. You're able to actually detect and this is here, you're basically detecting the change in movement between both sides, and you're basically measuring how much movement you have. But this type of short videos are sent to a cloud, and then there is a algorithm that actually gives us back an NIH stroke scale, or you could tailor this to FAST-CD or RACE based on the videos that you're sent from the field, and give you a very high accuracy on how much that patient has a likelihood to have an LVO based on the neurological exam, or NIH in this case. And you can see here the accuracy compared to a neurologist. It was incredible. It was very significant to using now. You had, it could be in some concepts, I think in Denmark now is being used potentially by bystanders. So if the population has this, and they obtain the videos following the app that has this type of connectivity to this algorithm, allows then to almost anyone activate a stroke code based on a high likelihood that that's an event, that's what's happening. So now you have these image data sets that can be used also to compare with the patient on recovery. So after the patient comes out, this is just showing now 400 patients, how accurate this was, and in detecting stroke versus not stroke, as well as detection of LVO or no LVO on the field using this app. So this is really exciting, but imagine that you could also tag along with videos done on the recovery, on the post-hospital care, and you can see the actually improvement of the patient in a very objective way without using an MRS score or something like that. So you can actually use a video to detect how accurate the movement of the patient is, how fast that movement is. So you're basically assessing that. One of the, this is now from the team of Nicolab, and they have, they're looking to a future launch of AI assessment of clot, the permeability of the clot, and the consistency of the clot. So that can help us on a non-invasive image have an idea of to estimate what the clot is. I love to see what Matt has to say about this, but it's an interesting concept to be able to decide which devices may work better when you do the treatment. So now you not only know that it's occluded, but you also are calculating the what device to use. Here is another exciting development by Nicolab is the ability to predict core and penumbra using non-CT perfusion, so just on plain CT or CT with contrast. So you're not using the CT perfusion algorithm, you're actually using that only with CT and CT with contrast and predict core and penumbra sizes, which could be increase the use of this technology in countries that don't have those softwares available. Now, this is where I wanted to kind of shift gears a little bit and share with you that when we work in a network of hospitals, but almost in any type of setting, what has happened is we have AI for many types of detection. So you have today for spine fractures, you have AI for cardiac, for chest problems, orthopedic, neuro. We talked about there are over 20, 25, 30 algorithms that you're going to have to be dealing with. So how do you manage all these AI and different types of vendors? So I think that the concept, and this is something come from iDoc, but I will share with you a little bit what we are doing in-house. But there is now this AI of the AIs, or some kind of manager to orchestrate all this type of imaging. So you acquire an image, doesn't matter what it is, at any time, and that image then goes through this box that has the ability to identify, is there an abnormality? It doesn't matter what part of the body, it doesn't matter what it is. And if there is an algorithm there, it will then basically detect that it will prioritize those images that have the abnormality to the area that you need to go to. So you're going upfront, is screening for abnormalities on all the images that you're doing, and then that will assign the AI that's needed to interpret that abnormality. So it's almost like a filter that is looking constantly, not in the cases that you will know, I think I have a stroke, I'm going to do a CTA. Now this is any patient in outpatient or inpatient that has a scan, and if it detects something abnormal, it will then run the AI that you need it to run. So it's almost like the way they put it, it was very interesting because you have this Neuro AI 1.0, which is you have a specific AI for each type of disease versus having something that is screening for everything and then assigning the specific AI algorithm that you need to. And this is called a basic image-based orchestration. You're going to hear more and more if you talk to IT guys about this. Imagine that you're not only doing this one image, but you're detecting LVO aneurysms. Maybe if there is a spine fracture, all that is being seen and then assigned and sent to the team, to the PACs, and to the different parts of that. So we are going the same way in our system. The other complexity we had is how patient images from the OR, from the endoscopy suite, from the OR, and all the radiology, all the silos, they can then come together and be linked to one archive system so that it's linked to the patient. So this is really important, is that how you have not the information of the patient fragmented through all the different silos that we have. And then because you have these images, it could be a video from the field, like I show you a CVA solution. You have that video connected to the patient, and then you can actually retrieve that because it was stored from the beginning, linked to the patient. So it doesn't matter if the image is only CAT scan, it could be a video, could be something else coming from that patient. But all that then is linked to the patient in a way that you can assign to the correct algorithm, and then you can get the information to who you want it to go. So there are different solutions for this. I showed you the one earlier from iDoc. This is include products. So there are different types of companies working on this. But the idea you can see here is how to get the image, any image 24/7 to the right algorithm, and then back to the teams that are going to be using that. Why that's important? Because once you have this, imagine that you can also, part of this is to create a diacom router that once that interpretation is done, you're making the clinical decisions. There is this barrier between the research and the clinical world, and you can anonymize all these images and bring that to research. And then potentially you have the ability to go in and out for pre-FDA algorithms and things like that, and then get back into your system. More than that, you can also start thinking about how this is the complexity, how this looks like in our system now, but it's really interesting in a situation like this. If you have a patient, a 45-year-old with a lung cancer, and you have a certain treatment that you're using, you are actually able, because the data set is connected to the electronic medical record, you're not only getting the image data file, but you're also getting the clinical information with that patient and the treatment that's been used for that cancer. You can actually go and compare that to all the other patients like that were treated to see in that specific patient-specific clinical situation that the treatment is effective or not. So this connection with EMR is key, having these images all connected to the data. And then you can see this little nodule there, how it will respond and how you can compare to other networks that are in the same consortium that is using this type of data sets. But you're seeing that we're creating a very clean data set of patients that are compared apples to apples, and very much like you can actually expect to have better data on outcomes because you're now comparing patients that are more alike clinically and imaging wise. So I think that this is really the goal to this. Now I'm going to walk back here. I'm going to show a video to you. Dylan, let's do the video now. And so AI part, it was one issue of how to manage image. The other thing I want to show you is, and this is brand new, I hope that we haven't shown this before, but it's a concept of how we bring to the Angel Suite our simulations and the best way possible to use the data we're getting during our procedures. So we're going to bring this up now as here it is. So what we did was basically, one of the issues was every time we had simulators and we didn't have the ability, they were isolated in the basement of the hospital, they're getting dusted. So we decided to bring this to the Angel Suite and create a workflow that you're able to do the 3D printing, you do device-specific simulation, and we do digital simulation all within the same solution. So it's a partnership between Mantis and Siemens. You get a spin like this, and so you're doing the regular angiogram you do. This is an Iacono room, and you can see that now you have these three options. You can send for a G7 stimulator on the left. The middle is Ankyras, which is device-specific simulation. And the third one is a case rehearsal using, in this case, is a previous VASC-Sim simulator. So all that is integrated. This is actually the G7 platform is in the Angel Suite. And this is now the 3D simulator also in the Angel Suite. So they're actually brought in the all the stuff that used to be separated from the Angel Lab. They're actually inside of the Angel Suite. And I think this is an example. We're going to show you a little bit how this works. But so we do a 3D data set. And then with this, we're able to get into a basically just a USB. There's no yet a connection directly from the Siemens, but this is how we do. We basically connect there, get information from the Iacono. And this data set now, the first thing I tend to do is to bring it back. And then on the back table, I have a G7 there. There's a little coffee mug there too. Then you are able to build this case, and actually the haptic simulation is actually on the fly. You can actually do that during your case. You just create a new teaching case out of this. But look at how you stitch the intracranial anatomy to the previous arch. So this is the only part here that it will be, this is the imported data set. We just got it. Now you're going to be able to stitch that to a previous anatomy of the aorta and everything else. But as you're doing this data can be used also for simulation of a device-specific simulation. So this is how you edit and you stitch to the normal anatomy of the arch and everything else. So now you're going to have basically a whole place that you can navigate digital devices into it. And I think it's very interesting to be able to do this on the fly like this. And then you can try, obviously, this is how the stitching process happens. I don't know if you've ever seen this before, but this can be done right there and then. And you can connect to that. And you see this is a big aorta there, then you just stitch to it. And now you create your own patient that was the same case that is on the table, or you just acquire the image there. And that stitching is relatively simple. You can see how fast you can get that done on the fly there. Now, I think that this is really interesting because these data sets potentially can be used for in the future for robotic navigation and other types of planning. So not only planning the case, but also how to tell your robotic system to navigate in an anatomy like this. So that's it. Basically, you're done now. So I'm going to move forward here and then show you a little bit. So this is now, I don't know if people are familiar with this. So I now what this does allows you to get you can try it out. Now you're basically navigating inside of that anatomy. And this is now a case. You have the vital signs on the left, and you can use your Angel Suite to move the C-arm and actually simulate the case. And you're basically testing that out on that digital model that you had done. This is how it works there. You can see us moving. And this is Ankyras. I don't know if you're familiar with this. We've seen a lot of sim and cure, but this is a little bit different. Look at the same case, you just import to that. So it's going to be a device. The devices that are available are very different than the ones we see. We see here a lot of devices that are not available in the US market yet. So it really gives you a perspective if you need to call a device from abroad or do something here. I'll move this forward a little bit. So now this is on Ankyras. You do the center line, and then look at that. You have the measurements of this anatomy all in place. And here is talking about the diameters, but look at this on the devices here. There, look at this. So these are, you can, the Revos there, you can go to, on the left, you can do the Revo, you can do all kinds of bout devices, Phenox, they're all available to you, as well as Medtronic, Stryker, and Microvention. So you can see, you've seen this, how this is done. Normally you can have an idea. Now you're actually simulating how this device is going to expand in there, how it's going to be. There's some challenges of sizing, and you actually can do overlapping devices on this software. So it's really cool for that. You're looking at porosity, the sizing. So now you're not testing your skill how to place the device like you did on the digital, the first example. Now you're actually seeing which devices that are clinically available that you can use on this anatomy and where you're going to land that. And obviously, if you have, this is now telescoping flow divergence, which is a unique feature of this. And then the last part is this one here, which is the physical simulation. So the use of, it takes about 2 to 3 days to get this back. So this cannot be done on the fly, but the same data set is sent for 3D printing. And then they will, you receive back. I don't have a 3D printer in my shop. You know, basically this is done outside and comes back to us. And then you're able to use this to actually deploy the device. This is how the 3D printing is done. And then here you see, now you receive on the mail, it's a nice little blood vessel of your patient case. And then you connect that to the, that's the simulator there. So you can actually see it's like a real, looks like the head part, the vessels are not floating anywhere. They're in a gel. And this is what it looks like on the simulator. And as we're doing the procedure now in deploying the device for real on that silicone model. Anyway, so this is what I wanted to show and challenge you a little bit on how do you feel, I guess the question is for everyone in the room, is if you feel the concept of how we get a lot of data and I think with OCT, which is the next talk, how do we use that data is a key part of it. And I feel that optimizing the workflow of all the images, the diagnosis we get to link to our patients and be able to assign that to be constantly screening for, there is a huge shortage of neuroradiologists right now. And there are a lot of challenges of how fast how many images you can obtain, how do you screen, and how well we use the time of everyone on this. So how efficient the information is. It was mind-blowing to me, the issue of getting patients' outcomes linked to the clinical, the EMR with the imaging is an extremely powerful tool. So I'm going to stop here and just see if you guys have any comments on this. Thank you so much for your attention.
Any questions for Dimitris, guys? John.
Thanks so much, Demetrius. It's really fascinating platform. There's one aspect is, of course, from an education standpoint and teaching. The other aspect is just the practicality of the simulator and rehearsing the techniques in advance of a procedure. At this early phase, where do you imagine it fitting in terms of implementing the platform? Is this part of the initial infrastructure that you would imagine that you would bring into the angio suite? Are these on case-by-case basis? reimbursement, cost, expense? And any thoughts about that in an idealized setting?
I mean, I think that that is part of the why we brought it to the Angel Suite. We felt that this technology was not being used as much because it was very difficult to take the time to go to a specific lab to do the simulation. So what we're noticing is now that is in the Angel Suite, we are getting to use that more. So the idea is to incorporate that in your own workflow. Now obviously the speed how things is improving as integration between the different types of parties involved, imaging companies, device companies, and all the simulators. I think that needs a lot of work still. And so to get to that, what I showed there, it does take some effort to be able to integrate all that. But once it becomes more seamless, I think that the pitch to do we do a trial that people are using versus the ones that are not using simulators? And if you think about new technologies, when you introduce that, this is really, I think there will be a tremendous differential on the outcomes if you have the ability to, the amount of studying you do when you look at this way is much more than you normally would do if you don't use this workflow. I'm noticing that everybody becomes more knowledgeable about the case. There is, from the administration standpoint, the argument was always, can you minimize the opening of devices that you're not going to use? So I think that by knowing upfront a little bit of what to expect, you can actually, how many cases, we have so many supplies for different reasons and all that. So I can see a world that you start, knowing better upfront what to use more often, this and that. So do you need that for that? No, but I think that it's going that way. It's going to probably have cost savings and better planning of the cases, and that hopefully will alter outcomes too.
Cheers. Amazing as always. I have a stupid question, a boring, pragmatic question. So in our lab, we have 3D printers and we do these things. We have a collaboration with Mentis as well. And just to validate what you're saying, the only time we do physical simulation is when we've failed, right? So you had a patient on a table, failed access, failed device implant, whatever. What's interesting about our experience with that is that we can reproduce that 100% with simulation. The only reason we don't do simulation, so the value is there, right? And then you can figure out what setup is going to get the job done. So the value is unquestionable. Where we struggle is the economic problem, right? To be able to simulate before every case with the different devices that are available. And I'm just curious, do you have any ideas how we solve that problem?
Yeah, so I think the issue for me would be obviously the simulation depends a lot on the data set you get to be able to simulate as accurate as possible. The one thing that I feel if we could get from early on CTAs, MRAs, so the data sets being as early as possible on the case and have the ability to plan that up front, it will prevent a lot of the headache to have to do after a failure to do that up front. Maybe it would justify the cost based on the more responsible and efficient use of the devices and the time in the Angel Suite. I tell you, every time we do this, it seems to shorten the case tremendously because you plan a lot. So if you're in a busy lab, this is efficient. This is a good thing to have that you want to, but the key part is that you don't want to delay your case to do the simulation so much. So the workflow here, I think what's missing is we need to get these data sets up front from all kinds of images we can make that work. Then we go to the Angel Suite with this much faster plan. But it has to be integrated in a clinical scenario. I think that's going to be very important. If you have that separated in the basement somewhere, you don't get to use as much. Thank you. So we're past next. Should we go or we have 3 minutes?
Do we know, Abby, if Victor is ready? Perfect. So can we get Victor on the screen? So I think you guys saw Matt was perfect time what he showed this morning about optic coherence tomography. And very, very proud to say with the support of our Baptist Foundation and cardiology team, we have a machine now. They're going to be engaging in research using optical coherence tomography and looking forward for Gentuity to get this intracranial probe approved to us. But working with Matt, Demetrius, and Vitor. Can we get Vitor on the screen, guys? We witnessed the first in-man use of this tool that is the new generation of the Gentuity OCT probe intracranially. I think Demetrius, you are very involved with that, Matt. So I'm glad to have all of you guys here with Vitor that did the first cases together with Pedro Lilik from Buenos Aires. So I would love you guys to take from there and show to us this new frontier.
Hey, Vitor, how are you?
Hey, I'm good.
Good. We feel
I'm
like
missing
you're
the
here.
party. I'm missing the party over there. Sorry.
No, we're very serious here, actually.
So the party
Vitor,
is the conference. I'm not saying the party afterwards.
I see. Vitor, so I will, let me have my slides set. I will introduce this and then I'll pass to you. Give me about 10 minutes or so, okay?
Good, excellent.
Awesome. So let's have the slides, the second set of slides. So yes, this is, I think you've seen some of this concept. We've been talking about this for the last 8 years. Next slide. I think the new thing today is we likely will change the name of, when you say HF OCT is a mouthful. If I even try to pronounce optical coherence tomography in different languages, everything, it just sounds a huge mouthful, but there was a lot of hype and there's a lot of preconceived ideas of what OCT is from the cardiologist side. But I have to say, this is a new, I think the separation between the OCT experience in cardiology with what's happening in neuro will be a key part of our success. So I think you are now early on this, you were hearing us still maturing how to call this technology, what's the best way to address this. Earlier today, Matt was talking about macroscopic view, and there are different ways to look at this. So let's just step back and see the initial experience. This slide shows a lot of things we are expecting that this could do. Whatever way we call HF-OCT in the future will be the fact that it had to have the ability to access the anatomy of the brain, safe to do. A lot of things that you see in this slide, actually, they were all met. These were all the criteria that we wanted to have, and we saw that happen in the first, I believe, 31 cases. Next. Oh, I think I left my control there. If you could just pass for me. So this is the platform. It's basically connected to your Angel Suite. This is the VIS-M platform. There is a Pro for neuro and one for cardiology. Next one. And this is the size. It's very much the 14 wire, similar to a synchro wire or any 14 wire that we're very used to use. This is basically it's a light source, so it has to have the differences that before we had a catheter that was placed, the previous OCTs, and now you just have this wire-like catheter that goes and moves through the anatomy. I'll show you a little bit of a video of how this looks like, but this is some of the characteristics I'm sure that Matt showed before, but I want to just show you a little bit of how this works. So you inject, in this case, contrast, and that device moves through the anatomy. You saw that wire moving back with the light source, and the image is acquired in an incredible speed. You can see here how that is, and look at the number of images you obtain, and this is exactly the challenge that we're seeing. But because of this high speed and a lot of frames, you are able to actually use less contrast than you would normally use if these were going to in a much lower speed. And so the pullback speed allows us also to deal with the Circo-Willis challenges of collaterals and so forth. We saw the microscopic appearance, and this is why it is so exciting for neuro. But one of the things we were looking was pathology characterization, device sizing. This is something we talked earlier today. Do we have the best way to do the sizing of our devices? So this data set is incredible for that. And we can monitor the treatment and the response that to every new device and everything that we're implanting in the vessels, how the healing happened in a macroscopic way. certainly the idea of predicting outcomes by having how a device is opposed against the wall or against the neck of the aneurysm, that is also an incredible application for this. So the team got together, and I have to acknowledge, of course, everyone. I think Ricardo has been a huge part of the team too, and we are like we had to do a lot of this work, and I think UMass was and Matt, Vanya, you guys. Giovanni, you know, these guys have been instrumental on getting us prepared to do the clinical work, because we could not figure out, these are so many things, not about the imaging only, but also how you do the pullback. So here you see what microcatheter, how you're going to deliver this, and what is the contrast volumes that you're going to use. All that had to be sorted out up front. And finally, then, I'm going to share, these are the cases from Pedro Lilic in Buenos Aires, and Vitor, of course, will show the cases in Toronto. But I think I'll start with a case that I think was, for me, extremely amazing to see for the first time, an acute stroke. So patient came in with an age of 7, and it was about 6 hours post the Lacine normal. And you can see the occlusion, and now you can see the DWI images pre-treatment, and this is flare, and this was the mismatch, and here is the angio suite. The decision was go to do a thrombectomy. Unfortunately, during the thrombectomy, this was not an easy one. There was this is a Trevo stent retriever. You have an aspiration, a CAT6 brought to the M1, as you can appreciate here. And this case was done first pass, and you see the result of the first pass. It was not recanalized. So there's still occlusion after the first pass. Now, second pass, third pass, fourth pass. So this is the ideal case if you think something is not working. You know, Matt, we're just talking about this. Could you simulate, if you knew more about the clot up front, could that have helped picking a different device? What is going wrong here? Why what normally works in the first pass and the majority of cases, now we're down to the fourth pass. So having ability to, in this case, eventually they were able to get a TK2A. The question was this, what kind of clot this was? Was it a problem with intracranial stenosis? Was it a dissection? And I think the ability to image this patient, now that, of course, the CAT scans are done post-op, patient is recovering. But in this case, about 6 days later, the patient was brought back to the industry. This is the angiogram you see. And then an OCT is done at this time to see what was there an underlying problem in that vessel that could explain why it took so long. So here you can see best, you know, very good images from, this is a Philips equipment, and you can see maybe there's a defect there on that M2, and what is that? So this is how it works. You can see the lab, and on the right lower corner, you see the unit, how you connect that wire to the console, and you can see the workflow of the team going up and navigating what, you know, is very common to us, the profile of the microcatheter and the size of the OCT wire is really within the expectation of flexibility, navigability that we see with our devices today. So you can see on the top left, the catheter in position and the placement of the inside of the microcatheter. You have the OCT imaging probe, and that basically allows you to not go naked. You don't travel with this alone. You actually go inside of a microcatheter, you're already in position. So the risk of patient is very minimized that way. And this is now how you're acquiring inject contrast, and you see how the pullback, the wire just moved down from the M3 down to M1 area. So you're imaging all that area, and this is what it comes out to be. This is what you see. So here you are seeing that there is something in the vessel lumen, and the angiogram was showing that there was something, but here now you'd see it's not a plaque. It's actually is not a dissection too. You see a little bit of the integrity of the vessel wall, and you see that there is a material that it likely is a white thrombus based on the characteristics of the OCT. So this is very much answering the question of do you need to do, what is the next step you're going to go from here? So you could potentially argue that this was a very important information that could have been done even in the day of the thrombectomy to try to figure out what is your next move? Do you keep doing stent retrievers, or do you change your device to a different approach, or medications or so forth? So I thought this case was incredible. And on the same line, within those initial cases, I think we all expected that the use of flow diversion and the would be one of the main applications of this to see malposition. So obviously here we all use, sometimes once you deploy a flow diverter, use a guide wire to go back into it to actually expand the flow diverter. And this is showing before and after this wire massage we call. It's a guide wire, as opposed to do an angioplasty, you go with the guide wire back. Here you actually can document how much the flow diverter increase in size or increases a position after the massage. And now, interesting case of MCA bifurcation that will allow us to see, there was a question in the carotid, the cervical carotid, if this was a fenestration or dissection or what it was, that finding on the right side image. So the initial, this is just the measurements of the aneurysm. This is now, I think what Vanya had shown us before is that look at the image, the second image from left to right. You can see here that you are seeing beyond the vessel wall. So because you are at the level of M2, and so you are really in the middle of the Sylvian fissure. And at this level, you're seeing a few things. One is the device chosen is called the contour device. So you can see the device in the image on the right side, the one that I hate to show only one side, but this one here, you can see the clarity of that device. In angiography, you would not be able to see that detail. It's just mind-blowing how well opposed or not to the vessel, to the neck, the aneurysm, but also what the subarachnoid space looks like around the blood vessel. You're seeing beyond the blood vessel just by having this type of imaging. So, oh, there you go. So now this is the concept, because you are in the M2 territory area. You're seeing a lot of what Vanya and Matt had described in the spinal canal in different areas. You can actually see beyond the blood vessel what was impossible to see before in the relationship of the Sylvian fissure to that. To answer the question of what was in the neck, that was actually a very bizarre looking carotid. And it turned out to be, it was an old dissection that was there. And that's what the answer was not a fenestration. And that what helped in this case. This is a case of a P64 used in a small choroidal artery. And this is another example of a 6-month follow-up after that. And there was a concern about stenosis on that. And there was a neo-intimal hyperplasia that was causing that narrowing. And that helped us to decide what to do in that case. And this is a case of an acute case that the flow diverter showed at the area of the neck of the aneurysm, the presence of a clot in that area too. So I will finish here. Vitor, I hope you're ready to go. The next thing I want to just challenge you is that perhaps by getting data sets like this, you can have a better simulation of, because you're using a better data to begin on the position of the struts. How can we then, merge that data, all this image that comes from OCT, into better simulation of what's going to happen down the line with that device? Definitely a question that I would love you guys to think about and maybe discuss after Vitor's presentation. Thank you. Vitor, it's you.
Thank you, Demetrius. So just to clarify, guys, Vitor practiced in Toronto. The case that Dimitri is showing is from Argentina. This catheter specifically is not FDA approved in the United States. I think for compliance, we just got to mention that. They have an equivalent for cardiology approved in the US, but in the US, this is not approved yet. Please, Vitor.
So thank you very much, guys. thank you, Demetrius, for the great introduction. And it's good that you have Matt already with you. So I want to show the beginning of the history with us here. So when it all started with this case, 72 years old, patient with high blood pressure, had a TIA in 2022, and we diagnosed this V4 lesion. And then after medical treatment, a month later, he had another TIA. So then we decided to treat him, and we did angioplasty. So he had another proximal lesion here at the end of V4, and that severe one in the proximal basilar. So we treated that one, and we did an angioplasty and we placed the wingspan. So after that, this patient started having or showing on the follow-up images on the CTAs, as you can see here in the second row, some dark imaging inside the stent. We thought could be a clot or could be an instant stenosis, a plaque. So we didn't know what to do. And we kept anticoagulating him and doing follow-ups. And you can see here at 6 months, that plaque was already there. So we had already worked with the OCT team, and we had visited Matt's lab to do practice using the new VSM that Demetrius just demonstrated to you. And with this case, we actually asked for special access, and we got it approved to actually be the first in-man case of this technology. And our questions here were really, what is this image? It's a clot, hyperplasia, new plaque. What is the risk? What is the stent? Inside this thing or outside? So, and we were really struggling to define the next management for this patient. And that's the beginning of our story with OCT. OCT is a technique used in different areas to see tissue. And from ophthalmology is probably the most well-known OCT technique, and they use to see the vessels in the back. And in cardiology, it's being used. So the first intravascular ultrasound in the coronary was actually done in 22. These are images here in the corner. So very rudimentary view, but they could already demonstrate the layers of the vessels, and they could identify plaque. And here in the second row, they could also do a post-procedure OCT that could identify the damage that the treatment at that time, angioplasty, was causing to the plaque despite reestablishing the vascular lumen. Since that, OCT is being used in cardiology with two objectives. One is to define a vulnerable plaque. So these are the criteria, and there are different ways of looking into the plaque and differentiate the plaque, look for inflammation. This is something that Matt has been talking a lot about, which is the inflammation, how we see inflammation in the plaque. And from our early experience, we've been looking and seeing some macrophage accumulation, and that's what it looks like. Here you have the OCT picture, and there's density where it shows where actually the macrophages are. And on the OCT, we see actually a dense imaging with a shadow. And that is actually how the macrophages will look like on the OCT. We will see some cases, and you will understand that on the neuro field as well. And also it's being used in cardiology to define the results of stents. So initially with angioplasty, that was showing the damage that we actually cause. And here is a couple of stents, well apposed, mal apposed, with a protrusion. And that has been all the work in cardiology. What I'm talking about OCT in cardiology now, before introducing our neuro, is that because a lot of people ask me about the OCT, why it's not used in cardiology, and why I think that this will be a hit and a big thing in neuro. And, my answer to them is that the disease that the cardiologists evaluate, and half of them now use regular OCT, represents only 5% of the diseases that we have in Europe. We have 95% of other indications for OCT, and the imaging of the vessel wall is actually crucial for the definition of some of our treatments. And we are not just putting stent to push a plaque, we are treating aneurysms, fusiform lesions. The etiology of the lesion, sometimes it's unclear. So actually, this is why I think, and I was always motivated and I was always watching Matt's lecture in the past and looking forward to the day that I would have this catheter in my hands and actually doing the procedures on our patients. And this is actually came to reality last year here. This is the setup here in Toronto of the OCT. There's actually a probe, that is the pullback probe, that it does the automatically pull back, and there is a catheter, and we actually connected the OCT probe just beside the bed. And we did some simulation before to define injection rate. So every first-in-man activity, we always come from simulation before. And then this is the team, and we define parameters on the simulation. And this is actually how the catheter looks like. And we did the pull. And the first case we did was actually the follow-up of the case that I just presented to you. And this case was actually very interesting because it showed that the stent was outside the plaque, and that the plaque was there. So there was this dark area. But what we can see is that the intimal was preserved. There was already a healing on top of the plaque, and there was not the plaque growing outside the stent. There was no signs of inflammation. It was actually quite reassuring. And this patient just came for follow-up a couple of weeks ago, and we managed him as a stable plaque, and he's doing fine. So, but we could also see is that we could evaluate the plaque, and we could also evaluate the stent in a very precise way. And as Dimitrios mentioned, we can have the measurements, the true measurements of the vessel with a precision that we cannot even compare with Vaso CT or even 3D array. So we will have a new standard of calculating devices and measuring the vessels when we will be using routinely this technology. And this is a picture of the stent, the distal and the proximal ends. So this is the strut of the stent, and you can see here, you know, it's almost 0.6 millimeter away from the vessel. And this is the other strut, and there is something here that can be a clot or can be just endothelial cells attached to the strut. And the proximal end, the stents are floating on the vessel, and there are some endothelial cells or endothelial tissue on the struts of the stents, but they, at least to my view, it didn't look too good. And this is, again, the comparison with cone beam, and the cone beam is not able to actually be that precise, demonstrating the apposition. So it was very, although I'm a big fan of Vaso CT and I do it routinely for every single case, I was kind of discouraged to see that the Vaso CT could not even show approximately what the OCT was actually showing. And also another aspect that we also explored and we realized was the measurement. Despite of having high quality post-processing Vaso CTs, the OCT can really excel on giving us precise measurements. And we also have some anatomical pictorials, like this is a perforator of the brainstem. And we can see here in detail the origin of it. And for some of my nerd colleagues, you know, this is the ICA, and we are always excited to see when the artery transition to all those perforators. And I think that we are looking into this with an anatomical view to actually start reporting the relationship between these vessels and the plaque. That will be certainly, with this level of definition, we will be able to demonstrate in a lot of details. So then after this first case, we could understand. So actually, we didn't know why the plaque was actually formed on top of the stent, why that all happened even 2 months after the procedure. This is a wingspan, the stent that was designed for intracranial ICAD. And this second case was a 68-year-old male that had a TIA, came to the hospital. We did an angiogram that in theory was to treat this carotid stenosis, and my colleagues have decided at that time that he didn't need treatment. They put him on best medical management, but he also had this intracranial stenosis on the cavernous segment. So he had another TIA a few months later, and on the CTA we saw a progression of the intracranial plaque, and still had this cervical one. And we thought that that could be a case that we actually, like the cardiologist, we need to see the plaque and evaluate if there is any characteristics of a vulnerable plaque to actually treat. So this is the stroke. When the patient came for the angiogram, we actually saw that the intracranial plaque was actually changing. So he had now an ulcer that it was probably formed in 1 month, because you can see here the CTA that showed the progression of this plaque. And in December on angio, we see this erosion on the plaque. So we had no doubts of which plaque was actually then producing those TIAs. And we have decided to actually perform the OCT. And this is what we found. So the first image here, just beside the angiogram, the first OCT picture, is actually a picture of what a lipidic plaque will look like. So you see that one part of the vessel, we can define the layers. We can see here endothelial cells, and then you see that the endothelial cells continue, and then you lose the definition of the tissue. And that is the sign of lipids, and then it decreases the signal. And this is what a lipidic plaque will look like. And in the center one, the second one from the left to the right, we can see the erosion. And in the erosion, there was already endothelial cells, although it was like less than a month, there was already some endothelial coverage. And we didn't see a sign of acute inflammation or clot inside the plaque, but you can imagine with stagnation, a clot could be formed at any time and embolize. And proximally, with the vessel partially normal and a plaque on the side, we could actually define what we called, so these two arrows are actually the macrophages that we saw, that I showed you on the cardiology slides. Here's how we actually see. You see this dense, hyperdense imaging with a shadow. Hyperdense image with a shadow is different from the other signals of the tissue. And this is what a macrophage will represent to us. So an ulcer without a clot, but signs of inflammation in a patient that had new symptoms. We decided to treat classically angioplasty and wingspan. So after this is how an OCT pull will look like. And just to give you an idea, it takes 2 seconds, and then we saw that actually the plaque wasn't looking nicely, was actually very, you see here, was crushed, the ulcer disappeared, but actually the plaque was completely mashed. We had few segments with clot hanging on the vessel, as you can see here, kind of a vascular mass that we could imagine, but now we can actually could see. And this is the vaso CT of the stent that to us looked okay. But then when we did the OCT, we actually could see that the tip of the stent, the distal end, was not completely closed. There was something from the vessel closing one of the struts of the stent. And actually the stent didn't cover anything of the plaque, was still hanging through the stent struts. And there was still clot on that. So, and I realized that that's probably the first patient I did had. And if I was keeping that plaque that way and with a stent that was not covering anything, I'm sure I would not I would have the same result. So I took an executive decision over there, and I actually decided to add another stent. I would not add another stent that would not cover the plaque. And we actually have decided to put a flow diverter stent because of the segment and because it was the only device that I had. I didn't have a balloon mounted stent here to put it over. And I have put a pipeline vantage, and this is the imaging after that. And you can see the flow diverter is actually pushing the plaque away, and you see the clots are all outside. We have already a 3-month follow-up of this patient, and it's beautiful, actually. And I'm not saying that a flow diverter should treat now ICADs, but I'm saying that the stents that we use for ICAD are not appropriate. And we should probably consider balloon mounted stents or other technologies that will actually be effectively pushing these plaques. So on the treatment side, I have done a flow diverter case. This is a 41-year-old with this recurring PCOM aneurysm. And we did the OCT before the flow diverter. We calculated the sign. This is the pullback. We could see the vessel. We could see the coils on the recurrence. We could see the origin of the PCOM, anterior choroidal. We then deployed a flow diverter stent. And after the flow diverter deployment, we could realize that the stent was not fully expanded at the level of the aneurysm. And at the level of the PCOM was okay, but at the level of the distal ICA, the stent was not properly apposed. I know that we have to define what is an apposition of these stents, but we actually decided to angioplasty. And this is what the vasal CT post-angioplasty looked like, was good. The angiogram was fine. And then when we did the OCT, we actually realized that there was a clot formation already, despite of effective antiaggregation. And you can see here the stent with early clot formation. So we actually put 2B3A, and we decided to reload the patient with dual antiaggregation. And we were very surprised because this was a very smooth procedure, angioplasty after stent to improve their position, with a patient with effective antiaggregation. And things like that may happen and we don't know. And this probably can be related to this fish mouthing or the issues that we've seen with certain flow diverters. So we actually, and this is my last slide. These are cases from us and from Pedro, actually showing that even on the diagnostic side, on the first row here, you have an aneurysm. And you can see the thin wall that can be now defined. We can actually see the wall of the vessels and the aneurysms and the layers. And I think we've never seen the vessels from inside with that definition. And for every single case we did, we actually learned something about the disease, about the technique, and about the patient itself. So I am very confident and that this will be a technology that will change a lot our view on devices, on treatments, and on patients. And I wish you guys will have access to this technology as soon as possible. And to my colleagues that still think that this is a technology that the cardiologists were not excited, and I can tell you that, hey, we will gain a lot with this technology in our field. Thank you very much for your attention, and thank you everyone that participated in this project, Demetrius, Ricardo, and Matt, that has been a big proponent of this technology, and thanks for the background work. Thank you, guys.
Thank you, Vitor, Demetrius. Any questions, guys, about?
You know, I started thinking about cervical spine x-rays in 80-year-olds, you know, and how terrible they are. And I'm wondering, what about the aortas in these patients? You know, we were seeing very small little abnormalities. I play golf with a cardiac surgeon. When he opens the heart, he's seeing all kinds of chordae that are broken off valves. He never touches them, but things don't look pretty. And, you know, what does the aorta, has anybody looked at the aorta in any of our stroke patients? I would think it might look like a mess with OCT.
So there's some technical issues with that because of the size of the aorta and the size of our imaging, as well as the clearance of the blood to obtain the image. There will be a little bit of a challenge to do that in that vessel size. But I think that the comment applies though for what we do with the information we get. Every case that we do, we saw things in a way that you just maybe imagine that could look like that. But this wingspan device, for example, how it looked like, it really changed and gives us the basis to, we need to do better or change this because it's not responding or not doing the treatment we expected to be doing. Based on the angiography, we had an impression of what outcome we were expecting to have, but by seeing more of that, now we see maybe we need to improve that procedure or do something different. I think that's going to be the way this is going to be done. I don't know if we always have to correlate with the clinical outcome. I don't think people are going to be changing only based on OCT. I think it will be a combination. It'll be one added information to make the decision, you know. And but I feel that there are a lot of unknowns in neuro. When you have artifacts from previous devices, OCT is a way to look from a different way without having the artifacts that we normally see on MRI, CT, or angio. So.
And I'm just going to comment on that, Tom. That's the debrief session that we had with Vitor after his case that we had the chance to watch. The question from the vendor is, where do you use this? I think the question right now is where you would not use this, because the risk of using this is super low. For sure, I think one of the things that we want to work on is how to integrate this. So 5 guys, 10 guys, different centers doing this, how to incorporate all this information. When do you react to the clot that you see in a flow diverter? When do you react to something different like the stent malposition that Vitor detects? So I think we're going to learn a lot, but that is, I think, is very exciting that we're going to be able to see things better, and how much you react to what you're seeing. I think that's going to be a very interesting learning curve.
I mean, there's a huge achievement to get here, to get these images. There are a lot of obstacles to how to navigate. The device had to go through so many changes compared to the cardiology device. And honestly, the experience that I had before was to use the cardiology system to do neuro devices, and it was just proved to be impossible to do that way. So we had to change a lot. So there's a lot of, Matt, go ahead.
Thank you. I just wanted to make a general comment. Demetrius, it's excellent that you pointed it out. There's a huge team of engineers who built this system. That little wire that you guys saw, there's 106 moving parts inside of it. This was not a trivial thing. But the general comment I wanted to make, I was on a frustrating call yesterday that Vitor knows about that I won't say. But what I want to say is the spirit of this meeting is innovation. Innovation, what Dr. Brott showed today, what Dr. Wong showed yesterday. When you're innovating and you're establishing how do you treat patients with carotid disease, how do you develop a resorbable flow diverter that does a better job, how do you develop an intravascular, it's a huge team of people, multidisciplinary, and Demetrius and Ricardo, Vitor and Peter. We've been doing this for years. We all got together in a very symbiotic fashion and worked well together from a multidisciplinary standpoint. And that's the only way to change the field. Can't do it alone. That's just a comment.
I agree, Matt. And for the steps that we have to do now in the future to improve the care of our patients, bringing new technologies, I think we should learn from our experience with OCT. I was very pleased to have all the support, and we prepared everything before extensively. So for the company, we did what they call the most successful first-in-man experience, and that is what it's a victory of us on the neuro field. So even the companies will see that we will do better in neuro, that we are now taking things serious, we work collaborative, and they will look and pay more attention to us than to other disciplines. So as we discussed yesterday with robotics, so now all the efforts will be directed to neuro, and probably also because we have the same level of commitment that we are having with other disciplines. And that was a very good way to introduce a new technology into our field.
Yeah, and fantastic work. Thank you, Vitor, and thank you, Demetrius. Quick couple comments. One is about accumulating the body of knowledge necessary to interpret these images correctly. Otherwise, will we all subject to confirmation bias when I'm looking at this image and I think, oh, is that endothelium or is that clot? And now, we'll naturally sort of skew towards our own biases. The other is there a danger of potentially over treating here? Where you looked at something there and you thought, okay, the stent is malopposed. It might have been just good enough on the vaso CT, and now we're doing additional steps that potentially come at higher risk, or are we avoiding a complication in the future? But just general comments. Thank you.
But these are we are discussing the same. So we have the privilege to all be at least 2 or 3 sets of eyes in every single case. This is also why the way we've been doing this first-in-man experience has been great. But certainly we are building a library. We have to understand these results and understand the relevance of it. So Matt had done a lot of groundwork on models and on animals. So we know a lot already, but for sure we will need to go through the different phases: an observational phase, a classification. We will need to understand what is relevant or not in terms of post-device imaging. And a lot of the technologies that we have, no one else that have access, no other field have access to that. So I think we have to be cautious. And I agree with your comment and understand first before making any assumptions, as the cardiac guys did for some of their images and experiences.
They know you talk too much. No, I'm kidding. We're all guilty of that. Abby is looking at the back, jumping. Stop. We gotta move on. Vitor, thank you, man. We know we can talk all day about this, and we will have more time to talk. I really appreciate your efforts, man. Demetrius is getting here a piece of Ponte Vedra from coming all the way from Chicago here. Your piece of Ponte Vedra is here waiting for you. You have to come from Canada to Jacksonville to pick that up. We're not gonna mail that to you.
I will come. Yeah. Thank you, guys.
Thank you, man.
Good luck.
Merci,
Have
mon
a
ami.
great, yeah.
Thank
I wish
you.
I was
Thank you.
there.
Obrigado.
Thank you, guys. Bye.
Thank you, man. Guys, this next session is for me is, with all the respect to the other speakers, for many reasons. And Jose doesn't know what's coming next, but we have 2 sessions in one here. One that Professor Jose Romano from University of Miami is going to be talking to you. And then right after, please don't go for lunch. We know the food is great. Everybody's hungry. But right after Jose's talk, we have a humble honoring ceremony here. So our Innovations Award come right after we moved from yesterday because of Jose. Jose has been a tremendous support of our team. We moved from Mayo don't throw a rock, Tom, to Baptist. And through University of Miami, we are part of StrokeNet. We collaborate with Ralph and Jose and the team on the Florida-Puerto Rico study, always discussing what can we do to decrease the gap. And Jose has put his whole career behind this. He's going to share with us. Thank you for being here, Jose.
Hey. Thank you for the invitation. Thank you for the kind words. It's great to be here again. May I advance the slides here? Oh, there we go. Okay. So we're going to go from very high tech to low tech interventions, but we believe that these are innovative and impactful. So I'm going to tell you a little bit about stroke systems of care and how data, how organization, how working together can get us to a better place in stroke care. Here are my disclosures. I do get some salary support through the Department of Health to the University of Miami, as well as some NIH funding. I'm going to touch on some of the accomplishments of the Florida Stroke Registry in acute stroke care delivery, in hospital certification, in pre-hospital systems of care, and a little bit on recurrence and readmission, and how policy plays a role in all of these factors. All of you know that stroke is a big problem at the global level. It is incredible. There are about 12 million strokes each year around the globe. Over 100 million strokes, over 100 million people live with a stroke. Our lifetime risk is probably 1 in 4 of developing a stroke. That is tremendous. And we used to think that stroke was a disease of older people, and now we know that at least around the world, 2/3 of strokes occur in individuals age 70 or younger. And the cost in dollars is enormous. It is estimated that perhaps up to 1% of the global GDP goes to stroke care and lack of productivity from stroke. The cost in human suffering is very hard to estimate. I'm going to switch gears and talk a little bit about Florida, because our state is pretty unique. It has some characteristics that make it different from other states. First of all, the population has grown enormously. In the past decade, we've had about a 15% growth in the population of Floridians. And this is from a couple of years ago. Now with our neighbors in the Northeast moving down to Florida, it may be even larger than that. And a lot of this growth has been in our population age 65 and older, and in the Hispanic or Latin American population. Now, Dr. Broad showed you these curves of dramatic decreases in stroke mortality, which has been incredible. A little bit concerningly, these decreases have flattened out a little bit, and in some areas there's been a little bit of reversal, including in Florida. So you see to your left, the counties that have had growth or increases in stroke deaths in individuals age 65 and older. And then on the right, you have the counties that have experienced the most increases in stroke mortality. And you see that a lot of these counties are in Florida, unfortunately. And that is why Florida system of stroke care is so important. So the Florida Stroke Registry began as an NIH-funded project back in 2012. And it was focused on trying to identify disparities. And at that point, we focused mainly on in-hospital delivery of care disparities. We had some hospitals in Florida and some hospitals in Puerto Rico that participated. When the grant finished, with grassroots effort from many of you in this room, we went to the state, and the state agreed that this was an important issue and decided to fund the Florida Stroke Registry. This has now grown to most stroke centers in Florida, and we have now expanded not only to the in-hospital metrics, but also some EMS metrics, some post-acute and post-discharge metrics, which I will share with you in a few minutes. And this is more than a data set. It is really, let me go back for a second. It is really a collaboration to try to improve care. It's a quality improvement project. It's an educational initiative, and I will try to show you in the next few slides how that looks. But before we go on, and I know that we'll talk more about Ralph in a few minutes, but Ralph Sacco unfortunately passed away earlier this year. Ralph was really the driving force behind this initiative. Ralph was a dear friend, a great mentor to many, a great leader. He really left a mark, and there's a lot that is owed to Ralph. His life was shortened, but it was very, very impactful. And we are here talking about the Florida Stroke Registry because of his legacy. So, as I mentioned, this initiative is more than a data set. There are some reports that come back to the hospitals, to the state, and also to stroke coalitions. And we'll talk more about coalitions in a few minutes, which are really, in a way, an intervention. When you're able to measure, compare yourself, benchmark, identify gaps, then you try to improve. There's also a very strong educational component to this initiative from an annual meeting, which next year, this coming year in the summer, will be in Jacksonville. We're very excited about that. There's webinars and journal clubs and some public service announcements. We have leveraged the data that we have to try to answer some other questions with affiliated projects, and I'll show you a couple of those. And of course, trying to help regions organize and identify local barriers and resources to improve stroke care. So this was the first important milestone. Based on what we had shown in the registry in the early years, that there were disparities in acute stroke care, the legislature decided to put into law that there should be a Florida Stroke Registry. So the Florida Stroke Registry is now owned and funded by the state of Florida with annual appropriations. At that point, the legislature continued the recommendation in law that stroke centers should classify themselves as primary stroke or comprehensive stroke centers. That came from the Florida Stroke Act in 2004. But at this point, it mandated a registry, and that all hospitals that treated stroke patients should provide data to the registry to the Department of Health. Now, we can look backwards. We can see what hospitals have acquired over the years. So since 2007, we have over 600,000 cases in the registry. Again, you know what they say about big data, dirty data, but it is a lot of data. So 600,000 cases with a very good regional representation, with good race ethnic representation. So this is really a very valuable data set. I'll give you a couple of examples of how this data is important. So early on, we identified some metrics that we wanted to track, some treatment performance metrics regarding time to treatment, proportion treated, some outcome metrics at discharge, and then some in-hospital metrics. And these are the metrics that the hospitals are already reporting to Joint Commission. And then with the metrics to your left, these performance measures, if you if you had a check mark for all of these measures that you were eligible for, then you had defect-free care. We identified that composite metric of defect-free care. This is what the defect-free care in Florida and in Puerto Rico looked like a few years ago. So you see the different colored bars representing first white individuals, African Americans, Hispanics, and then in the bright green, Puerto Ricans. And you see that that defect-free care metric improved over time. And this was because we were looking at it, we were reporting it, we were making sure that we did better as hospitals, as systems of care. Our colleagues in Puerto Rico were doing a bit worse. There were some disparities there. They improved over time. When the economic crisis hit, they had a lot of problems with hospitals, with personnel, with physicians, and you see how that impacted care as well. So this is a cautionary tale, how big picture economic factors can really affect what we do on a day-to-day basis, what our patients experience. This is door to CT. We need a CT to make treatment decisions. And you see that the proportion of individuals that get a CT within 25 minutes of hospital arrival improved over time. You see it by sex, by race, ethnicity, by region, and overall we see a significant improvement. When you take a deep dive, there are certain factors that are important. For example, it is your chances of getting a CT within 25 minutes of hospital arrival goes down after hours. That's a systems of care issue that can be addressed with resources. It shouldn't be the case, right? But we do see that finding, that problem after hours. Thrombolytic treatment. So in the state of Florida, currently about 14% of all people with an ischemic stroke that come to hospital get thrombolytic treatment. This is a dramatic improvement from where we were a decade ago. There's been a doubling of the use of thrombolytics over a decade. We do see some disparities. Over time, we have seen this persistent issue that African Americans are somewhat less likely to get thrombolytics. Now, the drivers of these disparities are hard to identify from this data. They may have to do with the types of hospitals that we have, or where population groups go to, but it is a disparity that we need to address. Thrombectomy. Now, thrombectomy is relatively recent in stroke care, but you see these dramatic increases. Nowadays, 16% of all Floridians with an ischemic stroke get a thrombectomy. That is really a dramatic improvement. And numerically, there's a slight increase in thrombectomies amongst Hispanics. That may have to do with the fact that there are a lot of thrombectomy capable and comprehensive stroke centers in South Florida, where there is a high proportion of Hispanics, but that difference is not statistically significant. A few years ago, my colleague Nigar Azdagi looked at some of the drivers regarding disparities in endovascular treatment for acute ischemic stroke. And this is again a bit of older data, but again, off our presentation, for example, was associated with a lower chance of getting a thrombectomy. And again, this is how hospitals are resourced. And these are the types of data that we can use to go to our administrations, to our hospitals, and say, we need more resources to be able to avoid these differences and inequities. We've also looked at the distribution of who gets an early versus a late thrombectomy. As you know, we now have good data showing that in select cases by neuroimaging, doing a thrombectomy even after 6 hours can be beneficial. So nowadays, about a third of all thrombectomies in Florida are done in the 6 to 24-hour window. 2/3 continue to be done in the early 0 to 6 hour window. We also found that there are important effects of time on the outcomes after thrombectomy. We know that time is brain, that with TPA, the sooner you go in, the better the outcomes. We found out that that is also true with thrombectomy, but only in the early window. In the early window, time is of the essence. In the late window, it plays less of a role, perhaps because there are slow progressors that come in a bit later and they get treated in a delayed manner. And for that group of people, perhaps that is less of an important effect. But again, this remains to be seen. Another important finding is that the longer that you are part of a quality improvement project, the better you do. So these are a proportion of individuals that get TPA amongst hospitals that have been in the registry for many years versus for those that have been in the registry for less than 5 years. And we see a statistically significant difference. And this is good. That means that quality improvement is a continuous process. It's not a one-time thing. You look, you measure, you improve, and then you look again, and you continue that improvement. Another issue that I want to talk to you about regarding the registry is the hospital certification issue. This is data from 2019, and these are nationally certified stroke centers. You see at the top, acute stroke ready hospitals and primary stroke centers. So about 1,400 hospitals that they were able to provide thrombolytics. And then at the bottom, and again, from a few years ago, a little over 300 centers that were able to do a thrombectomy. Now, when we looked at the comparison in the administration of thrombolytics in primary versus comprehensive stroke centers in Florida, we found out that those patients treated at comprehensive stroke centers were more likely to get TPA than if they went to a primary stroke center. That should not be the case, right? And they got their thrombolytic in a faster manner. As many of you know, in the state of Florida, up to very recently, the hospitals were able to self-designate and attest that they were either primary or comprehensive stroke centers. And that was what was politically possible when the Stroke Act passed in 2004. So my colleague, Erica Marulanda, looked at this data in the registry and found out that the utilization of TPA, times to treatment were better in nationally certified stroke centers than in self-attested stroke centers. These are comprehensive stroke centers or thrombectomy capable centers. So although the times to treatment improved in both nationally certified and in self-attested centers, there continued to be a difference over the years. So it was this type of data from the registry that convinced the state that, and with the help of many of you in this room that were strong advocates for this as well, the state, again, it changed the law and said, no more self-designation, everybody needs to be certified by a national authority. And they put a timeline on that. And this is important as well because this also advises the EMS medical directors of where to go. And I think that this is another win for all of us in the quality of care for stroke patients in Florida. So this is where we are now in the stroke registry. We have 168 hospitals. These numbers fluctuate a little bit. They go up, they go down, hospitals merge, et cetera. So you see the type of designation at the top, and then who certifies, Joint Commission, DNV, et cetera. We now have 92% of all hospitals in the state of Florida being nationally certified. So again, this is an important advance and win. I want to shift gears and give you some examples of the EMS systems of care. This is a representative of what we can do when we link our data sets. So the Florida Stroke Registry now, through the state, has access to the EMS data sets from STARS and also to administrative data sets through ACA. And we're in the process of doing some continuous linkage in the future. This is a one-time linkage with CMS data. I'm sorry, with MSTARS data a few years ago. And we were able to link a little over 20,000 cases. And what we found is that from the time of onset to the 911 call, there was about 5 hours. That's terrible. Now, initially, we thought that this was perhaps driven by people that woke up with stroke symptoms, but you see in the lower right-hand side that these delays were also present in people that presented in the afternoon. So this is really a call for public education. We need to do better, educate patients at risk, their families, and there's a number of initiatives that we are considering and that are already available to try to improve this. And we could perhaps target some of these education to certain areas. For example, our African-American population had a bit of a greater delay in calling 911, although it was very long for all groups overall. Now, once EMS is called, there is a very fast movement. So you see here that in Florida overall, from the time of 911 call to the arrival of the paramedics is about 10 minutes. Time in scene is about 15 minutes. And from scene to hospital, about 12 minutes. With some regional differences, recognizing geography and the density of hospitals. But for example, in South Florida, as you can see there, the time from scene to a stroke center is about 9 minutes. And this is important when you think about how you're going to improve your program. So for example, if you were considering a stroke mobile, perhaps you wouldn't put it in South Florida because you have very short transport times, and there will be better use for those dollars. But perhaps in other areas, that is important. Now, these delayed presentations are important. We found out that patients that come to hospital later after 4.5 hours tend to be younger. So we need to focus our campaigns on younger individuals now that we're seeing that stroke is affecting younger individuals. So again, people that come in a delayed manner, they are less likely to have good outcomes or acute treatment. This data also helps us to model transport policies by EMS. All of you in this room are very familiarized with the delays in getting a patient from a primary stroke center to a comprehensive stroke center. In the Hermes collaboration, which is a group that looked at multiple randomized controlled trials of thrombectomy, the time from a primary stroke center to a comprehensive stroke center versus going directly to a comprehensive stroke center added almost 2 hours. And in the Stratus registry, if you went directly to a thrombectomy capable center, you saved almost 90 minutes in time to treatment at perhaps a small expense of having people be out of window for thrombolytics. But if you limited that range to 20 miles or less, then nobody missed on their TPA, and you did save a lot of time on thrombectomy if you went directly to a comprehensive stroke center. So Florida EMS systems are really at the forefront of stroke care nationally. From the Stroke Act that allowed hospitals to bypass non-stroke hospitals now almost 20 years ago, to developing in certain areas a bypass protocol. So for example, for the past many years now, since 2015, Broward and Palm Beach counties in South Florida bypass all primary stroke centers. They go directly to a comprehensive stroke center. And in Miami-Dade County, they use severity and time. So if you are mild, based on one of these pre-hospital stroke scales, within 3.5 hours, you go to a primary. Anybody after 3.5 hours, regardless of severity, and anybody who is severe, regardless of time, goes to a comprehensive stroke center. And this is due, again, in part due to an embarrassment of riches. When you have a lot of thrombectomy capable and comprehensive stroke centers, you can do that. But this is the type of data that EMS needs to make decisions about where to take their patients. So again, this is data from South Florida, from the Tri-County area. And you see that although the onset to treatment, this is not arrival to hospital, but onset to treatment times improved over the years, there continued to be a difference between primary and comprehensive stroke centers. And it is this type of data, again, that EMS uses to determine their transport policies. Now, we recognize that the resources and the infrastructure is different in each area, and that is why all of these decisions need to be made at the regional level. We believe that stroke coalitions are critically important, and congratulations on the Northeast Florida Stroke Coalition, which we are trying to support through data and reports. So we created these regional dashboards with the input of all stakeholders. So currently these regional dashboards that go to the stroke coalitions, and we now have 8 of these stroke coalitions around the state, incorporate really acute stroke treatment metrics mainly, some outcomes, but I must say that we don't have a lot of data on modified Rankin scales. There's a lot of missingness there. This is a slide that I'd like to spend a couple of minutes in. This is some of the data that the regional dashboards have, and this is actually the Northeast Florida Stroke Coalition. So each of these bars is a hospital. The gray bar down there is the accumulation of all of these hospitals' data. This is Northeast Florida hospitals, and this is the state overall for each particular metric. The rows are colored, so orange bar hospitals are those hospitals that have low stroke volumes. The blue ones are middle volumes, and the green ones higher volumes based on tertiles only. And you can see that, for example, for the use of alteplase, some hospitals provide their stroke patients alteplase at a high rate and others at a low rate. When you look at door to needle amongst patients that get thrombolytics, again, across Northeast Florida, 38 minutes, that's very good. Across Florida, 34 minutes. And this, again, kudos to everybody. This is small, large, academic, private, urban, rural, everything in there. So I believe that Florida is probably at the forefront of these metrics in the country. You see that there is a significant difference. And when you look at the state as a group, as a coalition, when EMS looks at this, when the hospitals themselves that are not performing that well look at this, this is really an impetus to try to improve a little bit of friendly competition, a little bit of data transparency. And again, the stroke teams can go to their administration and say, listen, the guys next door are doing better. I need more resources. Now, I should say that this data doesn't have the hospital's name, and it's up to each hospital to share this data with their EMS directors. These rows each have a letter, and only each hospital knows which letter they are. This is the use of thrombectomy in ischemic stroke. And again, overall, 21% of ischemic stroke patients in Northeast Florida in the Jacksonville area are receiving thrombectomy, tremendous, ahead of the state, and but with variability across the different hospitals. This data is important, and we are very proud that the state has not only recognized it in the legislature, but it has also incorporated 2 stroke metrics into the state health improvement plan, which is a plan that is revised and has very lofty goals to try to improve care amongst different areas. But there are 2 metrics in the state health improvement plan related to stroke, as I mentioned, which are the increase in the use of EMS to come to hospital. We were at 49% in 2021, and we remain there. That's an area where we can improve with public education. And the proportion of patients that get their thrombolytic within 45 minutes, increasing from 75 to 85%. We are at 78% right now. So again, there's some positive movement there. Very briefly, because I know that I'm running out of time, when we move away from acute stroke treatment, we can look at the use of secondary prevention measures. What I'm showing you here is that over time, the proportion of individuals that are discharged on warfarin for atrial fibrillation-related strokes has gone down. The utilization of DOACs has increased. We've seen this nationally. But there is no change in the proportion of individuals that get discharged on aspirin. That's the blue bars. A significant portion of individuals go home on aspirin appropriately. You have a large stroke, you have to wait a little bit until you start your DOACs. But this is an area where patients slip through the cracks and they don't go to see the primary care physician, and then they don't get their anticoagulant in a timely manner. And we can track this again through the Florida Stroke Registry. We've looked at readmissions again by merging data sets. This is merged with CMS, and we saw, and this is from a few years ago, that the all-cause 30-day readmission was 15% in Florida after a stroke. And about 1 in 5 individuals that get readmitted, it is because of a cerebrovascular cause. With some disparities, again, a higher proportion of African Americans being readmitted. Now, the stroke coordinators always bang on our doors and tell us, don't forget to use aspirin, don't forget to prescribe statins, all of these important metrics. They do make a difference. So we've looked at the acute stroke metrics that are reported to the Joint Commission and their effect on mortality and readmission, and they do work. So the use of antithrombotics early after a stroke plays a role in decreased mortality. The use of statins not only decreases mortality at 1 year, but also decreases readmissions. But the transition of care is a problem. We do a great job in hospital. We give thrombolytics, we do thrombectomy, but then people go home and again, they feel like they fall off a cliff. So we have the Transitions of Stroke Care project, which is funded by the NIH. It is a side project to the registry. And this is some early data. We call patients in a structured interview at 30 days with consent. And we found out that 12% of patients after the stroke had not filled their medications, or they were not taking their medications prescribed at discharge. 18% had not seen a medical provider within 30 days. Only 1/3 of individuals had stopped smoking if they were smoking. Again, this is a failure of the system, and we need to do better there, right? We created this composite measure of all of these behaviors, the adequate transition of care metric, and overall 2/3 of patients had adequate behaviors at 30 days. 1/3 did not. So we need to improve there, of course. Many of you may know that we are a Coverdale state. The Paul Coverdale Acute Stroke Program is a CDC-sponsored program. The state receives this designation and funds from the CDC. And we are the 13th state with this denomination, which is great because this will put more emphasis into transitions of care, as well as looking at pre-hospital stages of care. So, just to summarize, there's been a great improvement in the quality of stroke care in Florida. Look at these metrics from 2010 to 2021. Again, the use of thrombolytics doubled. The use of thrombectomy increased dramatically from 2% to 16%. Our treatment within 60 and 45 minutes dramatically increased. So again, a tremendous improvement, but still a lot of work to be done. And I hope to have shown you that with these quality improvement projects, you can not only guide what we do in hospital, but you can actually change policy, you can change the law, and this feedback loop of measuring, proving, and measuring again is critically important to try to elevate care for everybody. So with that, I think I'll stop because I'm a little bit over time, and I'll be happy to take any questions if there are any, or do you want me to hold off for that?
Questions?
I have a question.
Right.
I'm over here.
Oh, sorry.
This is a great topic, awesome talk. Appreciate all the data and really impressive results there from 2010 to now. I just want to ask, so the Florida State Registry, who manages it? How was it built? How is it continually funded? So that's kind of my first question, is kind of the logistics behind the registry itself. I know a lot of work goes into any kind of large rate registry. And then secondarily, I'm sure a lot of the hospitals in the state of Florida participate in other registries such as Coverdell and Get With the Guidelines. So are you finding that hospitals and stroke coordinators quality teams are contributing into both Florida State Registry and a similar registry? So there's duplicative work. So just wondering about that.
A very good question. So first of all, the registry is sponsored and owned by the state, mandated by the state. We coordinated out of the University of Miami with a small team, data managers, biostatisticians, where we clean data and so on. This is funded through annual state appropriations that then provide the funds for our team to create these reports and educational activities. Now, the registry leverages Get With The Guidelines, so there's no excess work. So the hospitals enter the data into Get With The Guidelines, and the hospitals allow us to get that data from Get With The Guidelines. So the hospitals are not entering extra data. If you are a Coverdell participant, and I hope that all of you become Coverdell participants, there may be 2 or 3 extra measures that you have to document, but not much more. And then again, we collate that data, we analyze it, clean it, and we create these reports back to the hospitals, to the coalitions, and to the state. Well, the state sees an annual report as well. So no excess work. And then the benefits are, of course, the reports, the list serves that some of you may be on, the annual meetings, educational resources, collaboration, and then the facilitation of these regional coalitions excited about. Now, what we can do on the back end is that we can merge Get With The Guidelines with the Coverdell data points, extra data points, with MSTARS data, with ACA data, and then look at the continuum of care.
Thank
Yes.
you. The one question, do you have any information, and maybe I missed, but on the predictability of the tools, pre-hospital tools on LVO detection, the FAST-CD in specific, if you have that, that would be great to hear.
Sure. We don't yet. Once we get the MSTARS data, we will and link it continuously rather than sporadically. I think we'll be able to look at that and at least compared to admission NIH stroke scales, for example. We don't have imaging in the registry. That is an area where we'd love to get at least some data points, if not full imaging in the future. But that is something for the next few years.
I always love your lectures. Thank you so much. It was very inspiring. I have a very granular question. I don't know if you were here yesterday morning, but there was a discussion about robotics and neurointervention and how doing remote thrombectomies is going to solve this problem. As an expert, I know it's a very granular question, but as an expert in stroke systems of care, is that really what's going to move the needle forward in terms of access to mechanical thrombectomy?
I don't know. And I was not here yesterday. I don't know. I think that thrombectomy has been an incredible tool. We don't have enough people to do this. And again, I'll defer to my colleagues who are thrombectomy experts, but it's not only the individual, it's the techs, the nurses, the angio suite, the availability 24/7, the imaging to select patients that need to be established. I would assume that for areas where there is, one comprehensive stroke center in half of a state, that perhaps that is something that will happen. In Florida, we have a bunch of thrombectomy capable and comprehensive stroke centers now. So I am not sure whether that will be the key that will really change dramatically care in Florida. But as they were saying in the previous sessions, what we thought would never happen and we couldn't imagine is now a reality. So maybe this is what's going to happen in the future.
I have one for you, Jose. How do you think a EMS can best utilize these dashboards? Because we see a disparity the way this is being used, and actually South Florida dashboard is the most mature that we have, and we are following. And thank you, Wendy and the team, for work and pushing for that to happen here for us. How do you see this morphing as a statewide? You see, I saw in the beautiful slide there, all regions represented. Do you think at some point, with leadership in Tallahassee that was central on the South Florida, do you see this as a push? What is the next Florida? We did this, you did the Stroke Act that we were involved on in 2019. Would that be the next Stroke Act that we're gonna use that to say, okay, A is doing better than B, B needs to get to A in, so how do you see that?
Yeah, so I think that the soft approach is always better, and trying to encourage and showing how this works. Now, South Florida EMS took the lead and said, we have options, we will bypass. And not only that, but we realize that not all comprehensive stroke centers are born equally, and we will ask you for your data, and if you're not performing well, we will put you on notice. Actually, our own hospital a few years ago got put on STEMI bypass for a day. I think it was a warning shot across the bow to try to improve care. So I think that is an area that we need to understand better. EMS is a critical partner. They are invested in their patients, and they're becoming more and more activist. I'm not sure if we have any EMS colleagues here, but in Florida, they really play an incredible role. And I do think that they will be looking at these dashboards. They've been asking us to identify hospitals. We don't think that is the right way to do it at this point, at least not with our current data use agreements. But your EMS medical director has the right to come knocking on your door and and asking you, tell me which letter you are, which row you are in that dashboard. I want to know. I think you're going to see more EMS medical directors becoming involved, knowledgeable about the data, and will want to try to improve regional care. I think that has happened and will continue to expand.
Thank you. Anything else, guys? So don't go anywhere, Jose, because it is a true act part. First, we're going to give you on the behalf of our team here, our little piece of Pontevedra token of appreciation. And I forgot the second part, but I would like to invite Nima, Wendy, I don't know if Niraj, Eric, please come. And we have a senior member of our stroke community with the highest possible pedigree. Tom, please join us too, because I know Tom was a dear friend of Ralph. Every year in this conference, we do what we call Innovations in Cerebrovascular Science Award. And unfortunately, we're late because I think it's much nicer when we do this with the person right next to us. But we know you were brothers. And I met Ralph when I was a baby in the 1990s. It was our first visit to the United States Systems of Care at Columbia Presbyterian. And he had a very contagious smile. And I was a medical student, 50 years in Brazil, do 6 years of medical school. So I met Ralph in a carotid discussion between Ralph Sacco, Ben Stein, and Don Quest. I'll never forget that conversation. And I ended up watching Don Quest doing a carotid endarterectomy there. What we wrote about Ralph here is in the grateful recognition of Ralph Sacco and his enduring legacy as a leader, physician, researcher, mentor, and friend. For those of us that had the opportunity to cross paths with him, what Jose showed here today, as you honor with this picture, Ralph is on the dead center of that, present for the American Academy of Neurology. At one point, and I lost track, only non-cardiology president for the American Heart and Stroke Association, among other things, always very direct, always very honest, even about his own demise by a tremendous, tricky disease that is glioblastoma. Even that, he was totally open about that with his friends. So I'm honored to honor him through the Miami family. You guys are his legacy, and we're very proud to be a little bit of part of what you started there and what you continue to do. His legacy is alive and is doing very well. Thank you, Jose. Tom, any?
You know, Ralph, he was a groundbreaker, an absolute groundbreaker. And he accomplished things that nobody else was able to accomplish in Manhattan. And the Northern Manhattan study was really the first of its kind. And then I wondered, well, what is he going to do down in Florida? Is he going to just take a vacation? And really, he led the team that, first of all, he built the team. And then he led this is only part of what Ralph was able to accomplish at University of Miami and for all of the state. And as you say, for both the American Academy of Neurology and the American Heart Association. And he will really be missed. He is already.
Jose, thank you.
I want to thank all of you. This is very touching. Of course, Ralph, there's all of this and more. And, you know, he led a very impactful life. And although his life was cut short, the impact that he's had and the quality of life that he led has been really incredible. So he is really a role model to me and to many of us. So I appreciate on behalf of the University of Miami and of all of Florida, really this touching memory.
Thank you, guys. We can do right there. We'll do the right there. So we'll have a break, guys. We're back at 1:15 sharp for final sessions. Thank you.
80%. What do you think of the gumbo? Now that we have date. Gonna be on the slides. Just announced, okay. All right, everyone, thanks for being here. I know it's an afternoon, but we have some exciting and amazing talks coming up. It is my honor to introduce our next speaker, Dr. Amaru Suraj, a friend. He's a internationally recognized vascular neurology and researcher. And he is the global PI for SELECT-2, which is going to be his next talk. And he's a chair of neurology at Case Western. So with that, Amaru, are you there?
I'm here.
Oh, great.
I'm here.
All right.
I only see a black screen though. Is that going to change? It's odd. That's all.
We're working on it.
Yeah.
Hello, my friend. How you doing? I don't know. They don't have image feedback from here, right? Here.
Do you see my image?
We see you. Can you see us waving or no?
Yeah. I do see you very well.
Thank you. Thank you. Please go ahead.
Wonderful. Let me just have my slides.
Amaru, just a complete SELECT-2 that will change our guidelines for stroke intervention. So thank you for sharing and allowing us to be part of that with you.
Well, you said will change. It should have changed already. But anyway, a pleasure to be there. Thank you, Ricardo. Thank you, everybody. You guys were an integral part of SELECT-2, and I'm grateful for that. Thank you so much for being there. Do you see my screen?
Yes, we do.
What do you see?
There it is.
I see a good-looking guy and Ronaldo.
You see, that was the closing slide, but here you go. It's the opening slide for my friend there, the Brazilian Ronaldo. We'll talk about SELECT-2, but again, thank you, Ricardo. Thank you, Nima. I honestly wish I was there, but the travel didn't work out well. I will hold my invitation for next year for sure. Looks like a beautiful beach there. So this is on large core, which indeed have changed with your help from skepticism to concrete evidence over the last few months. We'll go over that. Those are my relevant disclosures. Select and Select 2 were funded by Stryker Neurovascular with grants to the institutions, not to myself, and they were not run by pharma. So I think many of the audience probably know that, but just making sure that we cover the bases. Endovascular thrombectomy is reperfusion therapy for patients with large vessel occlusion, and this is an illustration for patients with a left MCA M1 occlusion who is harboring a significant neurological deficit, but this is not reflective on the CAT scan. We don't see significant ischemic changes in this patient. So this is a slam dunk, excellent patients for intervention. Reversible neurological deficit, you intervene, you remove the clot. Plausibly, the patients would get better. No core infarct on the CTP, no changes on the CT. This patient's got reperfused, got successful reperfusion, ended up with a much smaller infarct that what could have been. Just quickly, for those who are not familiar, this is perfusion imaging software called Rabbit that looks for asymmetry between normal and abnormal sites, and because there is an occlusion, there is delayed in the blood flow. So the green area is delayed in the blood flow or critically hypoperfused tissue, which is pretty large, 107 cc's. And when you have significant delayed in blood flow for a certain amount of time, you start losing the volume, and you have poor infarct. We don't see any poor infarct here. We see zero. But what we are sure of here is that the final infarct volume is much smaller than the 157 cc. So this is how things worked for a while after the 2015 and 2017 trials. The journey for reperfusion started way back in 1996 when the pioneers looked at reperfusion and thrombolysis. I mean, I told my patient stroke is a clot sits in the blood vessel and prevent flow. So reperfusing and opening the blood vessel was, is, and will always be the mainstay of treatment of stroke. Adjunctive therapies are probably good and may be helpful, but this will always be the mainstay. It started with the TPA trials in 1996 in INDS 1 and 2. Tony Forland, one of my mentors and the emeritus chair here, did PROACT, which is pro-urokinase, in 1998, which was a pilot study. TPA was not around at the time. So they went on to the clot and injected the pro-urokinase. This is amazing. So it's a combination of mechanical and chemical. The interesting part that even the patients who got no intervention, the sham, they actually took them to the angio suite, did angio, went and rotated the clot, but did not inject pro-urokinase. I don't think IRB will allow you to do that. And those were positive trials, but multiple things happened. Pro-urokinase was not approved by the FDA. Those were against heparin for the veteran physicians and nurses and coordinators. We used to give heparin prior to thrombolysis. So that's why it didn't pan out. MELT is the PROACT in Japan, or the Japanese version. Then we had terrible results in 2013 from 3 trials: poor design, poor execution, poor selection of patients, all devices that did not work, a recipe for failure, so to speak, and did not show benefit, those trials. Then we have great results in 2015 with the new devices, better selection, better identification of patients with large vessel occlusion, up to 6 hours initially, then up to 24 hours with Dawn and Diffuse 3. So this is where the journey started. I think now after the large core, we can add those, but I maybe somebody in 10 years will do that, and large core will become history. So all of the population that I spoke about have pretty good imaging profiles. No core, no ischemic changes on CT. But this is not our population. The population that we studied is a different population with significant ischemic changes on the CT and large core on the perfusion. So you have different expectations. Those patients were largely excluded from the trials that I mentioned. If you look at the Hermes meta-analysis from the early window trials, you see that out of almost 1,300 patients, 1,200 had small core infarcts, only 121 had large core, and you see that the line crosses the no difference. So there was no evidence of large core benefit, of thrombectomy benefit in large core in this population. This is from the Hermes, one of our co-PIs, Dr. Campbell, published data in the Lancet Neurology. Again, this is good data, but it just shows you that they have only 50 patients with core volume of 70 cc's or more. We'll show you how many we have in Select 2, just from all the trials, and they had only 2 patients from randomized evidence that achieved good outcome after thrombectomy. So there was really no evidence on this population. That's why it was not hard to convince people to do the trial. And the way that we went on about Select 2 and Select 2 was very methodological. Started with an unrandomized trial, Select, smaller version, 9 sites in the United States. Actually, we did have a hospital in Florida, but it was not Baptist. From Select, we published this paper a few years ago, non-randomized data on large core, and you see we had 105 patients, thrombectomy versus medical management. Thrombectomy patients did better than medical management patients, and that was statistically significant. So of course, non-randomized, so there are biases. Physicians treated the patients who they thought they may benefit, and also some physicians are more aggressive than other physicians, if you may, but it was statistically significant, so, with 100 patients. So what we thought at the time, well, if we design the randomized trial, we need a larger sample size. We need to account for those, but this was the basis. Out of all of the large core trials, Select 2 was the only trial that was based on a phase 2 trial that did these calculations based on our own research, so to speak. There are other considerations of the large core population. How do you define large core? Is it based on CT? Is it based on perfusion? Is it based on DWI? And you can do that based on all of those, and this is an illustration of it. CT measures the hypodensity, perfusion measures the blood flow and velocity, and MRI measures the cytotoxic edema, and it's probably the gold standard. But why people don't treat patients with large core? Because, or prior to this evidence, why they hesitate, large infarct, significant tissue loss, less likely that they would benefit. Large infarct, large area at risk. If you open the blood vessel to this area of infarcted tissue, higher risk of bleeding, at least plausibly. But if you don't, the natural history is poor. The patients may still benefit from intervention. So you can make argument on both ends. And this is, when you look at something and you say this is ripe for randomized trial, and this is what we did. Additional point that we considered for Select 2, should we do it based on CT? Should we do it based on perfusion, or on both? CT is good, available everywhere, cheap, but requires certain expertise to interpret. It's also an ordinal scale, the aspects which measures the degree of ischemia or the ischemia estimates. So it's a scale from 0 to 10, 11-point scale. The higher is the better. When you go to lower aspects, these are the large core patients, 5 or less. But just look at two patients with the same aspects. They can have wildly different volumes. The volume give you a continuous measurement. It's automated, so it does not follow a lot of subjectivity. It has its issues, but you may consider it to be more comprehensive. So we ended up actually doing it on both because we wanted also to look at this question whether it should be done on CT or perfusion, and that's how we ended up doing the SELECT-2 trial, looking at thrombectomy efficacy and safety in patients with large core on CT aspects 3 to 5, perfusion volume of 50 cc or more, or MRI diffusion. This was a prospective randomized multi-center trial, open label, because you cannot do an intervention without the interventionalist knowing and without the patient knowing what did they receive. 31 sites in the United States, Canada, Europe, Australia, and New Zealand, with covariate adaptive randomization. You don't want the patients who are older, sicker, larger volumes, later treatment to be in one group and the other be in the other group. So that's why you do a covariate adaptive randomization to have them balance between the two groups. All of the patients received the same imaging with baseline CT plus perfusion or diffusion. The total enrollment target was 560. We had a plan for adaptive enrichment, meaning if certain patients were less likely to do well, just like the cancer trials, you have different chemotherapies, courses, and multiple arms, and the ones who don't do well or don't benefit get excluded after interim analysis. We were worried that the very large core will not do well. We were worried that beyond 12 hours will not do well. The DSMB, the Data and Safety Monitoring Board, was supposed to guide us, but they didn't need us to do any enrichment. We have two interim analysis pre-specified at 200, 380. And following a Japanese trial results that was based on MRI, Rescue Japan limit, we were asked to provide an additional analysis of 300 patients. The primary outcome was the shift, meaning shifting patients at least 1 point on the modified Rankin scale. Secondary outcomes were MRI 0 to 2, and which is functional independence, MRI 0 to 3, which is independent ambulation. Just keep in mind, a patient who comes in with an M1 occlusion or an ICA occlusion having a core of 120 cc's, this is as sick as they come. So if this patients end up walking with a cane at 90 days, this is a very good outcome. If this patient ends up being independent, this is even better. But just set your expectations right, because this is not the small core population where you think, well, 50 or 60% of my patients should do well. This is a different population, and that's why we looked at the shift. I mean, some people might say, well, an MRS of 4 and being in a wheelchair is not too good. Well, to some people, it might be good. Safety is important. Symptomatic hemorrhage and mortality and procedural complications, neurological worsening, because you're doing procedure on a high risk population. You want to make sure you're not harming people. Different map than what you saw in SELECT in the initial trial, just the United States, much bigger here. About 2/3 of the sites were in the United States, couple of sites in Canada, 5 sites in Barcelona, sites in Switzerland, and 4 sites in Australia and New Zealand. Visited almost everybody, but I didn't get to go to Australia and New Zealand, and we had great contributions from everybody. This trial, just to remind people, ran through the heart of the pandemic. We enrolled patients from October 2019 to September 2022. This this is when the pandemic hit in around March of 2020, when I started getting emails from IRBs and from sites and letters from IRBs freezing the trial, and you know, with the great support from all of the investigators, we were able to achieve this. I think, you know, remote consenting. I mean, I can write a bibliography on this. I mean, and we are writing a paper on that. How did we adapt to the pandemic? The patient's families cannot come to the emergency room to consent. So remote consenting was essential. The dedication of the investigators and the coordinators was essential to be able to complete the trial. 352 patients were enrolled. Great contributions, as I said, from many of our sites. I mean, almost everybody did so well. And you see here is Ricardo and Nima and you guys, 7 patients, which is very good contribution in the trial. We screened about 1,000 patients to enroll, 352 patients. 178 went to thrombectomy, 174 went to medical management. We had only 2 crossovers, meaning after the patient go to one arm, they cross to the other arm, they cross from medical management to thrombectomy. Again, great dedication by our teams. Only 4 patients lost follow-up. I mean, it's amazing when you know, you especially now, even for the 1-year follow-up, you hear from the coordinators, well, the patients haven't been picking up, but I have seen that they have a cardiology appointment, so I'm going to go intercept them or ambush them there to get their outcome. That is really great. These are the baseline characteristics. As I mentioned, this is a sick population, so median NIH was 19. Very good distribution between early and late window, 12 and 24 hours. And the volumes, the median volume was around 80 cc's, and the interquartile 60 to 120. Just to put this into context, Dawn median volume was around 9 cc's, and Diffuse 3 was around 10 cc's, and Hermes was around 8 cc's. So this is a very good representation of the large core population. And here are the outcomes. The medical management patients, about in 80% of the cases, 81% had MRS of 4, 5, and 6, while thrombectomy patients did better with a shift towards better outcomes, and that was statistically significant with a measure of superiority of 60%, meaning there is a probability of 60% that a patient who would receive thrombectomy will move on the modified Rankin by at least 1 point, and an odds of 1.5 the times of achieving at least 1 point improvement as compared to medical management. And this translated to a number needed to treat of 5. We treat 5 patients with large core thrombectomy for 1 patient to at least improve by 1 point. Looking at the secondary outcomes, if you're looking at functional independence and independent ambulation, 20% with thrombectomy and 7% with medical management, so almost 3 times, and a number needed to treat of 7, which is very good in this population. And independent ambulation, almost 40% of the patients achieved independent ambulation as compared to 20% in medical management, a number needed to treat of 5, which is again satisfying and very good. Symptomatic hemorrhages were not common, and there will be papers on that specifically. Just remember, this is a sick population, very large strokes when they come, very high stroke scale. In order for you to have symptomatic hemorrhage, you have to have 4 points worsening in the stroke scale due to a parenchymal hematoma, not any hemorrhage. That is related to the hemorrhage itself, that is not related to the stroke worsening. So that's why the symptomatic hemorrhage rate was low in Select 2, and it was centrally adjudicated. And now that we are pooling the data, that the symptomatic hemorrhage that was reported high in the Chinese trial will drop after the central adjudication that we have done with them. This is reassuring because a lot of people do not treat these patients because they are worried about the the risk of hemorrhage. Mortality was high in both populations, thrombectomy and medical management, but did not increase with thrombectomy, 42% versus 38%. Neurological worsening was worse with thrombectomy. Why? Because one of the explanations is you open the blood vessel into a large stroke, the cerebral edema because of the early reperfusion can do that. So 25% versus 16%. But this did not detract from the overall benefit that these patients had. How about the successful reperfusion? 80%, also great work from the interventionalist. I mean, this is large core and you go and you open the blood vessel. A lot of people are afraid of intervening in this population, and our interventionalists did very well. We had a and the editor for New England Journal of Medicine made us highlight this. We have about 20% complication rate. Some of them, you may argue, just cite complications. I mean, there is not just in complications. Complications are complications, but there are some that are more significant than others. To me, it's the perforation and the dissection, which was about 9%, are the most significant ones. Vasospasm is temporary, and the others are not as significant, but those also did not detract from the overall benefit. As treated population and per protocol also showed the same results as the main analysis. And here are the subgroups, and whether it's age, stroke severity, or time, or core volume, mismatch, no mismatch, all of these patients benefited. So the subgroups universally favored thrombectomy, and then I highlight the important ones, the main ones, which we should have a paper on that coming soon, all favored thrombectomy. And since this is a large core trial, it's important to look at the cores. 2/3 of the patients in SELECT-2 had a core of 70 cc or more. Remember, when I started, I talked about the Hermes having 50 patients in all of the Hermes trials, the 7 trials. 50 patients had core of 70 cc or more. In SELECT-2, it was 250 patients who have a core of 70 cc or more. About 1/3 of the patients have a core of 100 cc or more, which is a pretty good number. And about 13% of the population had a core of 150 cc or more. And in all of these patients, the treatment effect was maintained. Absolutely, the likelihood of achieving MRS of 0 to 2 and 0 to 3 decreases as the core volume increases. That is just, the plausibility. And the larger, the sicker the patients, the less likely they will do well. But at the same time, the medical management patients did worse. And that is why it was maintained. There are more details in the imaging paper that's going to come on this, and what is the cutoff that should be used. But these are the initial results on maintaining treatment effect. Of course, you have to personalize by patients. Importantly, we pre-specified 2 important populations. People said, well, you can't include patients with good aspects, and you can't include patients with certain volumes because they were in prior trials. We can argue about that, but the best is to make sure that you exclude them and you see if your results stand, and it did. And most importantly, the most stringent population with a core of more than 70 and an aspects of less than 6 had even better odds of achieving better outcome with thrombectomy. So the trial, without a doubt, showed superiority of thrombectomy as compared to medical management in large core population, whether it's a shift, whether it's MRS 0 to 2 or MRS 0 to 3. The symptomatic hemorrhage was infrequent. The side complications, the overall complications occurred in about 20%, and neurological worsening was higher with thrombectomy, but this did not detract from the overall benefit. I mean, and that's why, as Ricardo mentioned at the beginning, this is changing treatment approaches and protocols worldwide, and making these patients eligible, along with 2 other trials. The paper was published in New England Journal of Medicine back in February. At the same time, presentation at the ISC, and both Ricardo and Nima are named co-authors on the manuscripts, as you see here. Thank you both for your help. So it was not just SELECT-2. There are other trials that simultaneously the Chinese trial presented the results. A year before the Rescue Japan, the Japanese trial presented its results. All looked at large core. The Japanese one was based on MRI. The Chinese one was based mainly on CT. SELECT-2 was CT and CT perfusion and MRI. And important observation that all of them are positive, same treatment effect. If you look at the Japanese and you say it's 2.4 and the other ones are 1.3 and 1.5, it's just a different measure. If you translate it, it's the same treatment effect, and different populations. So is it 47% MR 0 to 3 or is it 31? I think the truth is somewhere in the middle of patients who can achieve that. There are other trials. Tesla was a United States-based trial that concluded 300 patients enrollment. It will be presented at the European Stroke Conference in a couple of weeks. Tension is a German European trial that stopped along with an extremist after SELECT-2 and Angel aspects. They will be presented at the World Stroke Conference in October. So by October, you will have 6 trials results. I mean, we expect, you know, similar direction from those, and we have plans to pool the results and get it together. I will be presenting the pooled analysis from the first 3 published trials in the European Stroke Conference in Germany. So some considerations remain. How large is large, and what is too large? I mean, we still maintain treatment effect in SELECT-2, but you know, a lot of people would ask, you know, where do I draw the line in the sand? I mean, personally, I look at 150 is somewhere where I start looking at limited number of patients, limited outcomes. You might personalize by patients, but I definitely wouldn't stop at 100. The Japanese trial showed that aspects of 3 may not benefit. We'll see how that pans out in the pooled meta-analysis. What imaging modality to use? There will be a paper from SELECT-2 coming on that, on perfusion versus aspects, and what's a good outcome? We discussed that quickly, but is it MR 0 to 3 is pretty good. 3 is very good, but there was other considerations. There was a paper from the leadership at SNES that looked at MRS of 5 in the trials that was cut in half. And from societal standpoint, you turn a patient from going to 24/7 nursing care to be probably at home. That is very important. And then how do you adapt to this in systems of care adaptation? More procedures, more interventionalists, more transfers. I think this is something that it's about 20% increase in the population or so. So these are things that we will see in the near future. Of course, several people contributed to this. Nobody more than the patients and their families. Great and noble contributions, and definitely my co-investigators. I probably Nima and Ricardo can tell you how many times I called and text and harassed them to enroll patients in the trial, and everybody actually responded. I never felt I was doing this by myself. So that's all I have to say, and happy to answer if there are any questions.
We're missing our last slide.
Well, you ambushed me before I put it there, but it's actually, let me just get done with this and show my screen of the no, those are this is Ricardo, and this is Ronaldo, and this is the real Ronaldo. I don't know if you guys know, but this is a very famous Brazilian soccer player. And, yeah. one time I
Dr.
asked-
Lopez was there in Yokohama when he got the haircut and beat the Germans
Here you go.
single-handed. So
Here you go. So
thank you,
Yeah.
Enro. Great talk, man. Strong work.
thank you, and hopefully next time in person.
I'm gonna try the haircut next year.
Yes, I'll
Any
do it
que-
with. I'll do it with you.
Let's wait for 2026 when the World Cup is here in the United States, then we can all showcase. Any questions, guys? I have one. That core that you're showing us, that's are you measuring that 70, 100, 150 on the CTP, or it's an endpoint that is combined CT, CTP?
Well, that's a great point, and I think this is something that if you look at the details in the paper, all but about 50 cases, we measured it on both CTP and CT, because there are cases where the CTP underestimates incomplete occlusion, clot migration. So we did a combination of the hypodensity on the CT and the CTP, and I think that's where the future will be heading. In the imaging paper, we will present both the CTP alone and the CTP plus CT and the CT alone, the hypodensity on CT. I think you do, and all of the good clinicians don't look just at CTP. You should look at the CT as well to see if there are hypodensities that you can't see on the CTP. Plus, if there are darker hypodensities that already infarcted. But very good point, Ricardo.
And who you're not intervening on. So if you look at a CT, I know you inferior to 100, 150. If you look at a plain CT or CT, CTP, whatever, who you're saying, no, this guy is not a good candidate. Who are you not intervening today based on the size of the core?
I mean, I will tell you that personally, our protocol here is 150. But that doesn't mean we don't consider more than 150. That means that those cases are for discussion. Remember that in Select 2, we excluded patients with established infarct. We excluded patients with cerebral edema. So we can't say much about those. I think if you look at an overall picture, and there are some people more aggressive than other people, that you treat the masses and some patients will benefit. I think we all like a line in the sand, and that's where my line is. I think if I don't know how the guidelines will come, and I understand that there will be an advisory after the European conference. The guidelines might just come based on the aspects rather than the volume. So I'm not sure how much granularity you will get with that.
Amory, great talk and fantastic job. Congratulations again. It's not easy to do such a trial and complete it. So
Thank you for your help.
Of course, are you going to tell us about Select 3, or are you going to keep it secret?
Well, so I think we retired the numbers. So we went with a Select Late, which is, as you guys know, hopefully all goes through well. I think that we busted the door for size wide open, and we want to bust the door for time wide open, no time limit. And I think that is how it should be. Hopefully we are able to prove that. So I mean, my dedication, Nima and Ricardo, for you and the interventionalists, to keep you guys in business. That is the goal.
Thank you.
Thank you, sir. Really appreciate. Looking forward to have you here next time.
Absolutely. I would love to. Enjoy the rest of the conference. Thank you so much.
Thank you. We have an executive decision to make together. We're gonna do some case discussion next, and we're slotted for a break at 2:30. So we need to vote. No break, go straight to the end. A 15-minute break or 30-minute break. So who votes for no break? So finish the Friday early, raise your hand. Who vote for 30-minute break? Who vote for 15-minute break? Okay, so no break 1 and We will follow the majority.
All right, guys, this is not formal, so we just have one or two cases depending on time, so participate and we'll open to discussion. And thanks for sticking with us. I know it's getting afternoon and late, but hang in there. So here's a case, 64-year-old with right-sided weakness and left gaze, NIH of 13, and the symptoms were fluctuating. The patient presented acutely. This is a CTA, and you guys can see that up here. Can't really see it on that screen, but there is a blockage right there.
You can pimp Dr. Lopez if you want.
Yep. This is the perfusion. So I guess at this point, anybody would not offer thrombectomy.
How long ago was the beginning of the symptom?
Within 6 to 7 hours, so that's not really open for conversation. Anybody would not offer thrombectomy. The reason I said that, there is a large vessel occlusion, right? But what's interesting, the perfusion was not really that impressive. And to me, that doesn't matter. What's important is the NIH of 13, right? So patient symptomatic and you have a blockage within the hour.
Be careful, we have a Calgary request.
Okay.
Is it truly occluded or is there forward flow through there?
This, yeah. Based on this CTA, it is occluded based on this CTA. So there's no flow past it. There's some branches that's coming out, possibly an M2 branch or anterior temporal, but there's abrupt cutoff, and obviously I don't have the slides to go through it.
Well, just for sake of discussion, well, I wonder if there is forward flow, and I would ask about the symptoms and how severe they are, how much they're fluctuating, and they're in hospital, how close we are to observing the patient and take them to the cath lab on an emergent basis.
Okay.
Thanks.
Very fair. I appreciate that comment. When I examined the patient, that was my case, the NIH was 13, but prior to me getting to the patient had been fluctuating. But when I'm seeing the patient to make this decision, the patient had gaze preference and weakness to paralysis on the contralateral side. It was a pretty disabling condition. But like you said, let's say NIH was 1 or 2. Yeah, I mean, we don't have, I think observation would be very reasonable. Okay, so management. This was the case. So the patient is taken to the angio suite, and as you guys know, we put a tube here, base catheter. You can inject dye. You can see that there's an abrupt cutoff right there. What's interesting on this patient on the lateral, despite of the perfusion, there is a large area of the brain that's really not getting flow. Dr. Lopez, what system would you use for this problem?
I think we should ask Dr. Hawkins. Lopez just had to answer a call, so I am not Dr. Lopez.
We have Dr.
It's
Hawkins
Dr.
here.
Hawkins.
Go ahead.
I'd probably use a Walrus balloon guider. Looks like I can get a red 72 out there. And if you know, I'm 27 and a solitaire.
Solitaire, good. Yeah, I mean, I think 72 is good. Dr. Hanno?
I would try to enroll this patient in one of our clinical trials. If a clinical trial family is not available, our newly approved electronic consent doesn't work. A great question. If I can get my aspiration catheter to the face of the clot, I'll try to aspirate first. I have to cross the clot with a wire. I would do exactly what Chris described. I like to avoid mentioning vendors because there's a very large variety of catheters that can be used. Red 72 is a good option. Again, that's my.
All right, sounds good. So it was a red 62, and I use a stent retriever. And with this stent retriever, I sometimes do injection to kind of see what we're dealing with. And when I did an injection, this is what I see. Chris,
Did Chris did this case with you? He
I
knew
don't
that?
remember. Chris, what do you see there? That's it's kind of jumps out at us.
So there's some stenosis there approximately that looks like it might be intrinsic disease. At least I'd be worried about that.
Yeah, so for everybody in the room, this is the vessel that was blocked. The stent is a stent retriever, so it's connected to the wire. And as Chris said, there is a narrowing right there. And I'll tell you the pertinence of that. And so 2 passes, this is what it looks like. So the discussion here is, what would you do next? So I did the same thing for 2 times, and this is the end result. And for everybody in the room again, you see that blockage has opened up a bit. There's a little bit of flow going, but obviously there's still a disease right there. I'll let Dr. Hanel pick on someone.
No, I was just gonna go back to, again, in the future, we're gonna have a way to answer that, right? Because I know what Chris mentioned, and I'm not sure I agree with that. We know there's narrowing if it's atro or sticky clot to the wall, or dissection. I don't remember the age of the patient. That answer, we don't know, and I don't think anybody can tell that on the angiogram. Could it be atro? Yes, but it could be just a clot that is adherent to the wall. And I used to think that I could tell that on an angiogram. And more when I look, especially now looking what we have with OCT, cannot say that. But there is stenosis there. And again, we are in 2023. We don't have OCT, and we have to deal with a vessel that is likely to be reoccluding. So,
Anybody else have any comment on this? So thank you for that. So the question now is, what do you do now? So the patient's on the table. This is the final result after 2 passes.
you don't have the AP, right?
It's pretty sluggish, but I don't have the view. No. Are you thinking about the collaterals or?
Yeah, distal M1, right?
If I recall, there was not much. I mean, that's the antegrade flow level.
You do, John.
Yeah, I think it looks like it's going to shut down. I might wait a little bit of time and scrutinize a bit further, but it seems like you may need to do another pass.
Yeah, no, I mean, I think we're all thinking the same thing. It looks bad, right? And it looks like it's going to shut down. I'm not showing the angio, sorry, but you know, the beauty of angio obviously is the flow dynamic. So when you inject, you can actually see the flow is slow. So you know that this is a slow, sluggish flow past it. So I did what you said. I waited. I did another run. It looked worse. Now what?
So is this patient, so the patient no TPA, not on any blood thinners?
Yeah.
Did you give heparin? Did you give anything else?
As of now, not yet. But the patient did not get TPA. And no, I don't use heparin.
I think on this situation, again, we are trying to enroll a patient in this study, right? Most were used 2B3A agents together with TNK or TPA. I think in this situation, more and more, even before getting what is next step, angioplasty there or stent, I'm thinking about putting this patient on 2B3A, and maybe in some of these cases, you're going to save a stent, because again, we had one that I happened to be in the room when we did. Remember that lady with the PCA? We gave Integralin and saved her. And we're about to stent the vessel. You were about to stent. I was there just like a parrot, commenting, but good at that. Giving opinions for free, but it saved her stent. So I think in some situations we're going to see that 2B3A you're going to give anyway. Might wait 5-10 minutes and see if the vessel reopens or stays open without an implant.
So obviously, as you guys know, we work together. I would like to say, I think like Dr. Hanel, but I'm still learning from him. So I did exactly the same thing you said. As soon as I see this, I started Cangalore drip. It's a blood thinner, works pretty fast. But actually, I started Cangalore drip. I didn't tell you right here. So before I waited, I knew this lesion, it doesn't look good. I started blood thinner Cangalore. and waited, did a run. This is what it looks like. So it did not go away. And cangalore has been in the patient's body. Now what?
Chris, John, anybody?
I'd probably just go up and then another pass. I think probably there's some thrombus there, I'm presuming. It's probably, odds are it's not a dissection. Think about some spasm potentially, but practically just go up again.
Chris, any thought?
I'd probably be thinking more toward like an angioplasty at this point. I think if it's continuing to worsen despite being on a cangular drip, that's probably where I'd be heading.
Anybody else? Does anybody else in the room see anything else disease in this picture?
I was about to point that out, the ACA, right? That's
Yeah.
interesting.
I mean, it's not, I mean, it becomes pertinent, but there's some disease other places, right? So as Dr. Hanel said, yeah, you don't know if this is athero, clots, whatnot, but this patient has ICAT. Doing another pass, I mean, it does, could do that, but there are evidence more passes, can cause problem as well. Dr. Hanel, any idea about just doing another pass or stent it or angioplasty?
I would go for an angioplasty, but again, that's one of those that nobody knows the answer, right? When you look at the paper that we work with Raul and the rescue stenting, the longer you wait, the worse the results, right? So, as you said, there's an indirect hint there that maybe there's underlying after look at the ACA. I just saw this on this picture. I'll be prone to go there in angioplasty, see if I can make a difference with that.
So would you take a balloon angioplasty and see what it looks like? And then what would you do?
I would angioplasty and see what kind of results I got. And again, what type of stent you use here. I probably still would do old school Enterprise. We published this many moons ago using Enterprise as a little better radial force. Probably the only time that we use Enterprise these days is for rescue, and this lesion is an off-label. Enterprise approved for aneurysms, but has a better radial force than Atlas. A 21 catheter, but I think it works really well for this. The curve, I don't like that curve for a wingspan. I don't like that curve for a balloon-mounted stent. So,
thank you. And for everybody in the room, as you know, we don't typically like to put a stent in the brain. We use a stent retriever for acute stroke, but stenting in the brain is not ideal. So yes, I mean, I was thinking what to do. I thought about doing a balloon, but I don't know. I decided, let me see if I can do a balloon mounted stent. So probably should have, in retrospect, just used balloon, like you said, see how it looks after angioplasty, because you see this sharp angle, you have to get these rigid stents through here. This probably was not wise. And the other point is, these are coronary stents. They're not for the brain. And trying to get this to the brain, these are a little bit stiff. However, thankfully, we have great tubes that allow us now really get distal in the brain. So here is the tube that allows me to now navigate the stent with some difficulty all the way through these curves. I'm showing this picture because this is not ideal, right? So the patient, what is the patient doing here in this picture? Moving, right? Because there's a map and then the map is off. So the patient is moving and, well, we could intubate the patient, but remember I told you the patient was fluctuating. You intubate, the blood pressure may drop. So I don't know the answer. Regardless, here I, with the help of this catheter that navigates pretty well, I was able to get this stent finally there. And
Nima,
yes.
Can I ask, John, are you guys general anesthesia or local? What do you guys typically do?
Oh, we almost do all cases under local, and then if there's significant issues like this, we'll probably convert to general. But just based on our resources, we don't have immediate available. We'd be stressing out our anesthetic team quite a bit by asking it for every case. Yeah.
And the other thing is, wingspan obviously would have been make me a little more nervous, but do a balloon exchange wingspan. So all that, you have a wire all the way up here, which can cause problems. So I'm starting to like this balloon mounted stent. Regardless, thankfully the patient did well, and here you can see that now that branch is open. The stent is right here. And obviously he did have a stroke, but he did well. All right. Any questions?
Nice result.
Thank you.
Great case. So you transitioned the patient to,
Yeah, so we start patient on Cangalore, and for everybody in the room, stent for stent. Now this patient has a stent in the blood vessel. We need to put him on dual antiplatelet. We transitioned to Berlenta. So we got a head CT post-op, didn't see any bleeding, so we transitioned to Berlenta and continue the aspirin and Berlenta.
do you have another case, Nim? I can show one here. I think we have 15 minutes.
Yeah, go ahead, show your case.
We killed the break, but we forgot to tell Dr. Shah, so we're trying to see if
No, I did. Dr. Shaw is going to be in 2:30.
Okay, perfect. So we have 15 minutes for one more case. Let's see if I can. Stay there, man. Don't go anywhere. Okay. So you see here, this 64-year-old lady came to us out of a TPA window, many hours, but within 24. So dawn, diffuse 3 type of patient, 64-year-old, an XPS of 7. Again, Amru showed us there that those patients were well represented on the trials. So she had a left side weakness, and you see here, we do John. John is from Calgary, and if you guys know what aspects stand for, Alberta scale. They do CT, CTA multi-phase, and we do CT, CTA multi-phase from collaboration with Calgary and CTP. We've been doing this for 9 years. We never had the heart to change that. We can discuss that, but that's our protocol in all the doors that we help covering. So we have this information. So on the CTA, very interesting, we have this stump on the cervical carotid, and I don't think there is a picture here of, I don't think there's a picture of the intracranial circulation, but there was, to my best recollection, this patient didn't have a intracranial vessel occlusion, but she has an IH of 20 with this CTA. What are you gonna do, Dr. Nima?
Good question. So NIH is high, so I think that is very important. As we discussed earlier, for me, exam dictates what we do. Now, issue here is, like you said, the intracranial vessels are open. So if the NIH is high, could this be a showered emboli? I guess that's one question. Or could you see it as just a perfusion? I think putting everything together, as you said, looking at the perfusion and the imaging, it's probably a perfusion dependent, not a showered emboli. So I would go after and try to open that up.
John?
I'm presuming there's no ipsilateral A1, that it's an isolated hemisphere.
Yes.
Then I'd probably consider that it's an acutely occluded carotid until proven otherwise. Probably go ahead and treat.
Yeah, that's what my thought process is. So I think it's very important, right, guys? There's no large intracranial large vessel occlusion, but the systems are all connected, right? It's just like the sewer system in the city. Again, this is there's no LVO by definition, so the MCA is open, but this patient has a large vessel, has a hypoperfusion. What Nima said, I think we always pay attention to that. Sometimes this patient look really sick from a shower of emboli, but in this case, I thought there was a perfusion deficit with no good collateral circulation. So what I was prepared to do here, I was prepared to do a possible angioplasty. This is one of those things that on the CTA, you see an indirect sign. There's a little bit of calcification. You see it on the plain CT, you see better. That doesn't show well on this picture. Very hard to say if the clot is here. Sometimes you see no contrast all the way up, and this clot can be on the cavernous, can be sitting elsewhere. It's just that there's no penetration of contrast on that vessel. So didn't know that. So what I did, I just brought my balloon guide catheter here and probe that lesion. There was no flow going through that with my catheter injection. I always do that. Some people do that with a microcatheter, because sometimes when you do a forceful injection, right, my mouse is, you do a forceful injection right there, you see contrast penetrate and you keep titrating, keep mapping where this clot is. In this case, the clot was right there. So what I did, I pushed my balloon guide and I did primary aspiration, and surprise, I got a big worm out of that carotid with aspiration from the neck using a balloon guide catheter. So I got this long 10-centimeter clot into the balloon. And then the angiogram right after that show that what you have is a underlying stenosis on that carotid that didn't look that bad, and the vessel intracranial was all open. So there was a big warm clot. If you look at 10 centimeters, basically the whole cervical carotid was clot. So we end up just putting a stent there because there was residual lesion here, and then we stent her.
How comfortable would you be to leave that be and come back later on to
Great question. So what I do for this, John, I like to look at my CT and CT perfusion maps, and we learned and we published this way back before we had all these fancy maps. If my cerebral blood volume is preserved on the CTP, we know that the hemorrhagic conversion. So it's very interesting looking at tendon occlusion. This is not a tendon occlusion, right? This is cervical carotid. If there's a poor perfusion on the cerebral blood volume, or if these patients have already infarct established on the plain CT, I'll be more conservative on that and maybe come back to deal with that in a different date. But on this one, I had a good cerebral blood volume preservation. Very interesting. There are 2 randomized trials ongoing right now for this specific question, right? Cervical carotid occlusion plus intracranial. Again, this is not the case, but I think that you can easily extrapolate to that when to stent in acute, when not to stent in acute. And look like the outcomes are better in patients that you stent up front or in patients that you delay. But again, definitely is an option to just angioplasty and let it be, avoid the 2B3A cangrelor or whatever strategy you use for that. Personally, if I have a good CTP profile and I will have the luxury of still be running CTPs for everybody for sake of protocol, and it helps on the next talk that Nima is going to give on MIVO. I think CTP is golden for those patients. But again, long story short, I thought a stent was the way to go here, but I hear you, and I know some people just angioplasty that. I look at this, it doesn't. If this slide collaborate, doesn't look that bad, right? But if you look at the next picture, you see that there is residual, and you still start seeing thrombus formation here again, and you see here again. That's why I decide not. Another question is, and you see here next that I put a filter wire beyond that. Some people say, why you did that? The patient has a stroke anyway. Again, I think we saved a lot getting that thrombus. I don't want anything flying, so I think to add a filter here on the simple anatomy takes 2 minutes to get the filter there and add protection. We're already doing this with balloon arrest proximally. So
that's what I was going to say. That walrus is nice. So you have the balloon as well.
Yeah. So they just put an EPI beyond that and just stent. But I was worried about a reocclusion.
Very good. Thank you. If you don't have any questions, we can actually move on to my talk, and then Dr. Shaw should be here soon, so we can.
Different has one. And
okay, go ahead.
So I'm curious if this patient was on aspirin or antiplatelets prior to this. Nope. Okay. And then did you, when you place stents like this, are you doing integralin and then loading post? Okay. And I would say, to the talk that we were discussing a couple days ago, is these are the kinds of patients that may present in our emergency room with waxing waning exams, right? We don't know that they've got this underlying disease per se, because we're going to send them out to come to a TIA clinic. But this is why I think there's indication for same-day TIA clinics to really be developed and for discussion around it, because these are the scary patients to send home without follow-up for 24 to 48 hours in transitional spaces.
Absolutely. I'm a big fan of that concept, but the patient needs to get a CTA, head and neck. Some people heart, head and neck, and we're working on that. We didn't have a chance to talk with Dr. Sapati about that today, but if you look at echo and CT for heart, and maybe Nima, you can comment on that. We're trying to get radiologists the same amount of contrast. Instead of starting on the heart, just go a little bit lower and get the heart with the head and neck. Cangrelor, Nima showcased Cangrelor. I'm still, we were first to publish on Cangrelor, but when we did research in non-human primates, integrin has a quote-unquote thrombolytic effect. So it's very interesting. Most we're studying integralin. So I wouldn't be surprised at all that 5 years from now, this patient is going to get a neranotide protective agent on the back of the ambulance. Is going to come to us with a neuroprotective agent. There's neranotide, there's the Hemera, there's Lumosa. All these that are undergoing study that I'm aware, and I'm sure there are many more. This patient is going to come on that. And I wouldn't be surprised at all that even in TICI 2B, 2C3, we're giving a cocktail of something. If you look at chance, right? That the choice or chance? The TPA?
Choice.
Choice. If you look at choice, I'm not sure if TPA is the medication of choice there. I wouldn't be surprised at all that we're doing a little cocktail of something after that to treat the microcirculation. So I think it'd be interesting. I think on this one, we did Cangrelor, but I think for me, it's Cangrelor or Integral in transition to Brilinta. In acute, there's plenty of coronary evidence that we should not be using Plavix. So for me, it's Cangrelor or Integral in transition to aspirin and Brilinta.
That's pretty similar question. So from we hospitalists, we have a patient on the floor or in the emergency room. You have accepted the patient going for cath. What are the do and don'ts for us in order to prepare the patient and make it easier for you? And what you experience, you say, oh no, ER or the hospitalist team should have not done that. So can you tell us about that?
Dr. Nima, do you want to take that one?
Yeah. Thank you for that question. I think, as Dr. Handel says, CTF or knowing the vasculature is very important for me. We just discussed, so if you have a carotid occlusion and IH is 0, if it's acute, patient had symptom, I'll put that patient in ICU. So from the ER standpoint, obviously we do a stroke. We are they're very liberal calling a cold stroke for like TIA as well, because that allows to get the imaging. So from the beginning, I think at least a CTA head and neck is very important. Now, let's say the patient has a large vessel occlusion. Well, if they're symptomatic, we can consider open it up like you just saw, or put them in neuro ICU. I think when and if they have opened up the vessel or not, it is very important for me that when the patient is downgraded from the ICU, that we still have a good communication. And the reason for that is, if patient changes exam and doesn't have any blockages, that could be like lacunar, fluctuating symptoms. Yeah, we still have to attend to that, but probably not much intervention we can offer. But let's say now you have a patient with a carotid occlusion, downgraded, and all of a sudden they're worsened. I think those are the patients that may benefit from some sort of revascularization. So I think that knowledge and that communication is very important.
I add to that, do not treat high blood pressure aggressively. I think if you're going to need TPA, TNK, we do try to lower this under 180, right? That's the number you guys are using. But again, if you're not on the front line giving the TPA or TNK, I would leave the blood pressure alone, because there's a very good chance this patient is auto-regulating, push her blood pressure up, because that's what she's trying to squeeze in blood. So from the frontline, non-stroke neurology perspective, I would say one thing that is a major no for me, and this even we try for intracranial hemorrhage, so we don't have a CAT scan yet, right? We don't know if this is ischemic or hemorrhagic. I think even that, we try to show that treating blood pressure aggressively made a difference. We failed in a couple of big randomized trials. So there's no urge to bring this pressure down, because you can definitely and be careful with the agent that you're going to use when you're dealing with this on TPA patients that we're trying to lower. You don't want to tank the blood pressure. I think that's I would add to that. So blood pressure, just let it run and let the neurologist guide where we're going.
Yeah, usually on the floor, I said CAB 180. I mean, this obviously changes based on patients, but as Dr. Handel said, the blood pressure goal, try to be normal for me, is really in 2 weeks, 4 weeks down the line. No reason, unless the patient actively bleeding or an issue, there's no reason to really bring the blood pressure down.
Thank you. I'm going to introduce our next speaker. If you look at the back of your program, somebody put that nicely, a little graph that from before Dr. Nima. So fastest door to start procedure, we got 2 national awards on this study that was by Medtronic named Stratis. So you see the Baptist numbers in blue, you see the Stratis numbers in light blue, and you see Swift Prime, that is one of the main studies that led to approval of thrombectomy as mainstream. So we're really, really excited that we had these numbers, and then we hired Dr. Nima. This is old news now, 6 years, right, Nima? Completing in July.
27.
Yeah.
So be careful.
I'm not the only one getting old. 6 years, 7 years ago, 3 kids after, but this was just on the first 2 weeks before firstborn. We look at Nima and said, Nima, what can we do better here? So guys, straight out of fellowship becomes a list of 12 items of things that we can do better. And that was for me is very inspiring. Still get the old bean. I'm trying to age well. I keep repeating that to myself. It's so inspired to see somebody new come with new ideas, motivated and committed to make a difference. And that's my youngest partner. Dr. Aikida could not come here. Poor guy's covering call. We just hired Danny Aikida, that is going to be the junior. Nima's going to lose that position July 2024. But for time being, tremendous addition. Energizer bunny of education, visit every single EMS unit that he can get a reach to. So hats off to you, my friend. Mevo is our next frontier. We're collaborating with Mayank and the team in Calgary to push this next frontier. So Nima is going to talk to us about medium-sized vessel, whatever that means, intervention.
Thanks for that warm introduction. As you know, for me, it's a team and the collaboration with my colleagues. So I appreciate that. Could you guys put my slide up? So Dr. Handel gave it up a little bit, but now Ellery and the rest of you guys who know what MEVO is, you cannot answer. But does anybody know what MEVO stands for? So does anybody know what LVO stand for? Have you guys heard of LVO? Large vessel occlusion. Good. So what is MEVO? So if you don't get anything out of this talk, I think MEVO is just become familiar with MEVO is helpful because as you see why, I think this is becoming the next frontier. So if you get anything out of this, just know what MEVO is. All right. So large vessel occlusion. I think a lot of us know what large vessel occlusion is. When we have acute ischemic stroke, we divide it into LVO or non-LVO. And the reason is because obviously the LVO are the one who have worse outcome, right? Because if your blood vessel is larger, they supply larger part of the brain. And those are the ones that the thrombectomy trials have tested. What is the LVO? The end of ICA or terminal part of the ICA, the proximal part of the MCA, M1, and basilar. So MEVO. MEVO stands for medium vessel occlusion. I've been interested in MEVO for probably as long as I started thrombectomy. The question is, what is and how does that patient going to do when they don't have an LVO, they don't have a little stroke somewhere, they don't have a medium-sized occlusion. And it's not that uncommon. 25 to 40% of the ischemic strokes do present as MEVO. So what are MEVOs? M2s, M3s, A2, A3s, PCA. These are the vessels that all the randomized trial that showed benefit of thrombectomy did not include, except for M2, none of them really included any other ones. When you hear of MEVO, since now you know where it is, you divide into two, primary MEVO versus secondary MEVO. Primary MEVO is, well, the patient, same as LVO. How do you get LVO? Well, you have AFib, blood clot goes, depending on the size of the blood clot, it ends somewhere. So that creates an occlusion. Or you can have atherosclerotic disease, shut down the vessel. What is secondary MEVO? Well, when we do thrombectomy, as you know, we have to still access the clot somehow to even suck it out or put the stent there. By doing that, you could cause distal embolism, and that can lead to medium vessel occlusion. What are the challenges? Well, it's hard to say what is M1, what is M2, where does it end? So I think we all should be familiar with the definition as much as we can. So as anybody who works with me knows that I love anatomy. So the MCA is the horizontal segment from the ICA into the bifurcation. So we call that M1 segment. M2 is really when it bifurcates, right? And then M3 is from circulus sulcus to the superficial aspect of the Sylvian fissure. But to differentiate M2 from M3, it's not really, okay, is there more branches bifurcating? No, it's when it exits the Sylvian fissure. And then we have M4, which is more distal arteries. So here's an example, CTA. You have the horizontal segment, that's M1. You have disc going up, that's M2. And then as it exits Sylvian fissure, that's M3. Another picture, M1, M2, and then you can see the M3s depending on where it is in relation to the Sylvian fissure and the insula. And then you have the cortical. The challenge is that it's not always the same, right? So there's many variations of the MCA. So when you hear LVO M1 occlusion, the M1 is not just one vessel. There's a lot of different variation, as you can see here. When we say M2 occlusion, same thing. There's a lot of different variation. For example, look at this. Here's the M1. So horizontal segment is M1, right? Now everybody knows. And when it bifurcates, you have the superior branch and inferior branch. Well, look at the size difference of the superior branch and inferior branch, right? So M2 occlusion on one side can determine worse symptoms depending on which side it is. And then you can see the M3s and M4s. So you can maybe use size definition, medium and distal vessel. If you look at this paper, they actually looked at large vessel. Majority of them are more than 2 millimeter. Still small, right? But they're about 2 millimeter. Small vessels, less than 0.5 millimeter. So I think looking at these pictures and figuring out what intervention to do, looking at the size is helpful. And these are the trials. As Dr. Hanel said, we are thankfully part of SCAPE MEVO soon, and we can enroll in these trials. But if you look at these trials, this is what they use, right? Distal M2, PCA, ACA, but those are really the MEVOs that we're talking about. So let's go to a case. This is a 6-year-old with left-sided weakness, dysarthria, extinction, so ignoring if you touch both sides, and last known well was the night before. So NIH4 presents to the primary stroke center. Obviously, we get a head CT, it looks pretty good. So NIH4, mild symptoms, and that's what we have. So our protocol is acute stroke, you call it cold stroke appropriately. We get a CT, CTA, CTP. This was a CTA. And to be honest, I don't know if I was on call for vascular or not, but when we looked at the CTA, we couldn't really find a clear large vessel occlusion. Maybe there's something there on this side. But regardless, CTA didn't look that impressive. So whoever was on call for vascular neurology said no obvious LVO. Do we have any treatment option for NIH4? Is there anything else you guys want to see? Dr. Hanel, anything else you want to see?
So wake up stroke, right? So out of window. You guys don't like extend protocol, right?
Not much.
So there are 2 papers that you can do based on advanced image MR or RCTP. You can do late TPA. Had this discussion before. For these distal occlusions, I think CTP, Walid Brinjiki, one of the Mayo radiologists, he jokes that he likes to tell his radiology residents that the occlusion is here and vaguely pointing to the vessel that is on that region. And then you look at the CTP, you see. We talked about this a second ago, right? I think CTP shows you that there is a vessel occluded there, even though if you cannot pinpoint on the CTA.
Thank you. Yes, I think the point I was trying to make is, we should be critical of CT perfusion. And for you guys who don't know, relying on CT perfusion for figuring out what's dead, what's not dead, I think we should all be critical of that. But when it comes to this, it helps. I mean, anybody can see those green area, right? So you have 40 ml. And for anybody who's not familiar with CTP, the green tells you the area at risk. And the red, which you don't see any, or pink, tells you the area that's damaged. Not on this side, but the other side. Anyway, so this patient had some weakness and IHF for extinction. And that's what we have. So how far will you go? And what would you do for this patient? Because I told you on the CTA, we couldn't really clear occlusion. So, on the perfusion, there's deficit. So what would you do for this patient? So what is the outcome of MEVO? Well, there actually been studies. There is a cohort that looks at, we think, well, if your distal vessel is occluded, it's not an LVO, so they're probably going to do well. See, Dr. Naval is in the audience. So he could, argue about the data, not best, but we know that 1 out of 4 patients with MEVO does not achieve independency, MRS of 0 to 2. So not every MEVO does well, and only half achieve excellent outcome. Remember, there's a difference between good outcome, right? Obviously, you want a good outcome. They can ambulate, they can take care of themselves. That's more of a ranking of 0 to 2. But if you still have some weakness, some limb, you cannot use your hand, but you can still function. But if you recover close to completely, that would be an excellent outcome. So what treatment option do we have for MEVO? Well, we don't have any randomized trial yet. So as of today, rest of this talk, I'm telling you, I don't have any randomized trial showing that medical management versus any cardiovascular disease is better. But we still have patients who may present with MEVO. So what do we do? Well, it is challenging because as I showed you in that CTA, unlike LVO, it's harder to see. And other question is, does it explain clinical symptoms? If you have an NIH of 20 something and you have a little distal blockage, does that explain the whole exam, or could this be a showered emboli, for example? And then if it's distal, the blood vessel gets smaller, so you still have to access it, get it out. So there could be complication, obviously, and you probably have more to lose because these patients are not your NIHF. Most often, they're not your patients who have nothing to lose. These are the milder symptoms. So those are the challenges. As you heard, I think this is an area where perfusion really helps. We've had conversation among ourselves. When we do a cold stroke, we automatically get CT, CTA, CTP. And I like that because, as I showed you, the green kind of helps. And not to really exclude patients, I think it's helpful to actually include more patients. There have been trials, so these are single-center, multi-centers, but again, not randomized, to look at outcome of MEVO thrombectomy. If you look, majority have only included M2s. There are more trials. But at least the reassuring thing is, look at the rate of hemorrhage. So what do we worry about? We're going through all the blood vessels, we worry about bleeding, perforation. At least based on this trial, we know that, rate of hemorrhage is not that bad. And we're actually part of the study. Dr. Hanel is in the room. He was part of the study. That's his name there. And whoever that guy is next to him was part of the study as well. And we did the multi-center retrospective study. We looked at M3s, any ACA. We included about 286, this was multi-center, patients in this study. And you can see that, so these are medical management versus thrombectomy of medium vessel. The problem with the paper obviously was the medical management, this is not a randomized trial. So the medical management had a lower NIH. Obviously, you selected probably bias by taking more patients for thrombectomy if they had a high NIH. But regardless, this was a study, and you can see the baseline NIH was different between the two groups. the outcome was not statistically different. So in 3 months, based on this, if you did a PCA thrombectomy versus medical management, the 3 months rate of good outcome was not significantly different, but the rate of excellent outcome was in favor of thrombectomy. And remember, the thrombectomy group had higher NIH, and symptomatic hemorrhage was not that bad. So relatively safe. So now that you know this, how far will you go? Well, let's go back to our case. 6-year-old with left-sided weakness, dysarthria, extinction, NIH of 4, came to the hospital. We talked about this, and obviously the patient went to angio since we're talking about thrombectomy. And it's hard to see, but one thing I love about angio is, again, it's a flow study. So when you inject, you can see how the flow is going in the brain. You see there's an area missing. That's that green that was showing on the perfusion right there. And if you wait delay runs, you can see that the dye goes slowly and stops right there. So we just did case discussion, so I'm not gonna go through the techniques too much, but it is a distal vessel. We still have to get there. Here, I did I crossed the lesion. We have good devices, the microcatheter. We inject dye to make sure we're not in a bad area. And then put a stent, retriever, aspirate, get the clot out. And you can see that this little clot, and here's the size. Anybody who works with me knows that I love taking pictures. And the reason for that is, what do I show in presentation? No, it's really nice to show the family or the patient, because the patient's like, I didn't have a stroke. Well, sir, this was your clot that we got out. So yes, you did. Regardless. So there was a blockage opened up right here. But at the end of the day, as you know, it's about the patient, right? This patient went home on day 3. It was embolic stroke, so we put him on Eliquis. NIH of 0. Yes, there were a few strokes, but remember, the disability is what we're trying to avoid. All right, so this is fresh, and nobody knows this except me and Gustavo. Is Gustavo in the room? And Dr. Hanel doesn't even know this. So this is just our data. How many MIVO, Dr. Hanel, do you think we've done since 2017 and 2022?
I have no idea.
Yep. So what I did, this is just basic look back at our data. Because we don't have randomized, right, we have to kind of select. So what do we do? Do we go after this blockage? Do we not? And to be honest, that is a hard decision to make, because like I just said, you have more to lose and you have to be careful. You cannot be a cowboy, say, I'm just going to go up as distal as I can, open up the blockage. So we have, at least from 17 to 22, about 100 patients, 50 of them were primary. So not that many numbers. Now, is this number going to change? Of course, based on the randomized trial. But for now, that's what we have. This patient that we selected, NIH was 12, so these are higher NIH patients. We were able to open up the vessels pretty good, as you can see. And the rate of 90-day MRS of 0 to 2 was about 40%. So not a bad outcome, but this is basically our data. And the risk of hemorrhage, I would argue, is not that bad. We apparently did more first pass stent retriever, 74%, and we did 25% first pass aspiration. And the other thing that I haven't talked about, something you can give blood there, right? You can give intraarterial TPA, but we only did that probably in 2 of these patients. So how about techniques? Well, thankfully, and I know we have vendors, and thank you guys for your support, and we do have great tools to select from. And to be honest, the tools are increasing in such a fast, rapid. I know Chris is here. We used to work together. I mean, there are things that came out over the last year or 2 that that weren't there obviously before. So there are things that are coming out. So we're lucky to have tools. However, like any tools, you have to select the right tool, right? So we have aspiration. So those are the tubes, catheters that navigate very nicely. They can go to the clot. You can remove the clot by just aspirating. I think we're moving toward more aspiration. The reason is less manipulation of the blood vessel, pulling a stent, whatnot. And as we're getting good catheters, if you can just navigate these catheters into the clot and connect it to suction, that really helps, again, you don't have to pass the clot. But we do have retrievers. So these are the stents. You go into the clot, you open it up, hold onto the stent, and you pull it out. So these are the devices. Red 42, I know we're not talking about specific devices because there's a lot of different vendors, but Red 43 is interesting because it is a bigger aspiration catheter that I think can navigate further. And we also have Zoom. So Zoom can navigate as well, aspirate. Now, the length becomes a little challenging, whether or not you can put a microcatheter, microwire, I'm sorry, stent retriever or not, but we have these catheters available. Tiger 13 is interesting. So talking about devices, well, Tiger 13, you can actually get pretty far with a very small microcatheter, like a SL10, which is a very small microcatheter, and open this up. Bottom line, the devices are great and allows us to do what we do. So technology is great. Now, let's go through the case, and I think that's the time. This is a different case, 66-year-old with right leg weakness. Worse the next day. So I'm coming around, and this guy's like, my right leg is not moving. Like, well, that's not good, obviously. Was it moving before? Yes, it's been kind of fluctuating. And for some reason, when we're rounding, usually, Ellery knows, we're like, the patient's worse. I'm like, is it worse because we're rounding, or is it worse that maybe I wasn't really doing anything overnight? I don't know. Regardless, this patient cannot absolutely move the right leg. Anybody knows where obviously we're talking about stroke. Where would be the stroke if you worry about a stroke? Good, who said that? So we do perfusion. Again, I told you these AC perfusion, I think, does help. The green can tell you that there's a chunk of brain that's not getting flow, right? So I took the patient to angio because the patient cannot move the right leg. What does that mean? Is it a disabling condition? Yes. Yes, sir.
Plain CT.
Good. So it was the next day. The plain CT showed some stroke. And that was important. I don't want to make it too complicated technically, but that was a decision I have to make. Is it stroke on the CT explain his paralysis, or is there a perfusion mismatch? And I don't know. At the time, I thought that there is a perfusion, but there was some stroke already on the CT. So I took the patient to angio, and this is a MEVO talk. So, sorry. All right, so you can see that the dye comes up. These are the MCA branches. We're looking at the side right there. I cannot. Okay, so right there, there's a blockage. Now what? What do we do? Here, I did use a stent retriever because, you know, I was like, well, I can get this solved. Probably can use a bigger catheters and bigger stuff. It didn't really work. I ended up actually leaving a stent behind to open up the vessel, multiple passes. I'm like, I'm not going to go after this multiple times. So I did put a stent there. The patient actually did well. And interestingly, the stent that I use it's not supposed to have a lot of force. I was not sure if this is the right decision to make, but follow up and see that there's flow past the stent.
Nima, can you clarify your anesthetic resource here with these kind of cases? Does this differ between MEVO and LVO?
Yeah, no, that's a good question. I think that to try to get to these vessels, you really need a good roadmap, right? You still have to navigate the wires and catheters. So if the patient is moving, if you're going into the M1, typically you can get there, you know, with, cardiology, if you think about it, the coronary, the heart is moving. They don't have a roadmap like we do. But if the patient is moving and you really need to go distal, that is difficult. So I'm glad you brought that up. There was actually a new, I meant to look it up, but there's a new, it was just published in JNIS about anesthesia versus no anesthesia for MEVO. I think that there could be a room for anesthesia. For now, I still do what I do with LVO versus MEVO, minimal sedation. But if the patient is aphasic or really agitated, moving around, yeah, I'm probably going to be more lenient toward intubating him.
Atlas.
Yeah. So again, at the end of the day, we have tools, remained open, and as anybody who works with me or knows me knows, I like walking. And again, at the end of the day, it's not about anything other than patient outcome and patient care. So this patient got better. Could I get better without all this fancy stuff? Maybe, I don't know. But at the end of the day, the patient did well and was able to walk. So that was very important. All right, so in summary, MEVO can lead to disabling outcome. thrombectomy may be of benefit. At least we know technically it's feasible, and thankfully we have good devices. I think selection is going to be the key. I talked about the M2s, M3s, ACAs. We have eloquent part of the brain, right? And we have non-eloquent part of the brain. So I think that's where we have to rely on exam, imaging. So I think selection is going to be harder, but the key. We talk about our door to puncture. Obviously, we like to speed up. You have LVO, door to puncture as fast as you can. When we do our M&M, there was a case, for example, there was a PCA occlusion. Door to puncture was a little delayed. That's okay. Actually, it was my case. I wanted to go see this patient because the patient can only not see from one side. So I wanted to explain to the patient, hey, yeah, we can open up the vessel, but there's risk and whatnot. So bottom line, I think selection, we have to be more careful with MIVOs. And there are ongoing trials that will answer some questions. And at the end, again, it's about patient care, and what we do, we cannot do without our team. We do have a great team, and I'm very lucky. I joined Baptist in 2016, and I was like, well, I'm not sure how long I'm going to stay here, but I really greatly appreciate the team mentality that we have. We cannot do this by ourselves. Dr. Hanno, Dr. Savaggio, my partners, I really like the collaboration. They've been very supportive. We work together very closely. I see Ellery here. She rounds with me and stick with me and take care of our patients greatly, tells them what to do and keep me straight. And I see our rest of our staff here, and Liz is here. So I greatly appreciate everyone and all your hard work for our patients. And with that, that's it. I was gonna, because they put my talk at the end, and I said, well, that's fine because everybody's gonna leave. I was gonna say there's a party afterward, but hang in there. There is a party afterward, but that was Dr. Shaw is gonna have the next time.
There is a party at 6 p.m. Don't miss that. Take a break between after Dr. Shaw's talk. We save the best for the last. 6 p.m. right away in the Abbey. 6. And where is the party? Surf what? Surf Club. Where is that located? Across the street. Okay. It should be a nice view of the ocean in a beautiful afternoon. So come Thursday, my friends. Is Dr. Naval in the room? If not, I'll do the honors.
Any questions? Anybody has any questions?
John, any question about MIVO? Demetrius, any comments?
Yeah, great talk. Thanks. With MIVO, obviously the issues are clinical. The deficits tend to be less pronounced. That brings up the question is whether or not you should do this or not. Technical standpoint, there's aspects of that, although the newer tools are much more effective. But I think the biggest challenge here is that a randomized trial now in our field is very different than it was in 2015, and there is a lot of enthusiasm, motivation, bias towards treatment. And so as we enroll in these randomized trials, I think that's one aspect we need a commitment towards proving this technology rather than just assuming it's going to work. Thanks.
We have Mayank and Mike, they're his partners on our case, that we are in a part of a clinical trial and we treat outside of clinical trial. So that's a problem, right? We did Dawn together. We are not, either you're part of the study or you're not being treated with intervention. So it's a very tricky conversation because if we had time, I was going to go back to Nima's one of his first slides, what he called M2. Please, if you don't, that's my head. Please, that's an M1. Don't name my M2, don't name my M1, M2, because it's a dominant vessel. So I struggle with some of this enrolling M2 patients. With all due respect, it's a disservice, like the same discussion we have with Amru earlier. To enroll a patient based on CTP and call that large core, we publish, Mark publishing called Go Score. So, but again, A3, PCA, those are, I think, we're going to be interested to see, because the other side is, and we're interested to see our numbers, our numbers that you put together with the guys, and I'm sure you're going to publish that. But what is, you talk about MRS 0, 1, 1 in 4, right? What is our MRS 0 and 1 with intervention?
Right, so let me go back.
You show 0 to 2, but it didn't show 0 to 1. So we need to look at that.
I
That'll
think
be
that's a great
interesting.
idea, because we're looking now, we're being more biased, right? We're now trying to get excellent outcome rather than,
Oh, I think we got to compare what is there, right? To have randomized data, say, look, we intervene on this 101. Those are the results. If you compare what's published for a non-intervention, because every time we touch somebody's groin, we think we're very good in what we do, but we are hurting some patients, right? Complications is inherent to procedures. The question is, are we helping more or hurting more? That's why John is saying the clinical trial is important.
thank you.
Thank you, man. Dr. Naval?
So as our last speaker of the day, before the alcohol starts flowing, I would like to invite Dr. Shah. Dr. Shah graduated from GS Medical College in Mumbai. There's two big medical schools in Mumbai, one for the people who are serious about becoming doctors. And that's the one she went to. I went to the other one. You can probably tell. She did her residency in neurology at Baylor. She did a fellowship at Johns Hopkins. And unfortunately, she joined Baptist Medical Center, which makes the rest of us look really bad at what we do. The rest of us neurointensivists anyway, because she is so phenomenal. She's going to tell us about ICH and updates in intracranial hemorrhage, including some recently presented, albeit not yet published, somewhat controversial trial results that we'll talk about. Thank you.
Thank you, Dr. Naval, for that very gracious introduction. Right, so I'm going to thank you for sticking around till the end. I promise I'll try very hard to, keep in time. I'm going to spend the next few minutes talking about updates in the management of ICH. I have no disclosures. We'll jump right into it. We know intracerebral hemorrhage accounts for about 10 to 15% of all strokes, and it is associated with high mortality and poor functional outcomes. Now, classically, injury with ICH is separated into primary injury from the bleed itself that dissects through the brain tissue, leads to high ICP, herniation, and hydrocephalus. This usually occurs within hours to the first few days. The secondary injury follows because of the presence of blood and perihematomal edema, inflammation cascades, effects of breakdown of blood products leads to secondary injury. There have been efforts by researchers to target the hematoma to reduce secondary injury, and one of the approaches is surgical to see if reducing hematoma volume would reduce the subsequent wave of secondary injury. Currently, our surgical options are craniotomy and hematoma evacuation, minimally invasive surgery for hematoma evacuation, decompressive craniectomy with or without hematoma evacuation. Cerebellar ICH is an entity of its own, and then intraventricular hemorrhage is often approached with a placement of an EVD with or without intraventricular thrombolysis. I will quickly review some of the existing data to see where that has brought us. Craniotomy and hematoma evacuation was evaluated in the STITCH trials. The STITCH 1 trial, published in 2005, enrolled about 1,000 patients between early surgery, mainly craniotomy, and medical management. The primary outcome was death and disability, and there was no difference in the primary outcome. But a subgroup analysis showed that there is benefit in superficial clots, which are within a centimeter of the cortex. That led to the STITCH 2 trial, which was published in 2013, about 600 patients. And that trial also did not show any significant difference. So that led to the thought whether a major invasive surgery, such as craniotomy, with dissection of brain tissue is leading to more damage than the hematoma itself. At this time, the indications for surgery have been limited to very large bleeds with significant midline shift, ICP issues, or bleeds that are secondary to an underlying lesion. But the question is, can timely surgery that is less damaging than the hematoma itself show some benefit? And that has led to the evolution of minimally invasive surgery in ICH. As the name suggests, this concept involves making a very small hole in the skull, placement of some device to reach the hematoma, and then some sort of aspiration device to evacuate the hematoma. Thrombolytics can be infused through that access. This was evaluated in the MISTY-3 trial, where a stereotactic hematoma evacuation followed by placement of a catheter in the clot cavity and introduction of alteplase or thrombolytics to dissolve the clot and evacuate the hematoma was compared to medical management in moderate to large ICHs in about 600 patients. There was no difference in the primary outcome, which was a primary endpoint, which was functional outcome, but there was improvement in mortality. On further analysis, on further analysis, it was found that if the end of treatment volume was less than 15 ml, there was benefit in functional outcome. However, that goal was achieved in only about 58% of patients. There have been some meta-analysis trying to evaluate the small observational studies that have been done in this field. The first one looks at neuroendoscopy or minimally invasive surgery, comparing it to craniotomy, and has found good functional outcome, improved mortality, better hematoma evacuation rate, less blood loss, less OR time, less hospital and ICU stay. Some others that have compared minimally invasive surgery to just medical management have also seen improvement in functional outcome and mortality. There are several devices in the market right now that are being evaluated. The BrainPath and the Myriad devices by the Nico Corporation, that is the one on top. The Apollo system, Artemis system, the Aurora Surgiscope, these are all some of the devices that are being evaluated. These are all the ongoing studies with these devices across US and the rest of the world. Most of them are still ongoing, but the ENRICH trial on the top is one that was recently completed in February 2023. Now, the ENRICH trial is early minimally invasive removal of ICH that compares minimally invasive parafascicular surgery to medical management. It involves the use of the BrainPath device, placement of the BrainPath device, which provides access to the clot, the trajectory of which is determined by imaging to cause minimum damage to brain structures. And then the Myriad device, which provides aspiration of the hematoma. This trial, the results of this trial have not been published yet, but they were presented recently at the American Association of Neurological Surgeons last month. Baptist was part of this trial and has enrolled 4 patients. Now, we do not have the results, we do not have the publication of this study, but thanks to Dr. Hanel, we have been able to obtain the slides from the presentation. And thanks to Dr. Gustavo Pradilla as well, who has been gracious enough to share this data with us. The ENRICH trial enrolled 300 patients within 24 hours of last known normal with ICH volumes of 30 to 80 ml and GCS between 5 and 14. The mean time from last known well to surgery was 16 hours. They initially started enrolling patients with deeper bleeds, what they called anterior basic ganglia bleed, and lobar bleeds. But after their pre-specified second interim analysis for futility, they decided to stop enrolling patients with anterior basal ganglia hemorrhages and focused on enriching the trial with lobar bleeds. In the surgical group, they were able to achieve 88% reduction in the clot volume, and the mean end of treatment volume was 15 ml. And they achieved 15 ml or less in about 73% patients. Now, their primary outcome was a utility-weighted MRS. Now, modified Rankin scale, which we all know is an ordinal scale ranging from 0 to 6 to assess disability in patients. The utility-weighted MRS is a newer concept in stroke trials that incorporates not only the researcher's interpretation of patient's disability, but the patient's interpretation of quality of life along with it. So the ordinal scale of the MRS is then converted into a continuous scale with weights assigned to each level of the MRS. And that ranges from 1 to 0, 1 being no disability and 0 severe disability or death. They also, in their statistical planning or in their methods, they had decided that if the mean difference of this utility-weighted MRS score between the two groups is greater than 0, then that would mean that there is a significant difference between the two groups. They, this analysis is also evaluated by the Bayesian inference model of probability, in which, based on prior probability of what we know in this field, we can predict posterior probability of superiority. And they decided a priori that more than 97.5% posterior probability of superiority will determine that the surgical option was better than medical management. These are the results of the trial. In the MRS, if you see the red column, the MRS of 6, which was death or mortality, was not different between the two groups. The mean utility-weighted MRS at 6 months was higher in the surgical group, and the treatment difference was 0.08, with a posterior probability of superiority of 98.1%. When you look at the data between the two different locations, even though they stopped enrolling anterior basal ganglia bleeds, it shows that the treatment, if you only look at the deeper bleeds, the treatment difference in the anterior basal ganglia bleed was negative, which means either no benefit or potentially harm. But the lobar bleeds had a treatment difference of 0.127 and a posterior probability of 99.7%. So the authors concluded that this is the first clinical trial that demonstrated a functional outcome benefit in surgical evacuation for supratentorial ICH patients within 24 hours of last known well. They also demonstrated that minimally invasive surgery is safe, and a substantial amount of clot evacuation can lead to better functional outcome as compared to medical management. And this strong signal comes from the superficial bleeds. Moving on to decompressive craniectomy, this is a trial to keep an eye out on. This is the SWITCH trial, which is a Swiss trial evaluating decompressive craniectomy without hematoma evacuation versus best medical management in supratentorial ICH patients. This study is expected to be completed in 2024. The 2022 American Heart Association, American Stroke Association guidelines for management of ICH provide guidelines or recommendations for surgical treatment in ICH. And obviously, this was released last year and does not incorporate the results of the ENRICH trial. But up until now, minimally invasive surgery was given a class 2A recommendation when compared with the medical management alone to improve mortality. When compared to craniotomy, it was recommended to improve outcomes, and minimally invasive surgery was given a class 2B recommendation. because there is not much certainty about improving functional outcomes when compared to medical management alone. Craniotomy was only, the benefit of craniotomy for functional outcome and mortality was not certain. And it is at this point was thought to be only a life-saving measure. But I expect the guidelines to be updated with results of the trials with the minimally invasive devices. And we hope that, as the trial results come out, we can find some answers and the subset of patients that could benefit with hematoma evacuation. I'll quickly move on to the other topic, which is anticoagulant reversal in ICH. This entity is associated with higher likelihood of hematoma expansion with increased risk of death and poor functional outcome. Now, in 2016, the Neurocritical Care Society released a guideline for reversal of antithrombotic agents in ICH. At that time, they recommended PCC or prothrombin complex concentrates for reversal of warfarin or vitamin K antagonists, idarucizumab or Praxpine for the reversal of direct thrombin inhibitors like dabigatran, and prothrombin complex concentrates for factor Xa inhibitors, and protamine for our heparins. This is some of the data in regards to those agents, but in interest of time, I'm going to move on. At that time, there were some novel antidotes for DOACs that were released. Okay. On the bottom is idarucizumab, which at that time had just been FDA approved for reversal for dabigatran. On the top is aripazine, which we will talk briefly a little bit later. And then the other agent of interest at that time was andexanet, which was at that time not FDA approved. Andexanet alpha is a genetically modified variant of human factor Xa that acts as a decoy, binds to the factor Xa, and then neutralizes the anticoagulant effect. This has been evaluated in healthy volunteer studies who are given a DOAC, given andexanet, and found to have decreased anti-10A activity within minutes. This was then evaluated in the ANNEXA-4 trial, where patients who were on factor Xa inhibitors with major bleeding, when received andexanet, had significant decrease in the factor Xa activity, excellent or good hemostasis at 12 hours, and a 10% thrombotic rate. Based on this data, the FDA provided accelerated approval in May 2018 with a requirement to conduct a randomized controlled trial that will compare andexanet alpha to usual care. That trial is underway, and we'll talk a little bit about that. But with that information, several centers started to use andexanet alpha, while others have been hesitant because of certain issues and concerns. The main one being the cost. It's about 4 times more expensive than prothrombin complex concentrate. The approval is based on a single-arm study. We don't know its hemostatic efficacy as compared to PCCs. There is a rebound of the anti-factor Xa activity in 2 hours after the infusion is completed. And then we don't have data on very sick patients with very large bleeds or those that plan to go for surgery. There is also a very high thrombotic risk. I looked into what we are using currently, which is PCCs in reversal of factor Xa inhibitors. There are several animal and healthy volunteer data that show that it reverses coagulation parameters pretty well. There was a 2019 meta-analysis and systematic review incorporating 10 studies, but they were basically non-randomized single-arm studies, but had a majority of ICH patients that showed that effective hemostasis was achieved in about 69% patients, and the thrombotic event rate was about 4%. Now, PCCs are FDA approved for reversal in vitamin K antagonists in patients with major bleeding, but the use in DOACs is off-label. We are all interested in knowing how andexanet compares to PCC, and there are some meta-analyses that evaluate that question. This is one from 2021 that included 21 studies, and basically found that there isn't a significant difference between the hemostatic efficacy of bleeding, hemostatic efficacy in ICH patients, and mortality between the two groups. But there was a higher thrombotic event in the andexanet group. Another meta-analysis from 2021 with 10 studies also showed essentially not a big difference between the two agents. But as we know, issues with meta-analysis, it is difficult to know how one agent was selected over the other in institutions. Non-randomized single-arm studies were included. That introduces a lot of heterogeneity. It is very difficult to control for baseline factors to be able to compare the two groups. Not all studies report how many patients required surgery. There is also lack of standardized imaging timing. And the thrombosis also was detected without a proper protocol. The timing of events are variable, whether patients had resumed their anticoagulant, whether they received any blood transfusions, are all not available. So we look forward to the ANNEXA-I trial, which is a phase 4 study that is comparing andexanet alpha to usual care in ICH patients on factor Xa inhibitors. The plan is to enroll about 450 patients with ICH volumes of about 60 ml or less. They are going to exclude patients with GCS less than 7 and planned surgery in 12 hours. Their primary outcome is going to be to evaluate effective hemostasis at 12 hours and also look at the effect on the anti-10A activity. This study is expected to complete in July 2024. Baptist is enrolling for this trial, but unfortunately, so far, we have not been able to enroll any patients. The 2022 guideline, AHA and ASA guideline, have given a class 1 recommendation to PCCs in the use of vitamin K antagonist reversal. And a class 2A recommendation, a class recommendation for idarucizumab for dabigatran and andexanet for apixaban or factor Xa inhibitors. And the PCCs have a class 2B recommendation. Now, aripazine, which is also called PER-977 or ciperantag, is touted to be a universal reversal agent that would reverse all DOACs, low molecular weight heparins, unfractionated heparins, or gatroban. It is proposed that it binds to anticoagulants, prevents them from binding to their target sites. There are some animal, preclinical, and healthy volunteer studies. A phase 2 study has also been recently completed, and it is thought to reverse within 10 minutes of a single dose with sustained action for 24 hours. And it also is thought to have no procoagulant effect. It is on fast track by the FDA for development, but it will be years before we will get some clinical data on it. But keep an eye out for that. What else do we look forward to in ICH? Recombinant factor 7A is a procoagulant agent that was evaluated in the FAST trial in 2008, comparing to placebo to reduce hematoma growth. Now, there was no difference in survival or functional outcome, and there were very high thrombotic rates in the factor 7A group, but there was a signal for larger reduction in hematoma volume if this agent was given within 2 hours of symptoms. This agent was also evaluated in the STOP-IT and the SPOTLIGHT trials, based on identifying a spot sign, which is a marker for hematoma expansion, but there was no difference seen in expansion or mortality. However, based on the signal from the FAST trial, the fastest trial is being conducted where recombinant factor 7A will be compared to placebo, and these agents will be given within 2 hours of symptom onset. Plan is to enroll about 800 patients with functional outcome as the primary endpoint, and is expected to complete in January 2028. Other ongoing trials are, restarting anticoagulation in patients with ICH remains an important topic. There are 3 trials ongoing on this regard. The ASPIRE trial that compares apixaban with aspirin in patients who have AFib with ICH. The STATIC trial comparing anticoagulants with antiplatelets to prevent any further ischemic events in ICH patients. And then the A3 ICH trial that will compare using DOACs with left atrial appendage closure with no anticoagulant in AFib patients who had ICH. Statins have been studied for ever and ever, and the data on statins and ICH has been very mixed. They were initially thought to cause some harm. Then there was some signal of benefit. The SATON trial is working on evaluating whether early initiation or continuation of statins versus discontinuation of statins in ICH patients. What does that do to recurrent ICH risk at 24 months? This study is expected to complete in 2026. Cavernous angiomas are a small subset of ICH patients that we see that sometimes have symptomatic hemorrhages. There are studies on diagnostic biomarkers that may help us predict which patients have the propensity to bleed in this condition. And immunomodulation with a variety of agents is being evaluated to see whether functional outcomes can improve in ICH patients. So I am excited about the research that's ongoing in this field and look forward to hopefully some positive trials that would guide us to better take care of these patients. Thank you.
Thank you, Jarna. I'm going to open, I guess, for questions, but I do have one for you. I actually did have access as well to the results of the surgical trials. A quick question: do you think the positive surgical findings are related in ENRICH are related to a novel surgical technique or novel statistical technique?
Always. I think whenever researchers deviate from what we expect to see in research, we wonder whether this is just a play of statistics to, find a positive result. But when you look back at Bayesian inferences of a probability, this approach to statistics is actually really old. It was thought to be very complicated and hence not neglected for all these years. But with newer technology and newer programming, this type of statistical approach is coming back in fashion. Now, as much as I can understand why this was used, it looks like this approach provides a lot of flexibility in your sample size and how you want to proceed with your enrollment. It is based on prior data that is available that gives you a prior probability to be able to predict a posterior probability. But it is, I think at this time, difficult without looking at the entire data to know whether this was just a play of statistics or truly there was benefit in using this approach.
So my concern, Jarna, is that it adds subjectivity to what should be an objective metric, right? So I remember back in the day when they had a study called the INTERACT-2 trial where you're looking at blood pressure goal 140 versus 180. And when that study started, they were doing dichotomized modified Rankin, like goal of 0 to 2 versus 3 to 6. And they realized through the interim analysis, they couldn't meet statistical significance. So they changed it to what's called the ordinal scale or modified Rankin shift. Changes from 3 to 2, 2 to 1, like how much did the whole scale shift? And then they found statistical significance. And that was one of the criticisms of the study. Like they got a P of 0.04 because arbitrarily 0.05 is the number you want to hit. You want to be less than that. This seems to be an extension of that. Now, if you go back to INTERACT-2, if you actually use this utility weighted modified Rankin scale, then your p-value would have been less than 0.01. So just for the audience, utility weighted MRS uses the modified Rankin scale, but it also uses the patient's subjective sense of how they feel after a procedure. If you were to use utility weighted modified Rankin for, let's say, an 80-year-old who had a hemicrania and said, how do you feel? I feel good. Are we going to use that And some people say, well, it should be used because shouldn't be patient-centric? Shouldn't the outcomes be patient-centric? But at that rate, a bunch of clinical trials we've done in the past that were negative using objective data would all turn positive using subjective data. And actually, if you look at the tables and the outcomes overall for the 300 patients, and you plug in the numbers into a statistical analysis, your p-value actually is 0.13. So if we had used regular modified Rankin, whether it's dichotomized or ordinal shift, like you've used for every other hemorrhage trial that has been negative, and that's been a frustration, right? That no surgical intervention has been shown to improve outcomes. If you use the classic modified Rankin, your p-value is not statistically significant. So what you've done is you've added a different way of looking at the same things. It's like widening the goalposts a little bit and saying, okay, go ahead, you can't shoot a goal with a regular sort of, distance, so let's give you a wider goalpost. So I don't know if it's superior. But anyway, go ahead.
That is,
On that,
Yes.
because I don't disagree with you, but we knew, again, we all know patient going downhill with intracranial hemorrhage, we know surgery helps. This is non-study, personal observation from a neurosurgeon, from a neurology, critical care physician, nurse. We see a patient herniating, you take the hematoma out, we're helping this patient. We never manage, and this is not science, this is anecdotal, personal observation from a physician. All of us will see that. We know we fail miserably multiple times, one after another in clinical trials to identify which patient population benefits from that. I cannot tell you that I'm happy to see the massage, statistical massage. I don't know the part that I didn't have a chance to go back to the protocol and read the original protocol. I always like to say, was this pre-specified or not? Because if it was pre-specified, it's different. If it was not pre-specified, then I think it's wide in the goalpost. Gustavo is a dear friend. I think they did a very good job. I think that's the best that we have. On our perception, and I think we share this a lot, I'm not seeing us changing much our management, maybe elsewhere. I don't see us being more aggressive to go take a hematoma out. I don't know. I think it remains to be seen because of this. I think maybe the new stitch is going to show something, but I always have to be, I want to see the paper. Was this pre-specified or not?
so I was going to say the same thing. Looking at the methods paper, this was the approach they planned for. They had pre-specified their cutoffs for the posterior probability of superiority. So it does not look like they analyzed the data and then decided to go from what they call frequentist approach of probability, which is our usual p-values and things like that, to this approach after getting the data. This was pre-specified in the methods paper to approach it like this. The one other thing is, what I'm reading is the use of the utility-weighted MRS helps you to use pretty much half the sample size. And that is something, if it is validated to have equivalent statistical efficiency to an MRS, then if it helps you to enroll lesser patients, then you probably, might want to use it. But this is all specified a priori.
But you're using half the number of patients, so you have to enroll half because you've now put subjectivity in there. Like I said, then why don't we go back and look at all those trials done in the past and see what the results would be hypothetically, right? I think you're just adding a statistical flaw. Like you've lost, maybe it's a great idea to take out those lobar hemorrhages. I don't know. I'm not criticizing the technique. The technique may be great.
Basal ganglia. Take out the basal ganglia.
Oh, in this case, though, I would have a problem with, if anything, if, speaking to, does this really change our practice? I think we're actually a very aggressive neurosurgical center. You see a big lobar hemorrhage, you know where they're going to go. Actually, the surgeons are aggressive in taking it out, assuming they don't have a poor baseline modified Rankin. But this study suggests that the basal ganglia hemorrhages, actually, there was no benefit, despite the addition of the utility weighted scale. So I wonder if those basal ganglia hemorrhages that we used to go after upfront, now we're going to be like, no, despite the statistical massage, they didn't actually see any difference.
I'm going to rephrase that on your behalf. The surgeons are aggressive in taking out the hemorrhage because they are pushed really hard, but the great critical care physicians are behind that and deal with these patients with large hemorrhage and perilesional edema and so forth and so on. I'll tell you that, put myself next to the two critical cares that are not here, they cannot defend themselves. So I'm going to speak on their behalf. You know what I'm talking about. If you have a patient with a 70 cc basal ganglia hemorrhage with Mohammed on call, till the hematoma is not out, you're not sleeping. So no. And honestly, I think that makes a difference. Probably not on the modified ranking score, but length of stay in the ICU, how many days this patient is going to be intubated, how long we're going to be able to win his hypertonic. And that's, I think, a point that I was hoping they were going to make with this, because we fail miserably. And I still knock myself on the head. If you look at thrombectomy, is 1 in 3. And we knew that in 2001. Again, when I came to Buffalo, I saw Nick Hopkins fishing a clot out. That patient is doing well. Again, we do that on the heart. It took us 14 years sacrificing human beings, human lives, somebody mom, somebody dad. It took us 14 years because we randomized patients the wrong way. So this here, I don't know, the impact is not as much, but I think we're looking at the wrong end point. And I'm looking forward to the publication, because maybe it's length of stay, maybe it's days intubated, maybe. So all this that has a cost for the society. And at the end of the day, these patients do a little bit better, that's good. But I agree with you. I would love to have seen this in a P 0.00001 for lobar hemorrhages. They'll be way cleaner. Now we're going to have to justify this again, do another study, and try again. But I'll stop.
The other thing is, I think this is a glorified post hoc analysis, right? So, how do our regular trials go? 300 patients, you enroll your patients, then you don't reach statistical significance. You find a subset, like you were talking about, what is the FAST trial? They're going fastest. That's crazy to me, because there's actually higher mortality in the activated factor 7 group. But nevertheless, you do post hoc analysis, you find that subset population where you actually did benefit them. Then you say, even though it was a failed study, let's only study what we found on post hoc analysis. And then that's a new paper or a new study. Over here, what they did is, with this adaptive nature, is you went with basal ganglia and cortical, found no benefit in basal ganglia, then went all lobar. Now the numbers are skewed significantly in favor of lobar. My fear is, now, if despite all the limitations, if, as Dr. Hanel says, the study comes out, we find benefit, that's great. But my big fear is, what happens is then you go back and generalize. Even though you adapted your trial to show that, because you thought lobar hemorrhages were going to be benefited, people are going to go back and say, wait, it's a positive surgical trial. So now lobar is fair game, basal ganglia is fair game. Even thalamus, there wasn't included in the study because they saw, based on the preliminary data, that thalamic hemorrhages are not benefited. That's pure fair game as well. Before you know it, it's like surgery is the new treatment option. And I would love for it to be, because we've been frustrated for, 30, 40 years with no surgical intervention that makes a difference. But you wouldn't want to extrapolate lobar hemorrhage data to basal ganglia and thalamic data. And people have to be careful with that, because sometimes you read the headlines, you don't read the actual paper.
So Dr. Naval, just to summarize, and Dr. Shah, since you're the expert on the topic here, how do you reconcile that? The trial is positive, but have all the caveats that you mentioned. Patients coming, basal ganglia, 70 cc's hemorrhage, a 49-year-old guy, hypertensive, plegic and aphasic. That's one. I can give you more data, more information if you need to decide. Or 49-year-old with a parietal hemorrhage, 80 cc's. So are you inclined to offer any of these patients surgery, or no, I don't believe this, there's no benefit in the surgery, I'm just gonna, patient's not herniated, has a big hemorrhage, because if patient's herniated, the decision is easy, I think. So how do you reconcile that, Niraj and Jarna?
I think at the data on the deeper hemorrhages, looking at the Stitch trial, which one especially, I think the basal ganglia hemorrhages will have to be managed medically.
49.
But we have not seen any mortality or functional outcome benefit.
Troy would tell me he's 49. You're not going to do anything.
It's worth a discussion, but I think that, again, as the signal for deeper hemorrhages is not good, I think that they can be left alone unless herniating or ICP issues or significant midline shift, and that is a conversation to be had. But the lobar hemorrhages, we can start considering them. There is signal from the Stitch 2 trial for mortality benefit if they are superficial. And then this trial that also shows some degree of benefit with minimally invasive. I mean, the surgical approaches are also different. So minimally invasive surgery in the lobar hemorrhages, I would want you to consider that more strongly.
Love that. That's a sign. And the beauty for me is we have a great relationship, a phenomenal team of neurocritical care, neurologists and neurosurgeons that we talk eye to eye. We see these patients together. So the discussion here is what is best for this patient. And fortunately, unfortunately, everybody that is a practitioner knows we don't know all the answers. So this exchange, I think, is the patient benefits from that when there's no clear-cut answer. Dr. Naval, on the basal ganglia 7 cc's, we're going to do statins. What are you going to do for this guy?
Yeah, statins, right. I think the one benefit we have in these patients is the benefit of time, right? So you can see how things evolve. I think clearly someone who's got a 70 cc hemorrhage, most likely you're going to start seeing more mass effect, a little bit of shift, a slight change in the exam. And that's the point at which you jump. I think we always talk about all these surgical trials are not don't do surgery. It is early conservative management versus early surgical management before you see a deterioration from the mass effect. If you think that exam is amplegic on one side and that matches your basal ganglia hemorrhage, that's fine. But if you're sleepy and there's something else that you think there's mass effect, then you go in. Then that's not, that doesn't fall under your inclusion criteria here because you think the hemorrhage is causing enough mass effect to cause neurological deterioration. The GCS is less than 12. All of them should go to the OR then. But this is more of a, well, I see it and, you know, it looks like a stroke, but it's a hemorrhage. You go after it just because you see something on the scan. I'd treat the patient, not the scan would be my preference.
I think we're all on the same page. I have one for you, Jarn, and I think we have some people here that are going to help us jump on this discussion. We always have this Andexanet versus Kcentra. For DOACs, as you said, is Kcentra is off-label. So I have a question about the cost, because my recollection that the cost today after Astra, I don't know who bought who, but there was a series of acquisitions there, and the price, thankfully, for the sake of our patients and system, the price dropped. And I think there's some newer data that I know, Jason, I know we are enrolling on one of the Andexa studies. I don't know if you want to comment on that, and we have some slides to share here just for, we're planning this for the debate yesterday. So we talked too much, we had to cut the debate. So I think we have to give an opportunity to rebate on that. And
Yes.
you have the last word, Jarn.
Yeah, so Jason Day here. I'll briefly discuss the Annexa I trial, the comparing against usual care. Usual care could be a brain hemorrhage that you wouldn't treat, a brain hemorrhage that you give other blood products randomized to Andexanet. One of the problems why we haven't enrolled is because, believe it or not, factor Xa inhibitors are actually kind of safe. I know they cause bleeds, but I've been going through our local hemorrhages admitted to the ICU. I'd say less than 5 a month are on Xa inhibitors. Some of them are on warfarin. There's a couple of months, maybe 6 weeks time frame where there's nobody with the hemorrhage were on a Xa inhibitor. Also, you have to enroll them within 6 hours of last known well for the trial. Many of these people wake up and they don't know. Have to have taken your Xa inhibitor within 15 hours of last arrival or last known well. You have to enroll them within 2 hours of the head CT that found the blood. And since there isn't head-to-head data that says Andexanet is standard of care, it's hard to have someone sitting at a remote hospital and say, let's transfer them here, hope they get here within 6 hours of last known well, and then randomize them when they could have been treated with something. But that being said, if the trial was to show that the mortality is better and the efficacy is similar or better, it's not as expensive as they once said. And a lot of these feeding hospitals that are under different jurisdictions, if you will, they will get complete reimbursement. So the commercial drug could be expanded to all of our campuses without any adverse cost to our health system. But I'll leave that. So I'll probably hand that over to the finance.
For full disclosure, my name is Florence Carranza with AstraZeneca. So wanted to really clarify, and I think Dr. Shaw, what you did was really great, the data up to now, and some of the studies include the previous pricing, and you're totally right on. This product was initially developed by Portola. Portola was purchased by Alexion, and then a year ago, it was purchased by AstraZeneca. So the pricing in the studies is correct. It was very high. And I think that's one of the reasons why it was cost prohibitive to have it in institutions such as yourself. So there was high demand, but cost was really restrictive. So one of the things that AstraZeneca did is ask institutions like yourself, what can we do to really help have health equity access throughout the systems, access in those community accounts, even freestanding EDs, and it was lower the cost. So that's the question that's always said, well, lower the price. Very few times do you get a response from a company that says, we are going to do it. And not only did AstraZeneca lowered it 55%. So that would be the equivalent to going to a biosimilar product. So you see AstraZeneca is fully in on helping access at all institutions, whether freestanding or small community hospital independent. The 55% reduction makes a big price differential. So it closes the gap.
So Florence, what's the difference between the cost for Dr. Naval? What's the difference of cost from PCC, Kcentra versus Andaxa today? If we're going to use Andaxa versus what's
so
the
you
cost?
have 340B pricing as well within the institution as well.
Sorry,
that is beyond what you need to.
340B?
It's for disproportionate share hospitals.
But again, dollar amount for
dollar.
Baptist accountant looking at if I choose drug A or drug B.
So I'll give you a range of it's a couple $1,000 that you're going to be seeing versus, double digits, or I mean, 10,000 plus or 15,000 plus dollar difference. It's a couple $1,000 difference from what it was in differential. So is it at the same level? May not be. If you are using a 340B price, which you may not know about that, right? The pharmacy would know, it lowers and it's much closer to in range.
But which dose you're talking about in Andaxa?
85% of the patients are going to be low dose. So it's going to be within that range for the low dose. Based on how you're dosing, of course, Kcentra, it's going to be differential there. So the low dose, 85% of your patients are only going to be a couple $1,000s off from per patient.
And one last one, because I know he is itching to talk, she's itching to talk, and everybody's itching to drink. I'm kidding, guys. If you don't like beer, that's okay. You mentioned there's some newer data comparing if you can in 2 minutes before I let Naval, he cannot wait to talk. I know him really well.
No, we appreciate it. And Amy Levesque is medical science liaison. I'll turn it over to her because we do have additional studies and you referenced some of them and she can share more information on that.
Hi, everybody. So with respect to direct comparative evidence, so everyone is looking for a randomized control trial, which Dr. Day mentioned is currently ongoing. As sort of a bridge over these last couple of years, as a company, we've turned to real world evidence to try and bridge the gap from our clinical trials to, yes?
So that's for Dr. Naval. There's no direct trial comparing Andaxa with Kcentra because Kcentra is not on-label use for DOACs. So the lovely system that we have does not allow you to do a trial, and we suffer that in other fields of medicine, not only intracranial hemorrhage. You cannot do an off-label because that's what the system pushes. The trial that everybody wants to see is direct head-to-head Mike Tyson versus Evander Holyfield, not Mike Tyson against Brazilian Maguila, because that's not fair. So with that said, so real world evidence, there's no Mike Tyson Holyfield because Holyfield, that's Kcentra, is not FDA approved for this. So Again, this is on us as practitioners. We have other institutions that are not FDA, that are not AstraZeneca, that could organize that study, but this is not there. So just want to, because that's the question that he has for you, and I think that's a very fair question.
Yeah, absolutely. And so the data that we have that's real world evidence is really an indirect comparative analysis, looking at kind of really robust, larger, much larger scale numbers of patients than these small plethora of 30, 40, 50 patient randomized observational studies that are done retrospectively. And then in general, most of them are looking at in-hospital mortality, 30-day mortality, hemostatic efficacy, as well as hematoma expansion, all of which are shown to be statistically significantly different in favor of Indexanet compared to 4-factor PCCs or usual care, depending on the particular analysis. There are about 6 of them that we can certainly go into, but I'm keeping you from drinks. And then in terms of safety, there's also a couple of analyses that also look at VT rates compared to the different populations and are showing no significant difference. That's kind of a very high level overview of some of the data that exists. If you like, I'm happy to run through it.
Can you show one of the 6 slides?
Sure.
What's your favorite one?
My favorite. And I that perhaps may be pretty relevant is this one that actually comes from the VA. So this was an analysis that looked at the US VA system. We looked at patients who were admitted for life-threatening major bleeding, all types of life-threatening major bleeding, and were treated with a factor 10A inhibitor. We looked at patients who received Indexanet alpha versus 4-factor PCCs. And we looked at in-hospital mortality as well as 30-day mortality. You can see here in the graph to the left, we're looking at those results. And so there's a statistically significant reduction in both in-hospital and 30-day mortality in those treated with Indexanet versus 4-factor PCCs. Off to the right, this analysis also started to look at things beyond just does the patient live or do they die, but actually looking at kind of healthcare use or resource utilization. So do the patients require mechanical ventilation? Are they in the hospital? What's their hospital length of stay, their ICU length of stay? And while none of those are statistically significant in this analysis, there does appear to be a numeric difference as well. And so I suppose this is one of my favorite ones, just because it is our US VA system, but also kind of pulls in some of the additional things to kind of consider, especially given that cost historically has been such a barrier. When you start kind of looking at these resource kind of metrics, there may be some offset.
Awesome. Thank you, guys. Not published yet, right? I see this is presented, so it'd be nice when we have that paper.
This particular one is not in manuscript yet.
So we can incorporate. Dr. Naval, one last comment, and then Dr. Shaw. Sorry, we hijacked your presentation. It is spark discussion. I think it's important. I struggle and we discuss. I have they decide if we're going to use K-Central and Dex, but I always ask the guys, so look, we have a drug that is approved direct for this. I'm taking this patient to the OR. Why we're using agent A versus B? I don't have a educated opinion. I think they both work. They'll be nice to see somebody doing a head-to-head independent study on that. Niraj?
What were the baseline demographics of the patients here?
Yeah, so these patients were in their 70s, 80s was kind of the median or mean.
GCS and ICH volumes
Yeah, so
comparable?
we do not have that level of detail in this because again, it is retrospective. So it is.
No, but that part is the most necessary one, right? So I'm going to tell you one study that was done, or paper that was published. I shouldn't say study because study gives it too much scientific value. Came out of Harvard, 29 patients, 18 patients got Indexa, 11 got Kcentra.
Yep.
That study suggested lower mortality, with Indexanet. But then you go and read the study, and you see the baseline demographics, the mean GCS, which is everybody's GCS who got Indexanet was 15. The mean GCS for patients who got Kcentra was 10. So are we going to say that their outcomes were related to GCS, which is probably the number one factor along with ICH volume in terms of determining your outcome? Or was it truly the hemostatic agent that was used? The problem you run into, I think, with Indexanet is how stringent those studies were upfront, right? You said GCS less than 7, you cannot enroll. ICH volume less greater than 60 cc's, you cannot enroll. Patients who are going to require emergent surgery, most likely in the next 12 hours, you cannot enroll, which are the sickest of your patients. And then you had a mortality of 14%. You had a 14% mortality despite the fact that you didn't have a low GCS, didn't have a big hemorrhage, and weren't going for surgery in the next 12 hours. I'm like, why did 14% die? Like, that's actually a shockingly high number for me. It's like, I see dead people when I give Indexa, and I feel like I'm the kid from Sixth Sense. So just trying to figure out, I think in all of these things, you have to be able to have a comparable baseline demographic. And I think that's been one of the issues that's in the study with Indexanet. It was a study specifically designed to show hemostatic efficacy, right? And then you showed that it corrected anti-10A levels, did so only for 2 hours. There was no correlation between those anti-10A level correction and hemostatic efficacy. That was never shown. Maybe there weren't enough patients who expanded the hematoma, but that was never shown. So the approval that was received for the use of Indexanet was basically the expedited, accelerated approval based on a surrogate marker. We don't know if that surrogate marker of anti-10A level means anything. Like where I come from and the way I've practiced for over 20 years, you treat the patient, not the number. I don't know if that number is meaningful. If that number was meaningful, why is it that activated factor 7 is not used routinely for patients that have ICH? It's a hemostatic agent, fixes numbers, but does it really treat the underlying problem? Does the risk outweigh the benefit? Consistently across trials, and we're talking about, and as Dr. Shah presented, 18 studies or 18 observations looking at patients who got PCC. On an average, consistently, whether you look at UPRATE or any other study, it's been 3 to 4%. With Indexanet, it's usually been 10 to 11%. And the question is why? And again, sometimes the response I'm given is, well, that is what you would expect when you take away a blood thinner, because they got reversal for the use of a blood thinner. You took the blood thinner away, yeah, they're going to have clots. That's not because of the agent that is being used or the Indexanet. That's because of the natural process, the natural history, if you will. But the natural history based on the case central study seems to suggest 3%. So really the evidence we look at when Dr. Shah, myself, we make our decisions is right now, we know there's a mechanism of action for both. There's a stronger mechanism of action, admittedly, for Indexanet, because it works on anti-10A and it helps with thrombin generation. PCC only works on thrombin generation and is non-specific. So we have mechanisms. We have no proven benefit to either. We don't know if it's better than giving the patient a sip of water. Now you have to look at the risk-benefit ratio. And from what it seems like, based on the data that's out there, published, not just presented, the risk is 3 times higher for a DVT, PE, MI with Indexanet compared to Kcentra. So when we weigh the risk and the benefit, if the benefit is unclear, if the risk is 3-fold higher with one agent, independent of the cost, and we're looking at cost too, but independent of the cost, it seems like right now at this minute seems to favor the alternative. I hope that Indexanet is the specific treatment or the antidote, but I just don't see the evidence for it.
So you raise a really great point with respect to the thrombotic events and the differences. And I think the primary difference between those numbers that you see are that you're comparing a randomized, not a randomized, but a clinical trial, and the fact that in Anexa-4, those events are actually looked for and rigorously looked for that 30-day periods using a case reporting form, versus in all of these PCC studies, which are all very retrospective. You're just looking back at the history and the data that you have in like your EMR. And so you're not actively, following up with those patients, on a prospective basis for that 30-day period. And so retrospectively, you may find less events because you're not looking for them and you're not following up with those patients versus in a clinical trial where you are.
Well, that's not entirely true. So if you look at the Indexanet study, initially when the first third of it came out, when you had first applied for getting accelerated approval. At that time, you're right, you were looking for those events. The rates of DVTs or Ps at that time was 18%. It dropped to 10% because for the second 2/3 of the study, it was then decided we're only going to look for symptomatic DVTs or PEs. So in the second 2/3 of that study of 350 odd patients, you were only waiting for symptoms. You weren't looking on every patient for DVTs and PEs. And again, as far as PCCs, that they've not looked at it. So there was a consortium of 26 stroke centers in this country, 23 of which are comprehensive stroke centers. They published data on 663 patients that got Kcentra. 663 for safety analysis, the number came out to be 3.8%. 433 for efficacy analysis, 82% good hemostasis, which matches the previous Anexa trials. So right now, like I said, based on the best available evidence, which is weak, you're seeing equal efficacy and a higher risk.
So, okay.
I'll give you 30 seconds and we're not going to solve this battle today. This guy is really, really strong on his positions. It's hard to make him move. Trust me. Very good points, right? I think the direct answer is a head-to-head comparison. I think till that doesn't come, you have a very good point too. Any retrospective study we know is under assessing the problem. Do you want to say any last 20 seconds? No? Thank you. Dr. Shaw, any final comments?
Say the same thing that, we're not seeing, at least so far in the meta-analysis, any benefit of Andexanet versus the PCC that we are all used to using, and the thrombotic risk does worry me. So until we get the results of the Anexa I trial, I don't think we're going to change our practice.
Thank you, guys. Phenomenal. Thank you, Dr. Shah, for finishing in a high-level discussion. I'm going to wrap it up, guys. Our nurses that are still here, anybody need to return your CME, your evaluation forms? Your feedback is really important. We'll not do it again. Can you put that back to April 10th? Oh, Rafa, I don't want to miss that either. April 10 to 12, 2024. If God permit, we're still alive and doing well, we'll be here. I'm very optimistic today. I cannot say enough thank you. I see a lot of you guys still here in the room. It's not possible to run an event like this in a place like this at an affordable CME. When I go around and advertise, this is the most affordable CME in the country for the level of the CME that is provided. And this is only possible because of our Baptist administration that supports this and our industry partners. For those of you guys that are still here, thank you very much. We're going to hit on you again next year. You got to help us more because we want to do this better and bigger. So get ready. To everybody that has been here and help organize this, I'm going to be unfair, but I'm going to mention some names. Young Samurai here, Abby. Where did he go? Team is right there. Wendy, our group of nurse practitioners from the ICU that organized the first 2 days. I think Tuesday was a very successful day, and the other 3 days here. I'm honored to be part of this team, and it's a phenomenal 3-4 days of camaraderie. And we'll celebrate 6 p.m. at the Surf Club patio. Just across the street, there will be signs with drinks and some finger food, drinks for Dr. Naval, food for the rest. And at last but not least, the last raffle. Excited to get the, and the Oscar goes to. I cannot read, man. I don't have my glasses. Embarrassing.
Eva Lim.
If you're not here, does it count? What are the rules?
Gotta be here.
I think you have to be here, right? Sorry. You snooze. Here.
Stephen Cook. Stephen Cook.
Yeah. Thank you, guys. See you soon.